come to collect you for your surgery, is that okay?
Right.
In the UK, some 3 million major operations are carried out every year.
Nice big deep breath. We'll look after you, don't worry.
Only the country's top surgeons are skilled enough to take on the most critical cases.
Cameron, you all right?
Just take a couple of deep breaths.
If you're going to make a hole in someone, you better be sure of what you're going to do.
Should we go for it? Right.
They're using pioneering techniques to treat conditions that used to kill.
A few years ago, these operations were felt to be too big or too dangerous.
But pushing the boundaries of modern medicine comes with great risk.
Just keep quiet for a second, please. If I move the blade too much, she's going to wake up unable to breathe.
Life is precious. It can vanish in a heartbeat.
Whoa!
You need to keep your head.
Hold this. The heart is empty. We haven't got any volume at the top.
If you panic, the patient can bleed to death.
The surgeons bear the ultimate responsibility.
I need it ASAP. I can't wait for this.
I'm not infallible.
Failure is absolutely possible. We are a team, but there's one person's name at the top of the bed.
Bloody hell.
This is what really happens behind the closed doors of their operating theatres.
This is a battle, us versus the Grim Reaper. And we're not going to lose.
The Queen Elizabeth, Birmingham, one of the UK's busiest hospitals.
Ready, steady, slide. Better.
Many of its 140 surgeons are leaders in their field, passing their skills on to the next generation of doctors.
Okay, so come and pop some gloves on. Right, so feel how this is very firm. We're going to press that now.
And pioneering and perfecting some of the rarest and most challenging operations available on the NHS. Ewan Griffiths specialises in complex surgery on the upper part of the digestive system.
So in operations that are complex, you need a specialist rather than a generalist who's a jack of all trades. It's not just what I want or the patient wants, it's what they need, really.
Today, Ewan is performing one of the most difficult procedures in his field, an esophagectomy, where the esophagus, the 25-centimetre tube that carries food and liquid into the digestive system, is removed and replaced with the stomach.
Reconstructing the esophagus is pretty challenging, actually. It's difficult surgery, and it's surgery that can go wrong.
The left, press the left.
Ewan's patient is 44-year-old mother of 3, Anmarie. When Anmarie was just 18 months old, a sibling accidentally gave her a bottle containing bleach, which she drank. Her esophagus was so badly scarred, it was severely narrowed. Ever since, she's had great difficulty swallowing when she eats.
Living with this condition is not like living the normal life. You've always got to watch what you're eating. And like sometimes I can eat and I get stuck. So like if I go out with my family, I'll just go out and I'll have like probably have a drink. I won't eat no food.
Anmarie has had to come to hospital up to 7 times a year to have her esophagus stretched so she can swallow. Each time, a balloon has to be inserted in her esophagus and then inflated.
She'd have a short anaesthetic. She often needed the balloon to be blown up twice to allow the esophagus to stretch and allow the passage of food to go through. I think in Anne-Marie's mind, she's completely fed up of needing to come into hospital every 6 to 8 weeks with the risk of a general anaesthetic. So I think she's quite rightly decided that enough's enough.
Do you have any allergies?
No. Sister Marie, she's very, like, quiet, you know what I mean? And I think she holds a lot in. All my family now is basically, they've all gone to, like, to get prayers and all that said for her. So we believe in the help of God, she will come out of it anyway and she'll be okay.
In the case of esophagectomy, we can cause all sorts of complications. And although the operation is as safe as it's ever been, some patients don't make it out of hospital after this sort of major surgery.
Anmarie wants to have this risky operation so she can eat more normally and not have to visit hospital so frequently.
I'd be able to do things I've never done before. Like go out and have a meal with other people. I've never done that.
In her operation, Anmarie's esophagus will be separated from the tissue and blood vessels that surround it in her chest and neck. Once free, it will be cut at the top and bottom and removed. Then her stomach, which will still be able to digest food, will be pulled up through her chest and attached at the top, creating a new esophagus.
I think it'll always be a slightly nervous operation for me. I want to make sure that it's done to the best of my ability. Morning. Hi there. How are you doing today? I think I can deal with most situations that come up, but it's dangerous territory. So I don't quite know how long the operation's going to last. I mean, it could be as early as sort of 6 or 7 hours, or it could take 8 or even 10 hours if we're unlucky. Okay. Are you happy that I phone your sister later?
Yeah.
When we're finished?
Fine, yeah.
All right.
Thank you.
Hello. Thank you all. Are you ready to go down?
Yeah.
Yeah.
Cool. You can only really go as far as reception.
Yeah. I will love her as a sister, but then also I love her like as a best friend.
My biggest worry about the operation that I might never wake up again.
Marie! Maria! Hang on, Mary, please.
Right, I'll see you, sir.
Right. We're just praying with the help of God she'll be all right when she comes out in a few months. I know it'll take her a few months, but at least she'll be over all this. I think she'll be a completely different girl, I think.
Anaesthetist Jeremy Marwick is preparing for Anmarie's operation in Theatre 11.
Good. Right. Let's do it. It's always a worry for us doing things like this because we stand a chance of making her life worse if it doesn't go to plan. Hi, Anmarie. Okay? It's a major operation, but we do it because we think the benefits outweigh the risks. So let's start off with a little bit of oxygen. And all you need to do is just focus on taking slow breaths in and out. And think of somewhere you'd rather be. Shouldn't be too difficult. Ready, steady, slide.
Okay, you happy to start?
So.
In this first part of the operation, Ewan needs to access Anmarie's esophagus to free it from the surrounding tissue, vessels, and organs in her chest.
Feel for the top of the rib. The esophagus is difficult to operate on because it's largely inaccessible. Just get my finger in the chest. So is the lung off now, Jeremy?
It's off, yeah.
Have a port, please. It's deep in the chest. It's near the aorta, which is the main blood supply from the heart going down into the abdomen. It's near the airways. There's a few things that we could injure that could actually kill the patient on the table.
Top lights down, please.
To reduce the risks, Ewan is using keyhole surgery for this part of the operation. It's far less invasive than making a massive incision down Anmarie's torso.
Yeah, gas on.
3 holes are made in Anmarie's chest, 1 for a camera.
Okay, so that's the lung.
And 2 others for the surgical instruments.
Just try to go over the bone. I learned keyhole techniques to do esophagectomy at the Queen Elizabeth. We have to use our touch and feel in a different way because we're feeling the instruments. And really it's much more challenging than open surgery when you can actually get your hands in a body cavity and feel your way around. I'll swap to the scissors again. If you don't have the training, it can be much more dangerous. And that's why we need to do it on a regular basis to make sure we know what we're doing and we can avoid some of the pitfalls that you can get if you just have a go.
To give Ewan a better view of Anmarie's esophagus, anaesthetist Jeremy has deflated her right lung.
Not even seen the esophagus yet. It's way more stuck than I was expecting. Normally, the lung would just collapse and give us a lot of space in the chest to work. But in Anmarie's case, we were confronted with these adhesions and scarring.
It appears past lung infections have left scar tissue behind.
So when scar tissue forms, it welds 2 structures together. So the lung was stuck to the chest wall. So we have to cut the adhesion and not cut the lung.
It takes Ewan 30 minutes just to cut the lung free and get the esophagus in his sights.
Oh, it's hard work.
Finally, Ewan loops a length of cord around the esophagus so he can lift it and work to free it from the surrounding tissue and blood vessels.
It's quite thick, isn't it? It's more diseased on the outside than I was expecting, to be honest. How's she doing, Jeremy?
Yeah, she's fine actually, yeah.
She actually had a very hostile chest. The esophagus was extremely stuck in places. And it was challenging to get it out, and starting with that and realising we had many more hours to operate was difficult. I think we can do the rest in the neck, actually. That's the apex of the chest. I don't think I want to go much higher than that, to be honest. Okay, it's completely free, isn't it?
After 2 hours, Anmarie's esophagus is separated from the tissue and vessels in her chest. It will now be easier to remove when Ewan has to detach it completely.
I'll do me.
We have the top lights on.
Top lights on, please.
Jeremy, are you happy to get the lung up?
Yes.
Slightly more tricky than I was expecting, to be honest.
But as Jeremy tries to re-inflate Anmarie's lung with air, there's a problem.
It's a big leak, mate. I'm struggling to ventilate, to be honest. I don't think it's a tube issue, I think it's a lung issue. Yeah, it's all coming out there that I'm putting in, that's the problem.
A tube to drain excess fluid and air from Anmarie's lungs is bubbling continuously. This shows that her right lung is leaking air because it's been slightly damaged, likely while separating it from the scar tissue.
My mind's starting to work further ahead, thinking, okay, what are we going to do if it doesn't settle? What are we going to do if it's leaking too much, if the leak's getting worse? What are we going to do?
If Jeremy has trouble controlling Anmarie's breathing, it could put her operation in jeopardy.
You happy, or?
Well, I don't know what we can do about it. I'm not massively happy, but I don't know what we can do about it.
Jeremy generally is very calm and in the theatre, and he copes with problems in his stride. But if he's worried, I'm worried.
Surgeon Simon Radley regularly takes on the most complicated operations in his field.
I think surgery progresses because surgeons are always asking themselves, is there a better way of doing this? And is there a way of doing this to make the operation quicker, safer, and reduce any risks there are from the procedure?
Okay. In his 2 decades as a consultant, Simon has carried out over 2,000 operations. His procedure today is on a patient who has bowel cancer that, if left untreated, will be fatal. She has a tumour in her colon, which has spread into nearby organs and caused a serious infection.
This is the colon tumour, around about here, a bit of the lobe of the liver there involved by it. And we're just scrolling down, so it's quite a big mass. But I suspect there's a lot of inflammation around this as well now.
You know, we can't really say where inflammation starts and tumour begins, or vice versa.
Simon's patient is 64-year-old Hazel, who has been at the Queen Elizabeth for the past 6 weeks.
Are you alright just to lift your feet up and we'll just knock that step back, okay?
She had to be admitted when her colon tumour perforated her abdominal wall, causing a serious abscess.
Lovely. Ready? I've got your back, okay?
Okay, yeah.
Yeah.
Now the infection is under control, Hazel needs surgery to try and remove the tumour.
I've never really smoked. Well, I've never smoked in my life. I drink occasionally, I used to ride my bike, I used to be a dinner lady at the high school.
Scans show the tumour, which started in Hazel's colon, has spread to the liver and abdominal wall. But because of inflammation, the surgeons can't tell if it's also spread to her duodenum, the first part of the small intestine. If it has, the tumour will be very difficult to remove entirely. The duodenum can't be cut away easily, as it forms an important part of the digestive system and is surrounded by vital blood vessels and organs. Without knowing the extent of Hazel's tumour, it's impossible to predict whether surgery will merely give her a few more months to live or save her life.
You're very fine, aren't you?
Hazel has been married to her husband Alan for 45 years. They have 2 children, 2 grandchildren, and have lived in Staffordshire their whole lives.
It's been hard for him, because he's the type of chap that he likes to be in control of things, and it's just been took away from him.
I wish I could mend her, really, put her right. It's just cruel. It's just cruel to watch her. All the fears are is now I'll get her off the table. It's like having my arms off if I lost her. I don't know. I don't know what I'd do with it, to be honest.
Nice to see you. How are you getting on?
I feel all right today.
Good.
Well, yeah, I feel a lot better than I have done the last few days.
I know we've talked about these things, the operation things, over the last few days and what we've got planned. Have to be realistic that we may not be able to get it all away. And the last thing, of course, is it is a big operation, and operations come with risks. And one of those risks is not going home from hospital. And I have to warn all my patients about that.
Just got out for the best, aren't
We'll look after you.
I'll try that one.
We're only out now is this surgery, which at the end of the day you've just got to put your faith in them blokes, are you?
Morning, everybody. Yeah. Patient Hazel Franks. She's got a locally advanced tumour involving the right lobe of her liver, her abdominal wall, with an abscess. Operating time 4 or 5 hours, but as long as it takes, really. Thank you. We go and get her?
Right.
Can't have the glasses. You can't just give up, can you? You've got to give it your best fight, really, and that's what I'm trying to do.
What I want you to do is just keep concentrating on your breathing. Okay? Nice deep breath in for me.
The length of Hazel's operation in Theatre 12 will depend on how widespread her cancer is. Joining Simon is surgical trainee, Deborah Wright, who has been studying her specialty for 10 years.
So, Mr. Radley, can you just run me through your strategy, which I know is slightly...
It's kind of make
we'll see. No,
make it up as you go along. I guess the determining factor will be, you know, really whether it's stuck to the duodenum or not. Yeah. Probably move the liver down first and go through the tip of the liver before and do the abdominal wall almost last, really. Sure. That would be plan A.
Yeah.
The training of surgeons has changed massively since I qualified as a junior doctor.
Go right to the top of that.
I was operating independently at a very early stage in my career, and hopefully I was reasonably competent, but I apologise to any of those people who I operated on, where the outcomes may not be as good as they should have been. Nowadays, we train our junior surgeons in a very structured way.
Can table go up to human heights, please?
Can I have a step, please?
Really go.
Okay. A teacher at this level is different to a teacher that you might think of more traditionally in a school or university setting. A teacher now isn't someone who tells you facts. They lead by example and show you how they approach things, the thought processes behind their decisions, sharing those decisions and that decision-making with you.
Are we okay to start, guys? All right, all good?
First, Simon and his team need to access Hazel's abdomen.
Okay, let's come down, keep coming down a bit. There we are on the midline, aren't we? That's not bad.
We are.
The setting up of the operation to start with is key. And that's one of the things that I teach my junior staff.
So actually, it's pretty good so far.
It's all about the preparation before you even touch the tumour.
Oh, there we go. Happy days.
Yeah.
Right, okay. So we're in.
We are in.
We're in our abdomen. That's
excellent.
Always a good start.
So we can do the operation not through a deep dark hole, but through a nice large incision, and we can see everything.
So let's just work out what we've got. So I think that's ovary.
Is it cecum there? Or?
Yeah, cecum terminal ileum.
Yeah.
Once in Hazel's abdomen, they need to identify the various structures and get a better idea of where the tumour has grown.
So
tumour's coming up to here, isn't it?
Well, we're in, there's transverse colon.
Yep.
There's tumour mass is down there. Okay, so that's where it's stuck to the abdominal wall. Good.
Clearly Simon is a technically very proficient surgeon, but actually what I'm learning from him is at least as much about how he communicates and how he makes decisions as about how to tie a knot and so on.
So actually, duodenum somewhere in there. Okay, good. So we're on plan A still.
In order to remove the tumour, first they need to isolate it.
Just give it. So that's back of stomach. It can be. That's a good start, isn't it?
It is.
By cutting all the way around where it's grown in Hazel's abdomen.
So tempting just to get your fingers in at this stage and just start fiddling, and actually you just stick to
the dissections that are easy, and then we'll go for the cancer once we've got above and below it.
Let's have a look. Look. The duodenum.
Yeah.
At the moment, they can't see all the way around the duodenum, so they don't know if the cancer has advanced into it.
Okay, we just Just want a bit of exposure in that corner now.
If it has, Simon knows he won't be able to remove it completely.
What I can't do in this operation is take the whole of the duodenum, because Hazel's not really well enough to withstand that sort of procedure. She may well not survive it.
Hopefully, now news is good news. I just don't know where to go, what to do for the best now. Just hanging about. That's all I can do, eh? Just wait and hope.
By the end of the morning, Ewan and the team in Theatre 11 are entering the second stage of Anmarie's esophagectomy.
Just need to keep that blowing.
Anmarie's lung is still leaking air after being damaged during the first stage of her operation.
Everybody hands on then. Ready, steady, go.
For the next part of the procedure, Anmarie needs to be on her back.
So we just need something underneath the shoulder blades and a head support.
In this new position, her lung settles against her chest wall, effectively blocking the leak, which indicates the damage is minor and will heal quickly.
And I'm happy the leak is almost entirely gone. Well, it's just kicked off again, but it's nothing like as bad as it was.
A nice relief for us all that worry could be put to bed for the moment and we could carry on and do the rest of the operation.
Okay. Am I okay to
Yes.
start? Okay, do you have a knife, please? There's operations that are very easy, and this is on a completely different spectrum. This is a very challenging operation. You know, I can't think of any other operation where we're operating in the chest, abdomen, and neck in 3 stages. There just isn't any other operation that does that, and that's one of the things I enjoy about it, the challenge of doing it and achieving that.
Ewan now has to access Anmarie's stomach to start the painstaking process of preparing it to replace her esophagus.
It has to be fairly delicate what we're doing, and we want to make sure the stomach's in good condition. If it's going to be bruised and injured, it's not going to do its job of replacing the esophagus. It's not going to heal very well. Stomach looks all right, doesn't it? Looks cool on there, actually. Do you have a pair of forceps for me, please? If you could just hold colon. We have to free it from the colon. So at the minute we're just dividing little bits that will stop it from going as high as it could normally. We have to divide vessels securely so they don't bleed, and we have to make sure the vessels that remain and that the arteries and the veins work to make sure it still stays alive, because if we injure them and the stomach dies, we wouldn't be able to use it. Do you want to push down there, Anthony? Fingers crossed. I'm hoping it will stretch all the way up. So here's hoping.
If the stomach won't reach the top of her neck, their last resort will be to use a section of Anmarie's colon to replace the esophagus.
It's not a great backup plan because it's an even more challenging reconstruction, and it's something we were reluctant to do in Anmarie's case. This operation was already tricky enough.
To see if the stomach is a suitable replacement for the esophagus and will reach to the top of the neck, Ewan first has to take out Anmarie's damaged esophagus.
We're going to start on the neck now, Jeremy.
Okay, mate.
Okay, do you have a knife? In my training, I think I'd done about 60 esophagectomies. And I've got a very particular way of doing the operation, which is slightly different to the way I was trained, because I've picked the best ways of doing different parts of the operation and sort of amalgamated it into the way I do it now.
To free Anmarie's esophagus from its surroundings in her neck, Ewan has to use his finger and a technique called blunt dissection.
So we use the finger because we can feel when something feels like it's going to strip off easily, and if there's resistance, we don't push through like we would with a knife or something sharp. Got the NG tube, got bone. The last thing I want to do is injure something important in the neck. I'm just trying to feel the esophagus and feel the bone. I'm just trying to bluntly free it up from its structures. I've done enough of these operations now to know what a normal structure feels like and what it doesn't feel like, and it's just experience knowing what is safe and what's not safe. And eventually I'm going to try and hook my finger around it and pull it out through the wound. We're not quite there yet.
But the scar tissue that formed after Anmarie's childhood injury means the esophagus is tricky to free.
Longer finger. That's the esophagus there. Yeah.
After 30 minutes, Ewan finally frees the esophagus.
Bloody hell. That wasn't easy either, was it? No? Yeah, I think there's lots of inflammation, wasn't there? Yeah.
He's now ready to remove it. First, he cuts it at the top, leaving a small amount where the stomach can be attached.
Right, hopefully that'll bring it down. Thank God for that. Jesus Christ. Okay, so that's the esophagus. After all that, so I'm just going to take the cardia, which gives as much length as possible.
Finally, he cuts it where it joins the stomach.
Okay, that's the esophagus.
Anmarie's damaged esophagus is now out.
Realisation comes that we've done it. We cut the esophagus, but it's then the worrying part is the reconstruction. I mean, I'm hoping it will reach. We'd gone way, way beyond the point of no return.
Simon is still trying to work out how advanced Hazel's cancer is in Theatre 12.
So we've got here, this tumour mass there.
He's cutting around Hazel's duodenum, the first part of her small intestine. He needs to determine if Hazel's colon tumour has advanced into it.
And that's where it's going out towards the liver, the lower lobe of the liver, or the right lobe of the liver. And that's all the right way around now.
It is.
Hazel is too frail for the radical surgery it would take to remove tissue from the duodenum. So if there is tumour there, it will need to be left behind.
That's better. Okay, so I'd be better probably at this stage transecting this small bowel, wouldn't I?
Yeah, because we can take that later.
From the top parts, we started working our way up from the lower part of the bowel, again towards the duodenum.
After cutting around most of the duodenum, Simon hasn't yet found any cancer advancing into it.
Yeah, let's do that.
We identified the bottom of the duodenum and the top of the duodenum, but we still weren't sure where we were in the middle.
So that's there. And where's duodenum? That's there. Okay, yeah, I think we're good.
That's when Bobby joined us for the operation.
Can I help you?
Specialist liver surgeon Bobby Dasry is going to help cut around the last tricky part of the duodenum.
I'll take you through it.
And Bobby spends all his time working around the duodenum, so it's great in that situation. We can then work together to tease out the duodenum.
So your duodenum's now there.
Yeah. But I think we'll have to start mobilizing it to get access to the duodenum.
So just take the stomach down up here first, do you think? Yeah, okay.
Bobby needs to cut carefully around the duodenum, millimetre by millimetre, avoiding important blood vessels.
So this is the bit, isn't it? This is the bit that's going to tell us whether we can do it or not, yeah.
scissors to me, please.
If they can cut all the way around without encountering tumour, they'll know that the cancer has not invaded it.
Can I have a small saw, please? Something like, yeah, that one. If you put your finger here,
yeah,
that's my finger on the top.
Oh,
Meeting in the middle.
absolute heaven. All right, hey, great, okay.
They've been able to reach all around the duodenum with their fingers from either side, which tells them the tumour hasn't spread that far. There's now a real chance they'll be able to save Hazel's life.
I've never felt like that about you before. The duodenum is the big thing for me, and knowing it's actually clear, great feeling. Right, should we do this? Because we can do this now. We're committed. You know, this really was happy days. We realised at that point we'd be able to remove the tumour with the liver and the abdominal wall.
The tumour is probably infiltrating the liver somewhere over here.
Right, thank you.
And we want to preserve as much liver as we can.
Yeah.
Bobby begins to remove the section of Hazel's liver where the tumour has spread.
Hazel can live very well without this piece of liver.
Absolutely, absolutely.
She won't even notice that it's gone.
Yeah.
So we have a couple of Roberts, please. So it's a bigger chunk of liver than I expected, actually.
Yeah. It's going more down
Always looks
posterior. So that's the liver there. That's the tumour there. And that's all the important plumbing at the back.
Yeah.
Learning to be a surgeon is an apprenticeship. Over the course of your training, it's really important that we are actually doing more and more.
It's nearly out.
It is.
But it's also the observing and, even more usefully, someone talking to you and explaining to you as they're doing it.
That's incredible. Okay, I think I'm going to come around there next. The joy of working in a teaching hospital like this with other consultants and junior staff.
So now it's just in the cavity.
Shall I just come around and have a feel on that side and just see where we are? You're talking, you're learning things from people the whole time. It is truly lifelong learning in my view. So we're actually, the only thing that's fixing it now is the abdominal wall.
To give Hazel the best chance of survival, they cut a wide margin of tissue where the tumour's attached to the abdominal wall in case it contains cancer cells.
If you've got a cancer, you want it out as a patient, and sometimes surgery isn't always the best answer to that. Surgery is only one of the regiments in that battle.
It is possible to treat some cancer patients before they end up on operating tables like Simon's. The QE now treats some hard-to-reach tumours with one of the most sophisticated technologies available, the CyberKnife. The QE's is only one of 6 in the country. Despite the name, there's actually no cutting involved. The CyberKnife system delivers a highly targeted form of radiotherapy and uses 3D scans and robotics for what can be potentially life-saving treatment.
We largely treat people with lung cancer, breast cancer, melanoma, brain tumours that have spread from primary cancers elsewhere outside of the brain. The benefit of using this technique is because it allows our machines to target the lesions that we want to.
To keep the patient in position for the targeted treatment, a specially fitted mesh mask is put in place. A scan of the area to be treated is downloaded into the CyberKnife system, which maps out where the hundreds of beams of radiation need to be delivered.
So we're targeting the lesion here with 197 beams. So we've got a nice MRI showing us exactly where it is.
An X-ray producing accelerator gun mounted on a robot arm delivers high-dose beams of radiation. As it moves around, it can attack the tumour from different angles, delivering the radiation with the precision of 1/10 of a millimetre. The accuracy allows larger doses to be given in each session, so the number of treatments needed is much lower than with conventional radiotherapy, up to 10 times fewer. Because the tumour is exposed to high doses of radiation and not the healthy tissue, patients usually suffer from few side effects.
So bring the bed down.
Over my career, I've seen huge changes in the way cancer's treated. Overall, we're looking more and more to non-surgical treatments. And that's ultimately got to be a better way, so people like me have to hang up their scalpels in the future.
By mid-afternoon, and after 6 hours, Ewan is starting the third and final part of Anmarie's operation in Theatre 11.
Okay, do you have the retractors? I'm not massively ecstatic, but I think it's going the best it can go. And I'm hoping the stomach will reach.
To create a new esophagus for Anmarie, Ewan has to push the stomach up through her chest and attach it at the top to the remains of her esophagus.
I'm just going to try and free it up a bit more.
It's ironic, the most difficult part comes right at the end when we're tired, when we've been operating all day.
Let's get the light a bit better. Do you have a laparoscopic camera bag?
The stomach is placed in a plastic bag.
Okay, do you have a tool microphone?
And a cord is attached to it.
Right, do you have some heavy ties? Just wait.
So it's easier to pull up through Anmarie's chest.
I just want to pull it up once rather than pulling it up, pulling it back down, you know, and then it all gets bruised and horrible. There's certain nervous parts of the operation. One particular part is to pull the stomach up and see if it will reach the remnant of the esophagus. And that is very stressful. And I think the day I become not nervous of that is probably the day I should stop doing them. Do you have the lube? So don't tug it, just sort of guide it. So every time I push up, you just pull a little bit.
As Ewan pushes the stomach up through the chest, an assistant gently pulls the cord attached to it to feed it through the hole in Anmarie's neck.
We've got to make sure that when we pull it up to the neck that we don't develop any twists or kinks, and that the blood supply to the stomach remains in good condition.
Can I have a Babcock, please?
Because if it does get compromised, the whole stomach could go down days later after the operation.
So this is the stomach coming up now.
The stomach has reached.
Any more to go? I don't think so. It's full.
But only just. And there's very little of the esophagus left to attach it to.
In other patients, we might have another 5 or 6 centimetres of the esophagus to play with. So if we make a mistake in the first attempt, we can nibble a little bit off and make another one.
So that's, you know, she's got 2 centimetres, 3 centimetres of esophagus left.
But in Anmarie's case, this was difficult. So we had one shot at doing the join, one shot only.
This is the trickiest part of the operation. So Ewan's asked senior upper gastrointestinal surgeon John Whiting to assist him. John was Ewan's mentor when Ewan first came to the QE.
Hi guys. When I first started in Birmingham, I worked with John. He trained me in most of the more advanced operations.
How's it all going? How's it gone so far?
It's not been the most easiest operation, to be honest.
No, I don't think it ever was going to be, was it?
I was very relieved to see him. It was the fact that he gave me an extra edge for me to do the best job possible.
I don't know, maybe I was a bit more optimistic than normal.
Ewan asked me to come along, not because I was going to be better at it than him, but basically if you're going to do something really complex, you want a very experienced pair of hands assisting you.
So now we need to do the most difficult bit of the operation, which is the join.
The join is the thing that we worry about, and the reason that we worry about it is that if that join leaks after the operation, then the patient can become very unwell.
Probably a risk of going through the stitches, isn't it?
Yeah. So getting that join right is absolutely critical, and that's one reason why it really is a very stressful operation for Ewan.
So I think we need to hand sew this. It's not going to staple, is it? No. So it's probably going to stitch the staple into the stomach.
Normally, they would use staples to make the join, but because there is so little tissue to work with, they can't take shortcuts.
You happy, John?
Yeah, that's good.
When you've got a limited amount of space, then you're really forced to hand sew the join. Each stitch will be individually placed. What you do is put the deeper stitches in first.
Cut again, please.
And you'll put it through the stomach, you'll put it through the esophagus so that they're sitting nicely, but you won't tie them. Because if you tie them and bring the tissue together, then it means the view for putting the other sutures in isn't as good. So you leave them loose.
Yep.
I'm going to clip this one.
Hang on.
But the thing that we have to do is to make sure that we don't tangle all those sutures up.
So this has come undone, that's why. That one, hang on.
The black one?
Yep, that's fine, yep. So hold that like that. So this is your last suture.
We place the knots by pushing the knot down to the tissues, so we've got that tactile feedback to make sure they're not too tight, not too loose, and just right, just opposing the tissues so it'll heal.
There was a point when I thought it wouldn't come up.
You're trying to do as good a job as you can all the time. You know, good enough is actually not good enough. It's got to be as good as you can possibly do.
That's the last stitch in the join done.
Pretty good to get that last stitch done. We were happy with how the spacing of all the stitches looked and how it had come together. And it looked pretty good. It looked the best we could do.
Right. Looks good.
Shall I love you and leave you then?
Yeah.
Thank you very much.
Thanks, John.
Okay, cheerio, folks.
Is the feeding tube going in the small bowel? She won't be able to eat and drink immediately. And if she has any problems with the joint, it'll allow her to have nutrition.
Clip, please.
When Anmarie does start eating again, she'll have to adjust to her new anatomy.
The stomach will still be involved in digestion in Anmarie's case, but she'll have to adapt to living with the stomach and the chest. She'll have to have smaller meals. She'll have to take her time on swallowing, and she'll have to take medication to stop the stomach producing acid, because otherwise she'll get lots of heartburn and acid reflux.
It's a long day.
The operation has lasted nearly 8 hours and appears to have gone well. However, more than 30% of patients will develop major complications, including the joint failing to heal properly.
Ironically, the worrying for me actually comes later.
Nice sit down.
Hope she does all right.
Me too.
I don't usually worry so much during the operation. It's the hours after, it's the days after, it's the nights after. But I really start to get concerned and worry.
Okay, Anmarie. You're right. So we're just going to take you around to recovery. Okay, operation's all done.
It will be about 2 months before Ewan knows how successful the operation has been. Simon and his team are nearing the end of Hazel's bowel cancer operation in Theatre 12. They have almost cut around the full extent of the tumour.
The main concern is she's not going to have much abdominal wall muscle after I've done this.
If they can remove the whole tumour, there's a chance they can cure Hazel.
In fact, Bobby, we're right. We're on the abdominal wall, aren't we? We knew that the tumour had perforated into the abdominal wall. So that's there, that's there, that's there. Let's go a bit wider, shall we? And as a result of that, I would be worried about leaving cancer tissue behind if I didn't take enough abdominal wall tissue with it. It's not just getting the whole of the tumour out, it's trying to get it out in one piece. Yeah, just that edge there next.
Oops, sorry.
Sorry. Naveed, I think this is nearly out.
Nice work. Good
Scissors,
work.
please. Wow, fantastic.
Yep.
I think I've got that all the way around.
Yep.
The tumour is out, along with a wide margin of tissue from all around it, where cancer cells could be hiding.
Terminalium, colon.
Cancer.
Cancer. You couldn't have done that without taking the liver, you know?
No.
No, it's right through it. Oh, that's a result, isn't it? That is really a result. I mean, I think that's better than I could have hoped for at the start of this operation, to be honest with you. And we see we've taken a huge amount of abdominal wall with it. So we want a piece of mesh.
Simon sews in the mesh to strengthen and stabilise Hazel's abdominal wall.
Right. Hey, let's have a closure stitch, please. At the start of the operation, we were thinking we can't do something perfect. We're going for an improvement in her quality of life. Little clipper, please. At the end of the operation, we're thinking, quietly thinking, we could potentially have cured her of this disease. Thank you. Thank you very much.
Thanks.
Thanks, everybody. Which would be fantastic.
Hazel? Hazel?
Hello? Yeah? It's what? Get in. Get in, yes? They're over the moon with her. Over the moon with her. We're supposed to be in there 8 hours. They said he's come out like shelling a pea. They think they've got the whole lot. Critical care area A, that's where we're going to go.
I've never seen you walk so far.
Can I ask who you are, please?
I'm your daughter and her husband.
Okay, I'll just check for you.
And a son.
Hi. Hello. Hey, well done. You've been brilliant.
Look at that. You look really well. Really well. You know?
Hazel and her family have to wait 2 weeks before pathology results will tell them if she is cancer-free. It's 8 weeks since Anmarie's operation.
Anmarie, please. Hello. How are you? In you come. How are you getting on?
Been eating a small amount of food.
Okay.
And I've been eating fish and fried rice and curry.
but she's still having the occasional problem.
It's just where the joint heals, it sometimes just narrows a little bit. And it should, with a couple of stretches, be more normal, so you can eat more normal food. I don't think you'll be in hospital, every 6 weeks like before the operation. Yeah. Okay, I don't think that'll happen. So Anmarie's going to need to work with our dietitian and our specialist nurses to try and optimise the way she eats. Okay, bye-bye now.
Thank you.
And I'm hoping we can work together and try and get her to a stage where she has a pretty normal life. I feel good. In the grand scheme of things, she's had an excellent outcome.
Hazel is still in hospital, recovering from the massive operation to remove her tumour. The pathology reports are now back and will indicate how successful Simon has been at removing the cancer.
Hello.
Good day, sir.
Hazel, afternoon.
Afternoon.
How are you?
I'm not too bad, thank you.
Fine, good to see you.
Sitting here, crossing my fingers.
Today's the day.
Okay.
Today's the day, eh?
So we've got the results back, and it's really good news. So the first thing is that we've got the whole tumour out. Right. Okay, so it is all removed. But one of the things I explained to you before was we look at the margins all the way around, and the margins look clear all the way around. That's just great, and that's absolutely as good as we could hope for.
Oh, yes.
So I'm delighted for you.
I mean, 12 months ago we was up the creek with air to paddle, weren't we? Basically.
Yeah, you've been looked after very well in the meantime, haven't you? Yeah. It's always great to be able to tell people that it's good news and that we've done as well as we possibly could, and probably better than we'd hoped.
Well, mate, we've done it, haven't we?
Yeah, you've done it. All right, you look after yourself. Yeah, and I'll see you soon. Always feel a little bit caught up in the emotion of it, because you can't not be, really. Well done. All right, yeah, give me a hug. You've done great, Hazel. You've done great.
Thank you
all right.
very much.
All right. One of the most important things that I've learned is not to take away hope. There is always something that you can do to improve their quality of life in some way. Sometimes improve the length of their life as well.
I'm feeling over the moon at the moment. Over the moon. Couldn't wish for anything better.
At the end of the day, I mean, they've just given her a life back, eh?
Oh, they have. They have.
I'm good again.
I'm down. Come on, you softy. Kiss.
To collect you for your surgery, is that okay?
Right.
In the UK, some 3 million major operations are carried out every year.
Nice big deep breath. We'll look after you, don't worry.
Only the country's top surgeons are skilled enough to take on the most critical cases.
Cameron, you all right?
Just take a couple of deep breaths.
If you're going to make a hole in someone, you better be sure what you're going to do.
Should we go for it? Right.
They're using pioneering techniques to treat conditions that used to kill.
A few years ago, these operations were felt to be too big or too dangerous.
But pushing the boundaries of modern medicine comes with great risk.
Just keep quiet for a second, please. If I move the blade too much, she's going to wake up unable to breathe.
Life is precious. It can vanish in a heartbeat.
Whoa!
You need to keep your head. Hold this. The heart is empty. We haven't got any volume at the top. If you panic, the patient can bleed to death.
The surgeons bear the ultimate responsibility.
I need it ASAP. I can't wait for this.
I'm not infallible.
Failure is absolutely possible.
We are a team, but there's one person's name at the top of the bed.
Bloody hell.
This is what really happens behind the closed doors of their operating theatres.
This is a battle, us versus the Grim Reaper. And we're not going to lose.
The Queen Elizabeth Hospital, Birmingham, is renowned for pioneering surgeries that can be risky, but if successful, truly life-changing. One of its leading surgeons is Navin Furtado, who specialises in correcting severe spinal deformities.
Spinal surgery is a risky specialty. We have to decide whether surgery is the right thing to do. There are scenarios where it's 50-50.
Oh, right. To the left. To the left.
The debate about who is deserving of NHS money and NHS care is ongoing all the time. We have to balance risk versus benefit.
Navin is taking on one of his biggest cases to date. 63-year-old Chris Green.
Okay. You're pulling me screaming.
Years of heavy work as a butcher have taken their toll on Chris's back. He now struggles to walk or even stand up straight and relies almost entirely on his wife, Sandra.
I can spend up to 15 hours a day in bed, rarely go out the house, constantly in excruciating pain from the nerves in the back, radiating down my leg.
Chris's spine has become increasingly deformed over the years. The spinal column is a strong but flexible structure, built from 24 bones, known as vertebrae. Between each vertebra are discs which act as shock absorbers whenever the body moves. A normal spine is curved, but some of Chris's discs have worn away through excessive lifting and straining, causing his lower spine to collapse into a straight line, forcing his head and neck forward in front of his pelvis.
Imagine if you had to walk around all day, bend forward, as if you were trying to hold a walking stick, but you didn't have that stick to support you. Your body is not designed to be in that position. Pain is going to come from muscle, from ligament, and the joints itself.
I never expected this. I used to be pretty healthy and fit in my younger days. Not being able to do things you used to be able to do, it's depressing. Household chores, gardening, the whole lot falls onto the wife.
We've had 4 years of hell. Chris getting up, having a cup of tea, going back to bed. Getting up, having a cup of coffee, going back to bed. Coming down for a sandwich, going back to bed. That's no life for anybody.
When I first saw Chris, he was consigned to the fact that this is his life, this is his future. One of chronic pain management, strong doses of pain medication, therapy, adaptations to his house. All of that has a cost.
Chris has already undergone 3 surgeries, none of which have corrected the deformity or reduced his pain. Navin is planning a radical procedure that few surgeons would attempt, rebuilding Chris's entire spine.
Hello there. Hi, Christopher, how are you?
Not too bad.
A bit nervous?
Yes.
Okay. We're going to make a big incision in your back from your shoulder blade area, right down to just above your bottom. He'd been seen by different consultants who'd felt that there was nothing else that they could offer him surgically. And we're going to remove part of the vertebra
part of that spinal bone from the back by taking out a wedge of bone.
I thought, you know, possibly there is something here to do, but to do it, you have to go big.
And so the operation is going to bring you from this position to more an upright position.
What we're going to do is essentially break his spine and reset it.
Navin will be operating within millimetres of Chris's spinal cord.
The risk is that we could damage nerves, worst case scenario, paralysing you from waist downwards. Okay. Has that been quite a lot to take in?
It's knocks you to your boots, as we say.
Yeah, it's a risk, but I'm hopeful that this will work. Yeah.
So.
Fingers crossed. Yeah.
I've said to Chris that there's you know, about a 70% chance of something going wrong around the time of surgery or in the first year.
Probably looking at about 8 hours of surgery or so.
You need to be confident in your own mind that the quality of life that you have at the moment is bad enough that you want to take on that risk.
All right, Chris, take care.
Okay,
all right.
Thank you very much.
Nice to see you. All right, you take care.
Okay.
All right, bye now.
Thank you very much.
Okay.
Where before Dr. Furtado, I hadn't really got much of a future. So it took me less than about 10 seconds to make my mind up. There's always a chance that things may go wrong, but you've got to look at the wider picture and think, am I going to get better? You're in the hands of the surgeon. Dr. Furtado is the goalkeeper that's going to save that penalty shootout.
Navin will be carrying out Chris's operation in Theatre 20, where the surgical team are getting ready.
Okay, Mel.
How are you doing? You okay?
Chris's operation is so complex that Navin has requested help from spinal surgeon Mel Granger.
Then you can start prepping.
Correction of spinal deformity is probably the biggest and most complicated surgery that we do within spines.
I think he's grateful for what we're trying and accepts the risks. Running out of options there.
There's always a little bit of anxiety with big operations like Chris's. You look forward to it, but you can't allow yourself to be distracted by anxieties. You've got to focus on the job in hand. Cheers, mate. Thanks.
As a butcher, it's almost like a surgeon. You use a knife to prepare beef or pork, you know, but I don't know if a surgeon uses a chopper like a butcher does.
For Chris's surgery, Navin and Mel will be working alongside anaesthetist, Khalid Hassan.
Little scratch there. When we anaesthetise patients, people think we just put them to sleep and then walk away.
Thank you.
Welcome. Thank you. Throughout the whole time that they're asleep, we are constantly monitoring all their vital functions and making sure that they're safe throughout the surgery. Okay, on three, gently. 1, 2, 3.
The surgery is likely to take up to 8 hours. Chris will be lying face down throughout.
Okay, so we've got Christopher Green. Okay, he's for instrumented deformity correction. Yeah.
We're going to remove a wedge of bone out of the vertebra to get the angle we need to get in his lower spine. That's the bit that's going to lose a bit of blood.
Expected duration of surgery? We're going to try and finish on time.
The aim of the surgery is to rebuild a curve in Chris's lower spine so he can stand up vertically rather than leaning forward. To do this, Navin and Mel will drill 23 screws along his spinal column. As they can't bend the spine, they'll need to break it by removing a 30-degree wedge of bone from one of the vertebrae. By closing this gap, Chris's spine will be realigned into a more natural curve. Metal rods will be attached to the screws, securing the corrected spine in its new position.
All right. Everyone happy enough?
Yeah.
Okay, good. You ready?
Yeah, everyone happy?
We're happy? Okay. Okay. Let's have the you got the dilator then.
Navin and Mel's first task is to clear a path to Chris's spinal column by removing the tissue that surrounds his vertebrae.
Forceps, please.
Running through the centre of the vertebrae is the spinal cord, responsible for all the movement in the body.
I remember the first time I saw a spinal cord and it just blew my mind.
So we'll expose the thoracic spine here.
Every second of every day, of every month, of every year, for the rest of your life. That thing transmits all the impulses from your brain down into your arms, legs and trunk. And the spinal cord, when you look at it, is about the width of your little finger.
Okay, let's get this retractor in there. So we've got to create basically a giant space for two nerves to go out.
During invasive surgery like Chris's, damaging the fragile spinal cord is a very real possibility.
Okay, so now moving down towards the lumbar spine. The spinal cord and the nerves take some manipulation. They can accommodate for that. But a millimetre here, a millimetre there might make a difference in terms of whether the patient's walking or not. Okay, so that's that first level essentially prepared.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
14 clinicians are needed to support Navin and Mel today. Twice as many as most routine procedures.
If you're doing operations on the spinal cord and spinal nerves, but you need a full team behind you to do it safely.
We're more than a football team.
Surgery of this sort is expensive. It is in the region of £20,000, £30,000. I've got to be pretty sure that what I'm offering is going to make a positive impact.
So far, so good.
Lulu, come on, baby. I've got a swollen abdomen. It just gradually got bigger and bigger over the last 8 to 10 years or so. I've tried Weight Watchers, Slimming World, every diet, and they wouldn't do no trick because my lymph glands just, they've broke down in my body.
Judy has an extreme case of lymphedema, chronic swelling caused by a defect in the system, which helps fight infection and drain excess fluid from the body's tissue.
It's like carrying another person, and most of the time I'm on the bed and just to take the weight off my legs because it's so painful.
Judy's lymphedema has caused a build-up of fluid at her waist. Gravity has taken over and she's been left with a hugely distended abdomen, known as an apron.
Because if I go outside, it feels like everybody's looking at me and like whispering to each other people. So that's the reason why I don't go out very often. It's horrible. I feel like an alien.
Plastics consultant Sonal Thomas has taken on the task of removing Judy's apron.
The majority of the public perceive plastic surgery to be cosmetic work, but it's much more than that. If a person has an abnormality that is correctable and is adversely affecting their quality of life, that is where the motivation comes from my side. I was surprised that Judy would have gone through life with such an enormous problem.
Ooh.
I take on board the fact that it's not a clear-cut life and death operation, like in a trauma situation or, a cancer that needs to be removed. But at the same time, she's got significant difficulties with managing herself on a day-to-day basis with things that you and I take for granted. And it's only going to get worse.
Her apron, full of excess fluid and tissue, has left her housebound and unable to walk more than just a few steps.
Oh, that's it. I'm in.
So the journey begins.
The detachment of Judy's apron will be the largest ever attempted at the QE.
I think it'll be easy to look at her clinical photographs first. I mean, that photograph is about a year old, so it's slightly worse now. It's reaching right down to the ankle area. So you can see there's a lot of lymphedema there. The lymphatic channels which take fluid into the lymph glands get blocked, and you get collection of fluid which just keeps on increasing over time. And the belly button is actually at the level of the knee joint.
Managing the sheer weight and size of the apron in theatre will be difficult. But there's another challenge.
The most concerning thing for you doing surgery is these large blood vessels down here. They're quite chunky. They're much bigger than you would normally find in the soft tissues of the anterior abdominal wall.
2 blood vessels, which would have previously circulated blood in Judy's abdomen, have now grown into her apron.
That's a very chunky vein.
Very chunky vein coming down.
So it's a huge vein, and that's...
As the apron has got larger, so too have the blood vessels.
The easiest place to access is here.
They will have to be carefully severed and tied off before the apron can be removed.
Pretty large. And that's going to be the
But that's really good to know pre-operatively, so we can plan it, and it also gives me...
The risks of the operation are increased by Judy's size. Weight gain has exacerbated the lymphedema, but she can't diet the apron off. It has to be removed surgically.
Go on, that's it. Go back now. Okay?
Yep.
Although they're separated, Judy's husband Dave has been supporting her journey to potentially life-changing surgery.
It kind of grew in the background, if that makes sense. There you go. Is that okay?
Yeah.
You all right?
Yeah.
She used to go to all these slimming clubs, and although you could see the weight coming off her face and other parts of her body, the stomach never reduced. She doesn't like asking for help, but she had to in the end. She really couldn't manage on her own.
Obesity is actually been on the rise. And because of this, a lot of plastic surgeons are now having to deal with this issue. There may be some folk who would say that we should not be carrying out this kind of surgery, which may be a financial drain on the National Health Service. But as surgeons, we are here to help our patients, not to judge them. And that's why we took the Hippocratic Oath when we became doctors many years ago.
Mr. Thomas, God bless him. He's fought for me. I am so grateful.
So, Judy, how are you?
I'm fine. I'm fine. I'm glad I'm here now.
Here.
I've been on and off crying all day, and I want to cry now because I've seen you.
Oh dear.
I know I'm in the right hands.
So, you're happy with all
Cosmetic surgeries, including apronectomies, aren't routinely provided on the NHS.
In terms of the risks, initially her request for this procedure was rejected because the commissioning groups did not actually understand the gravity of her problems.
I've suffered long enough.
Okay.
I don't want to go on like this no more. No turning back now. I've signed my life away.
You can always change your mind, but I don't think you will.
I'm here now.
Okay.
It took Sunil a year to convince the commissioning groups that Judy's weight couldn't be managed until her apron was removed.
I was really pleased when we finally got the green light to go ahead with Judy's operation. At the same time, I was slightly apprehensive because the surgical challenges would be very difficult.
How many of these have been done?
She's the first. I'm not putting it correctly. We do a fair number of these procedures, but not to this extent.
Great. Brilliant. Thank you.
Sunil will first make an incision at the top of Judy's apron, trying to remove as much tissue without piercing the abdominal wall that protects her muscles and internal organs. He'll then make an incision from underneath the apron, carefully severing and tying off the 2 large blood vessels, before finally lifting the apron free.
I've actually requested if it is possible for us to have 2 teams, one on each side, with independent scrub nurse on each side. So I think we'll start at the top, depending on...
Sunil has asked senior plastic surgeon Suk Rayat to assist him.
The amount of tissue, it's the largest that I've ever come across, and I think it's the second largest recorded case in the literature.
A 15-strong surgical team has been recruited to grapple with the huge weight of tissue during the operation, which will take place in Theatre 19.
We're going to have a sweepstake on the way.
Right.
Yeah.
55.
55?
Yes.
Okay. So Richard's 55.
When everyone's on high alert, a sweepstake, guess what the weight of this apron is going to be? Helps to diffuse the pressure.
Yeah, mine's 35. Half a small person.
I'd say 38.
I think he's going to be right.
Yeah.
It's not that we're being frivolous or we are disrespecting the patient in any way. It's just to improve the morale of the whole theatre team. It will be a challenge because of the intensity of this huge abdominal apron.
Okay, and your patient is? Judith. Any concerns anaesthetic side?
So cardiac-wise, you might lose a bit of volume. We've got 4 bloods cross-matched as well. So overall, she's a very high risk.
Okay.
I'm ready to go, ready to have it done. But deep down, I'm feeling a bit scared and frightened, still scared and frightened. I just want to get my life back. And it's hurtful. And I don't like it. I don't like what I've been called. I have to depend on other people and it's horrible. When I wake up, I want him to be there. Nobody else. Just Dave. We've been through a lot together. He's been my rock. Just to hold my hand and make sure everything's okay.
Knock, knock.
We've been separated for about a couple of years now. See you later. It's called Endless Arguments.
Take it.
I will.
I can remember the first time I saw her, yeah. I thought she's very pretty, very attractive. When somebody stays at home all day, so much bottled up emotion, and the first person that comes through the door, obviously is going to take all the flack. I'll see you in a while.
All right then, see you in a bit.
Take care.
I will,
Good luck.
later.
I think maybe that led to our bust-up.
Hi, Judith. You all right? Don't worry.
Nice and slow, yeah?
Unlike most patients who are anaesthetised in a side room, Judy is taken straight into theatre. Her size means it is easier for the team to transfer her while still conscious onto a specially reinforced operating table.
Okay.
Yep.
One.
Good. Well done.
Okay.
What you looking forward to doing the most?
Driving my Herbie. It's a VW Beetle.
Wow.
My Herbie.
I can't see any veins at the moment.
Overseeing Judy's anaesthetic today is Raj Rao.
Because it will be very deep. Just going to use ultrasound to look at your vein, okay?
Well done.
Her weight makes her a challenging patient for Raj to keep anaesthetised safely.
Have you got it?
Not yet. Obese patients do present with a set of challenges for us as anaesthetists. Because of the fat within the patient, it's difficult to get an IV access. Okay, sharp scratch coming. And also, putting a breathing tube into the windpipe itself is difficult because there's a lot of fat inside the oral cavity. That's easy. But the main problem is obese patients cannot breathe while they are lying down because all the organs are pushed against the lungs. That means the ventilator is struggling too hard to breathe for her, which could be a problem for us.
You think it might be? So we need two people. What we're going to do is we're going to bend her knees. Raj, are you happy for us to get started, for us to begin? Okay, knife to skin at 10 past 12. Okay. Yep. Judy is a high-risk patient. So for me, the biggest step forward was Judy's agreement that she would be willing to take the risks that this procedure involved.
Can I have a knife, please?
And I think it's the wrong approach to make a decision presuming that things are going to go wrong.
Like a clip?
There was no question in my mind whether or not this was the right or the wrong decision. I think you make a decision on the presumption that things are going to go right.
In Theatre 20, former butcher Chris has also taken a decision to undergo risky surgery for the chance of a more active life and less pain.
So we're going to both put screws into 6 and then alternate below 7. Okay.
Before Navin and Mel break Chris's spine and rebuild it,
Self-retaining, yeah.
they'll insert 23 screws in his lower vertebrae. These screws provide attachment points for the metal rods that will ultimately fix his reshaped spine into its new position.
Okay, let's have X-ray and then. Can you get me the light lead gown? Yeah, the Dalmatian dog or the boat one, the blue one, whichever.
Each step of the way, the team uses X-ray to guide and check their work, so protective lead gowns are worn throughout.
Can you just come over the top towards me a bit? And see that? That is S1, but it's higher than you think, Mel. Okay. So more towards you. Just come up north a sec.
The team will take around 60 X-rays to ensure they attach the screws in exactly the right position.
That is a big screw. So that's the biggest screw they have on the tray. There'll be a lot of stress going through the lower part of his spine.
Always in my mind, I've wanted to do something using my hands, essentially. So I was making Lego, Meccano, that sort of stuff as a kid.
And you've got the nibbler.
As surgeons, we like our toys.
Need 2 starters on this set. The instrumentation that we use in spines reminds me very much of the Meccano I used to have. I had set 8. I'm pretty sure I've still got it somewhere.
It's bloody, isn't it? Very bloody. Let's have a swab, please.
Another big swab, please.
Navin and Mel have now been operating on Chris for 4 hours.
Blood loss is substantial. I'm not entirely happy with them, actually, I must admit.
Starter, please.
If you're making a big cut from the top of his spine right down to his pelvis, that is a significant amount of blood loss.
He has been oozing quite a lot throughout the surgery.
His hemoglobin is very low, and with it, his blood pressure's just gone down.
When you do these osteotomies, when you break the spinal realignment, the bone bleeds. You produce blood in your bone. You put a patient face down, if they've got any pressure on their tummy, it will force the blood from the belly back into the spine. And so that can be a problem, both for the surgeon in terms of seeing what you're doing, but for the anaesthetist in terms of keeping up with blood loss.
Blood pressure's still heading south, isn't it?
Got another swab, please.
3 litres.
It's the job of anaesthetist Khaled to control Chris's blood levels.
Let's do one of my... When something like this occurs, for me personally, it starts to add to the stress level. You've got a pressure bag for this?
Yes.
And one needs to stay focused to look after the patient.
In spinal surgery, the patient is particularly vulnerable.
If their spine is all exposed and open at the back, lying face down for 12 hours potentially, that's a very difficult position to resuscitate someone in.
Have you got much in your cell saver to go back to?
Not much in there.
The team is using a blood salvage machine. This collects Chris's own blood, washes it, and then returns it to his body. It should eliminate the need for donor blood.
Oh, fantastic.
But the blood salvage machine can't keep up with demand.
Correct.
Okay.
Got a hematocrit of 19.
19?
19, 19.
That's a little low.
That's a bit low.
That's a bit low, okay.
There's 800 in the sucker, small amount of wash has been used, heavily blood-soaked swabs.
The average human body contains 5 litres of blood.
Oh, crikey, O'Reilly, that is not right at all.
So we are going to need more room at the bottom end, aren't we? Yeah.
Anticipating blood loss is a science, an art, and a challenge. If we didn't manage the replacement of the blood, then after about a litre, they may already be running into very, very serious problems.
We're probably about 1.2, 1.3 litres down.
I think we're bled more than we think, and we need to replace some more volume.
Thank you.
If Chris loses any more blood, he's at risk of organ failure.
OK, so bring 2 units of blood up and 2 FFPs, please.
Khalid makes an urgent request for donor blood.
Remember that for a moment? We'll put that up again a bit later. Put 2 bloods in.
How long do you want to catch up?
Give me
20 minutes?
15, 20 minutes.
20
yeah.
minutes. 20 minutes.
Yeah.
Khalid pauses the operation.
Oh, wait, sweaty work, that bit. All right, OK.
The team will have to wait to see if Chris is strong enough for them to continue surgery.
I have halted operations. It's always a tough decision. The distress it causes can be immense.
It's just his mind set that that's it, I'm going in, I'm having the operation, and I'm going to get better. Oh gosh, it'd be marvellous. Really would. I've waited for so long for something to happen. Just hope and pray that this operation does everything that we are hoping for. He's suffered enough, and enough is enough.
Found the abdominal wall yet, sort of? No, not quite. Under normal circumstances, we wouldn't have had to go so deep.
In Theatre 19, Judy's apron is so large that Sunil and his team are struggling to locate her abdominal wall, the point at which they can safely detach the maximum amount of tissue.
Because Judy's anatomy was so altered with the dragging of this abdominal apron, we found it quite difficult to find the abdominal wall.
I think let's infiltrate the lower incision. We know where we are.
here.
Yeah?
Sunil now wants to start cutting from underneath the apron.
I think that should be it.
But that means lifting a weight of over 30 kilos onto Judy's chest.
Raj, are you okay if we were to lift for a little bit? Be about 15 minutes. If we are causing you any respiratory problem, will you tell us? Whenever you're ready, so just tuck all this in.
The biggest concern was her ventilation. When Mr. Thomas moved the abdomen onto the chest, her airway pressures went really high.
Knife to me, please.
And one for me as well, please. Forceps.
Forceps. Okay.
The worst case scenario would be she's not able to oxygenate her organs, and that can have effect on the heart itself, and it can stop.
We just come out laterally, so to say.
You all right?
Have you?
Yeah.
Judy's heart and lungs are coping with the pressure, but the longer the apron is on her chest, the greater the chance of complications.
Raj, are you all right on your side?
Hemoglobin, everything is fine. Blood pressure is stable. Nothing to worry so far.
Sunil and Suk must work quickly to cut the remaining tissue.
Okay. So that's the belly button there, the long funnel-shaped stalk. I don't think this is reducible, so it's adherent.
In a regular apronectomy, the patient would be able to keep their belly button.
Can I have a stilly scissors, please?
Judy's umbilical stalk has become so distended, it can't be saved.
You'd never see such a thing, but I think in her case, with time, this has happened. Those staples are on the midline.
Only two major obstacles now remain. The large blood vessels from the CT scan that run from Judy's abdomen into her apron.
There's a place in surgery when you run and then when you walk. So this is a place where you need to walk slowly and carefully.
So it's about 7 centimeters lateral to the midline. Can we get the Doppler? Because that big vein is over here.
The Doppler bounces high-frequency sound waves off blood cells, helping Sunil and Suk to locate the veins.
All right.
Here we are.
Yeah, there it is. There it is. Let's deal with the vein now. Come.
Okay. Huge amount of blood, so it will.
Okay. Put a Liger clip on.
The veins run through the apron tissue and must be severed with great care.
If we inadvertently damage one of these vessels, we would need to control the bleeding within seconds.
Yeah.
Another one there.
This is the biggest.
A large bleed could be life-threatening. We're nearly there, aren't we?
Yeah. You want to carry on there? And we'll do the same. I don't know if that's a vein or not. Anyway.
The blood vessels have been safely cut and tied off.
Ties, please.
The team is ready to make the final incisions that will separate the apron from Judy's body.
Having that thing removed from her will change Judy's life in a way that I don't think she knows herself. It's like somebody pressing the reset button. I still have feelings, I suppose. I would love to see her now that thing's removed.
1, 2.
It's quite humbling to have a significant impact on the person you're operating on. But then there's a different dimension to it as well.
Scissors, please.
One of my senior colleagues used to tell me that a surgeon operates, but it is God above who heals.
She's been so far behind.
You can take the apron down.
Yeah. That's it. Goodness me.
Just hold the top.
There's a sense of euphoria almost in theatre because we've all focused together to get rid of this tissue and finally we've removed it.
This is like a sack of, the rice we buy in the...
Because it's not part of Judy anymore, it could be on a film set. It's almost surreal.
It feels a big relief once you have done the physical part of excising and removing the abdominal apron and it's come off. But then the bigger challenge is the patient heals well, that we're able to close the tummy properly and make sure that she doesn't get any wound problems.
That's the vertical dimension and that's the horizontal dimension of the defect.
The large wound in Judy's abdomen will need extensive surgery to repair.
What we need to do is delineate where we're going to suture. Can I have that pen again? I'll just do that for you. So that's the midline there.
Okay.
Layers of thin connective tissue that protect Judy's internal organs and muscles must be carefully stitched together. It's a slow and painstaking task.
Yeah, if you could. So it's Liz, yeah? You just tell her that if she could pick up the kids, please.
Okay.
Thanks a lot.
The team have been in theatre for over 4.5 hours.
I think I should end it off here now. So let's come together, all right? I don't think there's too much tension there. So thank you, everyone.
That's it, so all done. Thank you very much. Thank you.
What's the weight? What's the weight?
How much? I was 28. Yay!
The liquid inside the apron has drained away. When Judy was later weighed, she had lost 47 kilos, 7.5 stone.
The apron weighed the equivalent of a small person, I think.
It's going to be life-changing.
Yeah. Okay, ready, steady, slide.
Judy has so far handled the rigours of surgery, but with the added risks of her size, Raj wants to wake her immediately.
14023.
Nice big deep breath, Judy. All right. Okay, we'll take this out. She can have clots in her legs purely because she's not able to mobilize herself, and also because she's not able to breathe properly immediately after the surgery. She's at high risk of developing chest infection. It's all done. You're just waking up, all right? Remember, you're having an operation. It's all done. Every person is so different when they wake up. Sometimes they do have a good dream, and I've had thumbs up in the past, and sometimes they cry, and sometimes, they can scream and shout as well.
Somebody's at the door! Someone's at the door?
Yeah.
Okay, we'll have a look at that in a minute.
Oh,
Dave, is he on the ward, do you know?
I'm feeling nervous, feeling a little bit frightened. Oh, I really don't know what to expect. Everything's praying that Judy's going to be okay. It's a huge thing and not to be taken lightly. Hello? 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 How are you? Look at you. Yeah, I've been running. Yes, you're going to be.
If anyone asks me whether Judy's apron will return, it sort of sends a cold chill down my spine, because I think we've invested a lot in this. And really, this should not happen again, because it's entirely up to Judy to control her diet.
Hi, so thank you so much for your help.
It's
Really
okay.
obliged.
Very good, very good. Went very well.
Okay. There's some samosas.
We always have samosas when there's a big case.
The thing with samosas is, nobody ever complains. They're all happy with it.
As long as no one else has eaten them by the time the staff finish.
I think we need to let's put another blood in, and then we'll get going.
In Theatre 20, surgery on Chris's spine is about to resume. Khaled has given Chris a blood transfusion and is now confident that he's strong enough to make it through the most dangerous part of surgery.
So what are you going to do now?
Take out part of L5.
L5.
And make him bleed. This is the bit we expect to bleed.
Oh, okay. Yeah.
Not that first bit.
The L5 vertebra is the lowest moving vertebra in the spinal column. Supporting the weight of the upper body, it's where Chris's spine is most out of line. Removing a 30-degree wedge of bone at the L5 will break his spine. But this dramatic act is the key to reshaping Chris's spinal column.
Someone was to say that back to me, that I'm going to break your spine and reset it, it would be pretty far-fetched and out there, and would be hard to believe. But these are things that we can do.
Once we start cutting the bone at the front, the spine will get weaker, and there's a risk of it obviously fracturing through.
Damage to the spinal cord at this point could result in paralysis from the waist down.
Mallet, please.
Delicate adjustment.
Coventry screwdriver. People would think the spinal surgery is very delicate, microsurgery, don't move, you might catch a nerve. And people would be sort of slightly surprised when we get hammers and chisels out.
This is a brutal assault on the body. Things can go wrong despite best precautions. We might do the best surgery technically and everything's gone well, but still the patient wakes up with some problem.
I always think that works a bit like a pneumatic drill.
And this is the nature of what we do, and it took a while for me as a junior neurosurgical trainee to get my head around that. But I got to a point, I think, over the years of being able to put that into a compartment in my brain somewhere and not let it overtake my decision-making process.
There's bits of bone in your bowl that we can keep.
Fragments of bone removed from the vertebra are kept as they'll be needed later in the operation.
So use two of these in parallel, don't we? And then we can control the way that we close that gap by compressing together, sorry.
So Lucas,
Navin and Mel attach clamps to the vertebrae either side of the wedge they've removed. The clamps will be gradually tightened, closing the gap and slowly realigning Chris's spine into a more natural curved shape, so he will be able to stand up straight again.
Want to compress a bit more on my side.
It needs more compressed on your side actually as well, just asymmetrically.
Little by little, Navin and Mel are reshaping Chris's spine.
I'm probably not one to show stress. I guess psychologists say that's a bad thing. You're meant to express your stress, aren't you, in some way, shape or form, to have less of an impact on your own body. And maybe I'll see that in years to come.
So just check how far we are at the front. Can we have X-ray in? See that? So that's your side there. I think we could probably go a bit more at the front there.
We can see that the gap down there has closed.
I mean, that's absolutely spot on there, isn't it?
Yeah, that's not so bad. Okay, that's as best as we're going to get it, I think.
Before final adjustments to the spine can be made, the team must build the remaining fixtures that will secure the spine in its new position. It's a crucial part of the operation. The titanium rods will have to be shaped with precision so that they fix into every single screw head in Chris's realigned spine.
So just to confirm, 6mm titanium rod.
Okay, that's good. Yeah, just add a bit more curve at the top end. Yeah.
Usually, the surgeons have to rely on trial and error to shape the rods to the contours of their patient's newly curved spine. But the Queen Elizabeth is using Chris's surgery to test the latest computer technology.
Into the screw head is actually the computer's registering its relative position.
Yeah, go for it.
An infrared camera with 5 lenses maps the exact location of each screw head. A computer then calculates the contour of each rod.
Yeah, just made the lordosis in the lumbar spine, and then the top bit will come back to the rod.
You see, you've got your curve there.
Yeah.
The computer has generated a design that the team can use to create perfectly shaped rods.
So you worry about angles, aren't you?
For this guy, all about the angles.
Number
4.
56.
56.
The accuracy of the technology increases the chances of a successful outcome to Chris's operation.
Changes what we can do in surgery. It shows exactly what it's going to be like when he stands up. You can be confident that we've fixed it in such a way that this should hold, then that's a game changer.
Okay, let's try that and see.
Moment of truth.
This innovative technology should also deliver faster results, cutting expensive theatre time and reducing risks to the patient from long periods under anaesthetic.
That was a good rod bender.
Awesome, look. Amazing.
Okay, good.
If I can introduce technology that's going to be a benefit, that's for me, that's the ultimate aim. And what we might offer now might not be what we offer in 20, 30 years' time.
Once the rods have been bent into shape and fixed to the screw heads,
Can I have a blocker?
Navin and Mel can tighten the screws, making the final crucial adjustments to the shape of Chris's spine.
The most dangerous part of the operation is when we put the rods onto the screws, tighten them down, and that changes the shape of the spine. You can go for too much correction, you can try and straighten it too much. Sometimes it can leave patients worse off. The old phrase, the enemy of good is perfection, applies brilliantly to spinal surgery.
Can the table go up, please?
Don't go for an extra 5 or 10%. You've got what you need, get out.
Osteotome.
The screws and rods are susceptible to metal fatigue.
Osteotome. And a hammer.
To strengthen Chris's rebuilt spine and last him into old age, Navin and Mel will also do a bone graft.
Let's have the intratech.
Mel takes advantage of the body's natural healing process by deliberately distressing the vertebrae to stimulate new bone growth around the metalwork.
If you think about it, your arm bone is biologically relatively inactive until you break it. Because you disrupt the surface of the bone, and the bone sort of switches on. And we're doing exactly the same with this bone. We're roughening the surface to switch the bone on. Okay. We got the rest of that bone that we took out.
Fragments of the removed vertebrae are also packed around the spine and metalwork. Over the coming months, these fragments will grow and fuse together, creating one solid structure of bone and titanium. Chris won't be able to bend his back again. With time, he should be able to stand and walk upright with less pain.
Can I have the needles thingy me, Bob?
Supposed to renew me, Philip.
After more than 8 hours of surgery, all that's left to do is stitch Chris up.
Kelly, what are his numbers looking like?
They're better. There's possibility he might need a bit more blood.
How many has he had now?
He's had 10 units of blood.
10, oh shit.
Probably bled more than the average, I think.
He definitely bled more than me.
I feel like I've worked hard.
You have, Khaled, and it's much appreciated.
This case was at the top end of challenging in terms of the surgical exposure that was taking place. So got anything more like this lined up in the near future?
Oh, yes.
I'll book my leave. And I was outnumbered. There's 2 surgeons and 1 anaesthetist.
Oh dear, what a day. It's a tough one. You feel like having a drink at the end of the day, and you've earned it because it is a tiring day. So you can actually see here he's got a curve in his lower back. So that suggests that we've done something to give him a curve back.
I hope so after all that.
We feel relief that things have gone well. Feel that we've achieved the best that we can for Chris. And then your stress levels drop off a bit because what subsequently happens after that is out of your control.
Am I excused now if I've done everything I need to do? Thank you. Coffee. Food.
It's such a privilege working inside the body. It really is. Don't ever take the trust the patient puts in you for granted. They put their quality of life in your hands.
Six weeks after her operation, Judy is back at the Queen Elizabeth for a consultation with Sunil.
Mr. Thomas is on his way.
Okay.
So we're just going to
No problem.
Hi. How are you keeping?
Yeah, I'm fine.
Good.
I'm feeling a lot better.
Up and about? And...
I'm up and about and then doing my exercises and going out for a little walk outside.
In the future, Judy would be able to manage a lot of things on her own. And I think in terms of providing care for this person from the district nurses, maintaining her hygiene, moving her around, getting a wheelchair or getting an ambulance, that is more cost to the NHS.
I couldn't ask for a better surgeon.
Okay.
Thank you very much, sir.
So I think the government has been helped financially with her operation.
To go from there to here, it's just amazing. I feel more happy myself. I feel like a new woman. I just feel like, honestly, a new woman.
The operation has been deemed such a success that Judy has had further funding approved for a gastric bypass, a procedure that was previously impossible with an apron of her size.
I'm sure this is a new beginning for Judy in terms of self-esteem. And I'm really very privileged that I was able to be a part of this process of helping to improve this patient's quality of life.
Eight weeks after his surgery, Chris is back to meet with Navin.
Right, nice to see you again.
Yes, yes.
Hi, how are you? You okay?
I'm not too bad, thank you.
Okay, you grab a seat there for me. Right, do you want to come and walk over here? And you're using a frame at the moment?
I've just moved to a stick.
Oh, just a stick,
I'm going
okay.
around the house,
Yeah.
holding onto things
Okay.
since yesterday afternoon.
Yeah. Everyone has their own goals and what they want to achieve in life. And I think in Chris's case, if you didn't offer surgery, then his options are very limited. Okay, so see how you're balanced there?
Yes.
Yeah, in terms of your head being over your pelvis, this is much improved to what you were before.
Much.
In terms of the parameters that for what we've corrected, it's spot on. It's what we wanted to achieve. But persevere, it will be hard work. And think about the long game, because that's where we need to be reviewing things at 18 months, 12 to 18 months down the line here.
Thank you very much.
No problem. Nice to see you again, Chris.
Thank you.
Okay. I'll put you across, don't worry.
Oh, thank you so
Yeah,
much.
no problem, that's okay. I think it was the right decision to offer Chris surgery. He's only just started his rehabilitation process, and that's going to be a long road for him. I'm optimistic that he's able to stand upright and less pain. I have seen a change in his hope.
I feel very optimistic about the future. He's done his part of the job. He's straightened me up and squared me off, shall we say. So now it's just about me doing everything I can.
Chris is making a mess with all the furniture, bang, crash, wallow. And I'm being the waitress. Unpaid, by the way. But saying that, this week he has booked up to make both of us realise you're only here for a short time. So make the most of it. And we're going to. First thing, once he's really sorted, is a nice holiday. Don't know where yet, but we'll find somewhere.
I've come to collect you for your surgery, is that okay?
Right. In the UK, some 3 million major operations are carried out every year.
Nice big deep breath. We'll look after you, don't worry.
Only the country's top surgeons are skilled enough to take on the most critical cases.
Cameron, you all right?
Just take a couple of deep breaths.
If you're going to make a hole in someone, you better be sure what you're going to do.
Should we go for it? Right.
They're using pioneering techniques to treat conditions that used to kill.
A few years ago, these operations were felt to be too big or too dangerous.
But pushing the boundaries of modern medicine comes with great risk.
Just keep quiet for a second, please. If I move the blade too much, she's going to wake up unable to breathe.
Life is precious. It can vanish in a heartbeat.
Whoa!
You need to keep your head. Hold this. The heart is empty. We haven't got any volume at the top. If you panic, the patient can bleed to death.
The surgeons bear the ultimate responsibility.
I need it ASAP. I can't wait for this.
I'm not infallible. Failure is absolutely possible.
We are a team, but there's one person's name at the top of the bed.
Bloody hell.
This is what really happens behind the closed doors of their operating theatres.
This is a battle, us versus the Grim Reaper. And we're not going to lose.
I'd walk to and from work, and it's great because it gives you time to think. You're so in the zone when you're operating that, the day just goes.
Tim Martin is a consultant maxillofacial surgeon at the Queen Elizabeth Hospital, Birmingham.
I was never a high performer at school. On reflection, I can't quite believe that I'm in a position where I'm doing the type of surgery I do now.
He specialises in tackling complex cases affecting the face and jaw.
As a surgical team, we're lucky that we get these challenges. But the difficulty with some of these big cases is that we don't have certainty. Sometimes there just isn't that information out there.
Today, Tim's preparing to operate on a patient with a condition he's never treated before.
And there is bone loss, but it's definitely progressive.
9 months ago, a woman whose face was rapidly being consumed from the inside was referred to Tim.
If you look at the most recent CT, she's got this big soft tissue mass here and a defect in the maxilla and a little bit of breach at the back.
Her upper jawbone and eye socket were being eaten away by disease, and the surrounding muscle and tissue was becoming inflamed and tough.
It just destroyed things. My initial assumption was, oh my word, this is going to be a cancer. But when the biopsy came back as inflammation, I very quickly realised that we've got a disease that we don't really understand.
Tim asked the team to investigate further to try to establish what was wrong.
The pathologist was saying to me, well, leave it with me, I'll do some more tests. And that's when he comes back and says, well, actually, this is looking like tumour-factive fibroinflammatory disease, which is really unusual.
It's a disease that causes the body's immune system to attack bone and flesh. And it's so rare that only a handful of surgeons in the world have ever attempted to operate on patients with this condition.
There's no real information about the natural history of this, the mortality of this. I'm nervous, and I think we're all a bit nervous, aren't we?
Tim's patient is 49-year-old former police officer, Loretta.
The first thing you're aware of when you wake up in the morning is that your mouth has been fused. It's like somebody's sewn your mouth shut. It just feels like this monster.
Not long ago, she had a busy, active life. Now she's in agonising pain and almost housebound.
Certainly didn't see it coming. Never saw this one coming. Particularly with something so rare.
It's difficult to watch your wife suffer so much, but you have no option. You can only be there and try and support them.
Loretta has undergone months of chemotherapy and steroids in an attempt to combat the disease, without success. The condition is continuing to destroy the tissue and bone in her jaw.
Just common sense suggested that actually we've got to get rid of all of this. But you kind of feel almost backed into a corner in that I really don't want to operate on Loretta, but we know that, there aren't many options left. Loretta?
The problem for Tim is that there is no medical protocol for how to proceed.
How's your mouth opening now? That's
worse than ever. Yeah,
So your
and
mouth
almost now
opening's the
that it's almost like it's wired shut now.
Yeah.
That is me trying to force it open.
Yeah.
So it's liquid diet only, and it
Okay.
has been now for about 6 weeks.
Okay.
Yeah, and it's worrying. It's
Yeah.
worrying now. It's really getting to the stage where we kind of feel like we've thrown everything in the kitchen sink.
Yeah.
Pretty much.
I agree.
At it.
We're in a position with you now where surgery's what we're hanging a hat on. But in your case, we haven't got any experience, but no one has. Coming to conclusions for treatment with Loretta is really rather uncomfortable. We're going to remove that left upper jaw, and then it goes back a couple of inches deep to my finger here.
Okay, where there's a recess.
Yeah, it is difficult because it's out of the back of the jaw, and there are big veins there, and it is getting into an area which is, in inverted commas, that horrible phrase that surgeons use, kind of tiger country, but it is. My take on tiger country, it's an area where you've got to be particularly careful, where there are vital bits of anatomy that could be damaged and complications can rapidly spiral out of control. Clearly you're nervous about this, and I think I've let you know we're nervous about this as well.
What's comforting is that we've always seemed to have been on the same page and almost come to the same decisions at around the same time.
Yeah.
There's nobody I'd rather be under the care of. It takes a special person to do what these people do.
I'm shitting bricks. I really am shitting bricks. No, I'm nervous about this one. Yeah.
Where are we going?
64-year-old Nora is also facing surgery to treat an extremely rare disease. She's come to the QE with her daughter, Helen.
Nora? Yeah, hello there, my name's Ellen. Hello. You'll be going into surgery in 24, I'll take you there.
Nora has an unusual cancerous tumour called a clival chordoma, located at the junction of the brain and spine. It was only discovered by chance after a recent family outing.
Don't bang your head.
I went with my son and 2 grandchildren, and I went for a ride on one of the fairground rides. It was one of those rides that lifts you up in the air and then drops you down very quickly and stops just before it hits the ground. And when it stopped, I felt a really bad pain in my neck.
A scan revealed that some of the bones in Nora's neck had been fractured because they had been weakened by a tumour near the base of her skull. The bulk of Nora's tumour lies in front of her brainstem. This is an area at the top of the spinal cord which controls the flow of messages between the rest of the brain and the body. The growth is surrounded by important blood vessels and the nerves that allow Nora to swallow and breathe.
If I don't have anything done, the tumour will just keep on growing. So I've got to do something. You just don't know what's going on inside you, do you?
Nora has already had an operation to stabilise the bones in her neck. Now, she is pinning her hopes on neurosurgeon Alex Paluzzi. But the position of the tumour makes removing it one of the most challenging procedures Alex has ever attempted.
I think there's always a time in a surgeon's career when they come across something they've never seen before, and you never know what's going to happen.
There's a risk that operating so close to the brainstem could cause Nora to suffer a stroke or leave her disabled. So Alex has brought in ear, nose and throat specialist Shaz Ahmed to help plan the surgery.
So you get the 2 main vessels that bring blood to the hemispheres of the brain. It's like the 2 snakes guarding the treasure, and you've got the tumour there in between.
This is certainly the most complex skull-based pathology that I have been involved in my career.
I would tend to agree with that. You make a lot of calculations and you do think about different scenarios. Are we going to make the patient worse? How many operations are we going to do?
Between them, Alex and Shaz have amassed hundreds of operating hours on skull-based tumours. And at the Queen Elizabeth, they have perfected a technique which involves operating through the nose.
When the 2 of us come through the nose, then we'll be operating through a very narrow, confined space.
It's impossible to tell from the scan if the tumour will be soft and easy to remove, or fibrous and tough.
We might find that it's so fibrous that it's very difficult to pull out without causing damage to important structures. Things can go sort of pear-shaped very quickly.
I'm scared and I'm worried, but I know the best doctors are doing it and it's the best chance for her.
In these circumstances, if we didn't do the operation, within a matter of probably a few months, it is likely that Nora would die. Just a few details just before we take you down to theatre. I know you signed a consent form a few weeks ago.
It's hard to see your mum worried, but she's brave.
My biggest fear is that something goes wrong and I end up not able to care for myself.
Okay, thank you.
My dad had a stroke and I saw what it did to him. It just wrecked him, really. If it goes wrong, well, the chance you have to take. I haven't really got any choice.
It's just the uncertainty of how she's going to be when she comes back, I think. There's so many things that could go wrong.
The team assembling for Nora's procedure anticipate having to operate for at least 7 hours in Theatre 21.
Okay, the trick when you're going off to sleep is just to think of something nice, somewhere else you'd rather be. Nice holiday, somewhere hot.
Everyone ready? Set and slide. That's great. Okay.
To access the tumour deep inside Nora's head without making incisions in her face, Alex and Shaz will navigate through her nostrils. First, they need to clear a pathway via her nose and sinus to reach the brainstem, where the tumour is growing.
Once you're all set up, to have the room lights off, please.
Yep. That's lovely.
They're using a specially designed endoscopic camera. Shaz makes the initial approach using a tiny endoscopic scalpel.
Can I have suction, please? A procedure like Nora's, we try not to become daunted by it. It's why we're here. This is why I became a skull-based surgeon.
In order to reach the tumour, Shaz needs to tunnel through a bony structure called a turbinate within the nasal passage. Alex then removes the fragments of bone and enlarges the path Shaz has made.
The challenge is working in a small space. In a way, it's a little bit like dancing together. You don't want to step on each other's toes. Jackie, guys, I need a little bit of concentration.
Okay, can the irrigation go up, please?
Millimetre by millimetre, Shaz is drilling through the bone that's blocking his route to the tumour.
We're going many centimetres deeper than the usual place where the back of the nose is. 30. We know from the scan that the tumour comes right up.
After almost an hour of tunnelling, Shaz gets glimpses of the tumour on his monitor.
We're right onto it already. This is tumour, yeah? That's why it's there's no bone here.
Shaz has reached the cancer next to Nora's brainstem. Only now will the surgeons find out whether or not its texture will make it easy to remove.
So I think there's parts of it which are quite soft.
Yeah.
Have a feel, see what you think.
Is it suckable at all?
Up close, the tumour is far more fibrous.
Very vascular, very tough. The nature of the beast is completely different. When you try and gently tease it out, you don't know what it is going to be stuck to. Either it's a tumour that wants to come out or it isn't. And this isn't. We're not going to achieve much here.
After almost an hour of painstaking efforts, Alex is struggling to make progress.
There are times during difficult operations where you reach the brick wall. I'm thinking whether we should actually just stop and...
Do you want me to work on the lower bit for a little while?
Yeah, why don't you?
Shaz offers to tackle the tumour from a different angle.
I have the through biter next.
But as the tumour is packed with blood vessels, it's hard to distinguish from the surrounding tissue. Cutting it out is delicate work.
What we don't want to be doing is pulling the tumour and pulling nerves and brain structures underneath.
But Shaz's new line of attack is helping him make inroads into the tumour.
This is soft tissue, so I think this could be it here.
When somebody thinks that we cannot do anything further because of the way you've been approaching things, then you got somebody who thinks in a slightly different way. That's the beauty of working together in these situations. Nice one, Shaz.
Could have a Mexican wave then.
When tackling a tumour, does luck come into it? Well, that's what makes surgery really challenging.
After 45 minutes, Shaz has successfully removed the bulk of the tumour. He and Alex have now reached the lining of the brain, called the dura.
The dura is very diseased.
The dura is a protective membrane which surrounds the brain and spinal cord. It seems that Nora's condition has also spread into this vital layer.
Removing the dura in an area in the skull base is always a big step. It's not taken lightly. There is a risk of stroke, of very serious disability. The ultimate risk is the risk of death.
It's up to Alex to decide what course of action to take.
So I think I would just take the dura out.
Okay.
Yep. You okay with that?
Yep, let's go for it.
Very few surgeons operate on the dura so close to the brainstem.
So we're looking at the front part of the brainstem. It's not a view you see every day. It's like looking at somebody's soul.
Alex has cut out a patch of diseased dura the size of a postage stamp.
One of the most difficult things in any operation is to know exactly when to stop. There's nobody there telling you. You're ultimately the judge of that. I would just stop there.
Close?
Yeah.
If the team try to take more tumour, they run the risk of leaving Nora disabled.
It's about having a patient achieve the goals that they want to achieve, as well as the goals that you want to achieve, and trying to somehow meet in the middle.
I think we got about 70–80% of the tumour out, which was a great result.
It went well for you, it went well for Shaz, it went well for the patient.
Well, let's wait until she wakes up.
She'll be all right.
It's taken them nearly 10 hours to remove as much cancerous tissue as possible and to repair the dura.
Unfortunately, we left a small portion of the tumour, and that was difficult to reach through the nose. I've done as much as I can safely do, and no matter how disappointing it is, you have to stop.
Could well take a while for her to come round.
I have removed about 80% of the tumour, but how is that 20% going to behave? How am I going to tackle that 20%?
home for the next 2 weeks.
It's the morning of former police officer Loretta's operation. She's returning to the Queen Elizabeth with her mother, sister and husband.
I've never been in hospital for an operation before, so it's the fear of the unknown.
It's the first time on record any surgeon in the UK has attempted to operate on the rare condition she's suffering from. A huge undertaking for consultant Tim. So his friend and colleague Sat Palmer will be helping him.
I probably communicate with Sat arguably more than Sarah, my wife, and we're forever taking the mickey out of each other.
Tim and I have been working together for 15 years. He's one of my best friends. My cut's going to be like that.
Yeah.
And then you're only able to have the courage to take on a lot of the big cases if you've got close colleagues that you totally trust.
Loretta, my name's Fleur. We're going to check you in. We're going to go into Bayford and get a trolley ready for you.
As all other treatments have failed to stop the spread of the rare condition destroying her face, surgery is Loretta's last resort.
I'm terrified that potentially it could be the last time. Say goodbye to my family.
It'll be all right. To bring your wife to hospital, and there is always that small chance. You don't know whether it's you're going to see him again.
Did the royal wave.
There's so much I want to do still. I'm too young to die. You really do feel helpless, and your life literally is in your surgeon's hands, and they become your hero and your god.
Loretta's operation is expected to last at least 10 hours in Theatre 8.
I hope you had a better night's sleep last night than I did.
I did actually. I slept quite well actually. I woke up at about 4, which is, and then worried a little bit and then went back to sleep. With Loretta, I've had 6 months to get to know her. And, she is a friend, and I do talk to her on my mobile. She's got my mobile, I speak to her. So that just adds on the pressure a bit more.
That's all right. You have a good sleep for us now, Loretta. OK, we'll take care of you now, OK? All right, all done. On 3. 1, 2, 3.
As so little is known about Loretta's condition, it's been difficult for Tim to be sure the risks of such major surgery are worth taking.
You're all right there, Tim?
Ish.
Okay.
Part of you thinks, are we doing the right thing? The problem for Loretta is that we're all in the dark. We don't know what the future's going to hold. Dry swab marker pen.
Tim will focus on removing the diseased jawbone and muscle from Loretta's skull, while Sat will take bone from her hip to create a bespoke graft that will become Loretta's new jaw. The graft will include bone, muscle, and 2 blood vessels. It needs to fit perfectly into the diseased area cut out by Tim. Then the graft's blood vessels will have to be connected to the artery and vein in Loretta's neck before the team can reconstruct her face. First, Tim's cutting through the diseased muscle on the left of Loretta's face to access the bone.
That's the jug. But it's not separating from the jug as nicely as you'd hope for, is it? Definitely abnormal. All the muscles attached to the bone have all become scarred and thickened and inflamed. So she cannot physically open her mouth, and it just makes surgery really difficult. Open wide, squeeze, 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 squeeze. Push, let go. Bloody hell. And this is where it's all disease, isn't it? Yeah, this is definitely abnormal there. Yeah, I'm comfortable that we're doing the right thing.
While Tim focuses on cutting out the inflamed tissue, Sat has started to expose Loretta's hip bone, ready to make the graft for her face.
Can I have a screw, please? A 12mm screw.
For accuracy, he's using a 3D cutting guide, which precisely replicates the diseased section they're removing from Loretta's upper jaw. It's only possible thanks to pioneering 3D computer modelling methods.
Sometimes we have really unique cases come in, and it's quite difficult because you've never designed for something like that, which is quite challenging.
Heather Goodrum is the first 3D biomedical technician in the UK's National Health Service.
So this is Loretta. This is the pelvic bone. So we've created a cutting guide which they can place onto the bone, and it will sit perfectly because it's been created on the patient CT scan. They can cut round that using it like a stencil.
After she's mapped out each guide on the computer, Heather's designs emerge from the 3D printer in resin.
So this is the guide that sits on the pelvis, and once that's cut, it will come up to her face.
Finally, any remaining residue is filed away, leaving only the bespoke model.
It just literally clicks into place. Very accurate.
By reducing time-consuming guesswork in theatre, 3D guides save around £20,000 per operation.
Science, art and technology all combined into one.
Now 3.5 hours into the operation, Sat relies on the cutting guide to extract exactly the right amount of bone from Loretta's hip.
So I need to take a little bit more of this edge. So it generally looks really good.
Once the graft is prepared, Sat leaves it connected to the blood supply until they're ready for it to be moved to Loretta's face. But cutting out the diseased area of muscle and bone is proving difficult.
God, it's all just so tight. God, no wonder she couldn't open her mouth.
These muscles that should have been nice and soft and pliable seem just like really kind of tanned, hard leather.
Still, God, blimey. That is just fixed, isn't it?
Prior to getting in here, I was rather hoping that we could open the jaw to get in there, because we need to get deep down. And that's just not the case. Her jaw's just not budging.
So am I, mate, but fucking hell, it's hard.
If the muscle and soft tissues aren't going to budge, then we're going to have to break the jaw.
To reach the area of bone and muscle he needs to remove, Tim's only option is to slice right through Loretta's jawbone.
Can I have a saw, please?
Breaking the jaw or dividing the jaw at the back here is something that we do not infrequently. We know that there's a sizable artery that can cause trouble, but you can normally control it.
But with the abnormal tissue hardened around it, Loretta's artery has been distorted.
Not what we want. Oh, bollocks.
The saw has cut the artery. I've got to control this, but I know that this isn't going to be easy.
Toughen up, please.
Oh, sorry.
If she loses more than a litre of blood, he may have to abort the operation.
If that bleed gets out of control, we're going to be a bit stuffed. All hands on deck. May I have another Langenbeck, please?
When things start going wrong, everything just kind of zooms in onto the problem. And for me, I lose all sense of what's happening around me.
All right, Tim. It's all a bit fraught at now. I'm going to need some hands in a minute.
There's no point freezing. You've got to do something.
Tim can't prise Loretta's jaw apart in order to reach in and clamp the artery.
That is just horrible.
To stem the bleeding, he sticks his finger in the hole.
Sucker's blocked, everyone.
We need, Deb, can we get two suckers, please, quickly?
The moment he asks to keep changing the suckers is often an indication to me that he's stressed.
The artery is so hardened by disease, Tim is struggling to clamp it and stop the bleed.
I'm just thinking now about not doing any more harm than we already have.
Mentally, we all have a picture of how you want the whole surgery to go. And if it doesn't go as well as you want it to, there are always seeds of doubt that appear as to whether you've made the right decision to operate.
You can see the hole there.
Sam, don't move, whatever. Thank you.
That looks like your artery underneath.
By taking a route through the top of the jaw, they eventually succeed in clamping the artery, stopping the bleeding.
Thank you very much, everyone. That's lovely. Perfect.
If SAT hadn't been there, it would have been a lot harder. It's about the psychological support in these bigger cases where you're pushing the boundaries of your own surgical ability.
Are you guys all right?
I wasn't. I don't normally get stressed, but this one's really made me stressed. What was going through my mind was, should we be thinking of bailing out? By proceeding, are we going to make things worse? I know that we've got to go deeper still. You know, if this occurs deeper down, we're going to be in a bit of a pickle. But in actual fact, we've gone past the point of no return. Well, we've just got to crack on.
This isn't an indicator of what's to come.
Following surgery to remove an unusual tumour through her nose, Nora's been closely monitored. Although 80% of her cancer was cut out from around her brainstem, her latest scan shows her remaining tumour is growing aggressively.
When I saw the MRI scan, I was quite shocked because that small lump that we couldn't reach from the nose had grown dramatically. It was initially the size of a small hazelnut, and it became the size of a mandarin.
I'll have one on each cheek.
Love the kids.
Thank you. It's just going to keep growing and then it might do more damage. It's a bit scary, really.
Because the tumour is so close to Nora's brainstem, she's at high risk of suffering a fatal stroke.
So this is a very active tumour. So we have a limited window of opportunity now.
Just feels bad for Mum, really. It's just every time she seems to get back on her feet, it's like it starts again. But hopefully this one will get the rest of what's left and can start to look forward a bit more. I think I'm coming towards the end of it now. You're quite frightened because you don't know what's going to happen and you don't know if you're going to survive.
This might feel a bit cold and achy going up the arm. A couple of nice deep breaths. We'll see you when it's all done.
The remnants of tumour that couldn't be reached via Nora's nose are rapidly regrowing at the back of her brainstem. This time, Alex will need to cut a window in her skull behind the ear before pulling back her brain to access the tumour. He'll have to navigate the nerves for breathing, swallowing and speaking, which all lie in his path.
It is one of the most challenging operations you do in neurosurgery, where you're pushing the limits of your capabilities. You don't know whether you're going to be able to remove that tumour. Even the slightest movement can cause a permanent damage.
To avoid damaging any of these nerves, Alex has enlisted the help of consultant ear, nose and throat specialist, Richard Irving. An expert in a technique called nerve monitoring, he inserts recording needles into her tongue, allowing him to monitor 12 vital nerves that relay information from the brain.
This one here, and that's number 11.
Each recording needle will trigger an alarm if Alex comes too close.
We all okay to start? Yeah. This is the previous incision, so we're going to reopen here. It's good to approach a second stage or a third stage procedure with a white canvas. You don't want the bias from the previous procedure to interfere with your decision making too much. So we should get down to the tumour quite, hopefully quite nicely. A bad experience shouldn't prevent you from trying again. Otherwise, we would never do anything. But at the same time, you obviously want to be cautious. Okay, can I please? I have the RPMs up to 75,000, please.
Alex drills through Nora's skull to create the window to access the underside of her brain.
And now I've taken out quite a generous sort of bone window. So the next step is to open the dura. It will allow us to sort of retract the brain, hopefully without causing any damage.
He carefully draws back the brain to reveal the tumour beneath, nestled around the brainstem.
Well, I like to use the analogy with food. The tumour grew to the size of a meatball, and essentially the cranial nerves are like spaghetti in front of the meatball. The name of the game today is trying to eat the meatball without breaking the spaghetti and without spilling any sauce. Can we have the stimulator and the volume up now?
Volume up, please, on the stimulator.
Now Alex has gained access, he will be relying on the beep of the monitor to help him navigate the nerves.
Facial.
Anything now?
Yeah, that's vagus and glossopharyngeal. Nothing.
It's taken 90 minutes to isolate the nerves. Now Alex is ready to attack the tumour.
Being careful not to damage those nerves. When we face a case like Nora's, and we know that there's a huge degree of uncertainty about the beast we're dealing with, put yourself together and you go through a checklist of things that you can do. Just going to cut through the tumour, right in between the nerves. If I move the blade too much, I'm going to sever one of those nerves, which means she's going to wake up with unable to swallow or to breathe. Now working blindly behind the lower cranial nerves. Oh, it's a nasty tumour. Horrible tumour.
Using a sucker, Alex must remove the tumour, one tiny piece at a time.
There's a limit to how comfortable you can be trying to minimize any movement at the tip of your fingers. After a few hours, you realize that your shoulders tend to tense up. It's important to maintain that focus throughout the operation. Even the slightest movement or lapse in your concentration can spell disaster. Okay, so we were very close to facial nerve now. We haven't actually seen it yet. I need to be very careful. Whoa! What nerve is that?
number
Well,
6.
tell us the nerve keeps firing.
The alarm means that Alex is hitting Nora's facial nerve. There is a risk he is causing damage.
Unfortunately, the only way to get down there is to stretch those fibers, which is not ideal, but there's no way around, really. We know that the cranial nerves are plastered on top of the tumour. It's very, very challenging when you're dealing with a fibrous tumour, something that is very difficult to pull out. Facial nerve was stuck to the tumour. There is a certain pressure you have to put onto those nerves. It's very difficult.
Alex manages to remove more of the tumour without snapping the nerve which controls Nora's facial expressions.
So I'm just dissecting the tumour from the brainstem now.
At last he's deep enough to work on the area of tumour, right alongside her brainstem.
Seems to have come away quite nicely there.
I wouldn't say nicely. So I think we call it a day. Can we keep the microscope sterile?
Yep.
After almost 7 hours of operating, Alex hasn't been able to remove the entire tumour, but he has taken 95%.
I reached a situation where am I going to stop here or can I make things even better? Now it's very difficult to draw that line.
Going well, Alex?
Yes and no.
Okay.
Although the operation has gone largely to plan, the team are concerned it may have caused permanent damage to Nora's cranial nerves.
See how she wakes up now. We need to know what she's like straight away.
It's good to see respiratory effort, but really we want to see some swallowing and some coughing at this point. And there's not much of that going on.
One of the most anxious moments of being a neurosurgeon is towards the end of an operation. And you got that 20 minutes when you ask yourself, is this patient going to wake up? And if they're going to wake up, are they going to be okay?
Bit of a swallow. Definitely swallowing.
Okay, well, that's quite reassuring.
Yeah, but no real cough.
Okay. I hope it's a temporary thing.
Open your eyes, Nora. That's it, well done. Listen, I'd like you to give me a little gentle cough.
Yeah, excellent. The best moment of the day is actually when you finish an operation and your patient wakes up. Excellent. And all of a sudden, sort of your muscles become like jelly and you realize how tense you've been. Nora, it's Mr. Paluzzi here. So everything went okay? You managed to remove most of it, okay? Okay.
While many of the routine operations at the QE have been completed, Tim and Sat are only halfway through Loretta's procedure in Theatre 8.
So that's lovely. Okay, I've got the saw.
After 5 hours of surgery, they've reached the point when the hip bone graft is about to be plumbed into Loretta's face. To keep the bone and muscle alive, its artery and vein will be attached to another artery and vein in Loretta's neck. But first, Tim must extract the diseased section of Loretta's jawbone.
Pterygoid chisel.
And a mallet.
Every minute. Cheers, mate.
Tim's sawn through the bone and is about to prise it out.
Nearly there.
Okay.
The diseased bone is removed in one piece.
I think I just have a feel around, so tell me what you think. Clearance-wise, I don't think I could do much more.
No, agreed. I think the most stressful bit is actually once the abnormal tissue has been removed and you see the hole. And then you suddenly think, we've got to put this back together.
The added complication is that once the hip bone graft is removed from the body, it has less than an hour to live.
You only detach the muscle and bone once you're absolutely ready, because during that time, it's got no blood supply. So there is a pressure to get it done as quickly as possible.
It's time for Tim to position the graft into the hole in Loretta's face.
Can you just gently hold that? Scissors, please. Jameson's. So, let's see if we can get this thing to fit. If we just let everything go, yeah, that's beautiful. That's bang on. You've done one of the goals that you've set out to achieve. So there is an element of relief. Woohoo! Okay, can we reel the microscope in, thanks?
Now Tim and Sat must face the painstaking task of plumbing in the graft's blood supply.
What do you want to do? Artery or vein?
You've been very kind to me today,
Right.
so whichever you want.
do the artery.
Okay. Can I zoom in?
Rejoining the ends of arteries just 4 millimeters wide is a test of technique.
You truly are stitching with stitches that are thinner than a hair. It's a bit temperamental, this artery.
Tim manages to stitch the two ends together. Next, he needs to see whether blood can flow through.
The problem we've got with Loretta is the blood vessels in the neck are involved with this disease. And so the real worry here is, are these vessels going to flow? I've got the clamp off there and it's just not flowing. Why the fuck isn't that flowing? We might have to look at the artery again.
Okay. Tim, why don't we take it fully down again and then trim it back?
The artery in Loretta's neck has been damaged by the disease, causing Tim's connection to fail. They need to unpick all the stitches and trim the vessel back. Only then can they attempt to stitch it to the graft's artery again.
You can just get that shit out of it. Can you pull it up at all or not? Or are you pulling?
I will do. Once I'll let this go and then I'll pull it up.
Once it's finally connected, the blood should start to flow down the artery into the bone graft.
Thank you, that's perfect. You probably let go, Sat. I think it may be strong enough.
With the vessel reconnected, it's time to test the flow again.
You're waiting for this blood to flow through your joint. So there's a lot at stake. And you begin to think, well, my word, if this doesn't work, we've really got to start coming up with a solution.
Sluggish.
It's going to be tentative, little bugger, though.
That's starting.
Fucking, it took a little while, though, didn't it? Did you see? Fucking hell.
Have you found flow?
Yeah.
Hold on.
They look for signs of bleeding as confirmation that the graft has a function in blood supply.
Yeah. Lovely. So the bone's bleeding up there.
And the muscle is bleeding at the back end.
Sorry for being so fucking nervous. I think whenever you've done a big procedure like this, there's this big adrenaline rush. I mean, I still get excited by surgery. I think it'd be a very sad day when surgery doesn't excite me. We've done as much as we can with the disease. Clearance-wise, there's no way we could have done better than that. I'll tell you something, I've not worried so much.
It's been a struggle.
In 14 years. Time almost stands still during a long operation.
In the end, Loretta's operation has taken Tim and Sat 12 hours.
Cheers, mate. Thank you. Yeah, I was worried about this. I know now, in retrospect, why I was nervous about it. It was, you know, as operations go, quite nerve-wracking. But we've done it because the natural history of this disease seems to be progressive, and if we missed the boat and it started going into the base of skull, then it potentially could be life-limiting.
Neurosurgeon Alex Baluzzi is visiting Nora to discuss her post-operative care.
Knock.
Come here, Mr. Blue.
Hi, Nora.
It's been 2 months since Nora's last operation, when 95% of her tumour was removed.
It's good to see that you've come through those big operations
Right, yeah.
in good conditions. I think I reached the maximum of what I can do surgically.
Yeah.
And now I'm going to hand you over to my colleagues, and they will begin the next stage of your treatment,
Okay.
which is the radiotherapy. So the hope is that the radiotherapy will keep it under control.
Yeah.
Okay. How long for, I do not know.
Yes, I understand that.
So this is the end of a chapter, if you want.
Yeah. Okay then, Mr. Approach.
Okay.
No more hand-holding with me.
Never too much.
Too Italian.
Yes, I get that a lot.
Yeah. Okay, thank you. See you later.
Bye, Helen.
Thank you for everything.
Pleasure. I was hoping that the outcome would be better, that we were able to remove the whole of the tumour. Unfortunately, you need to accept the fact that you're dealing with a disease which is too hard to fight. What I know is that if we didn't intervene, then the disease would have taken its course much faster.
It's 2 weeks since Loretta's operation. Today she's back at the Queen Elizabeth Birmingham for a checkup on her progress with surgeon Tim Martin.
I'm a little bit nervous about seeing Loretta because she's had time to think about this, and I just wanted to say that it was worthwhile doing it. My biggest worry is that she'll come in and say, I wish I hadn't had it done. Hello. How are things, first of all?
Pretty darn good, I have to say.
Okay.
Physically,
Yes.
I think since we got over that first week, well,
It was tough.
Yeah, it was tough.
So the hollow's setting in, isn't it?
It is now. Now the swelling's going down.
Yeah.
It's all nicely recessed.
Let me get my gloves on. So inside your mouth looks great. Those little stitches up there we're going to leave. Okay. Just bite together on your back teeth. Okay, so you might struggle just to get the right bite, but that looks okay. I think looking at you, there's a few things that need doing. I think getting teeth will make a big difference. So we'll hopefully be able to fill the hollow up here.
Yeah.
This bit of swelling at the back there, I think, will go down a bit more, but you probably need a bit of filling out here. And what might be nice is to put some fat in here as well. So my take on this disease, having treated Loretta, it's nasty. The tissues are hard to deal with. It's still a disease process not to underestimate.
For the moment, Loretta is out of danger. Surgery has stopped the disease from progressing into the base of her skull.
I think I'm comfortable we've done the right thing. Hopefully you are as well.
It could have been a whole lot worse, and that would have been, I honestly think if we had chosen not to go ahead with the surgery.
I think things would be different.
Yeah, I think they'd be a lot different then.
The thing is,
You have just been amazing, honestly.
Lovely. Cheers. And just call if I can do anything.
Oh, thank you.
Cheers. Bye now.
There are lots of moments where I've honestly thought this cannot have a happy ending. The nice thing is today, I think we're coming out fairly confident that we've got a future. And we couldn't be more excited. We're thrilled. What amazing people out there.
It makes me feel good that she's as positive and as bubbly as she is. So medicine's all about pushing boundaries. For Loretta, undoubtedly, it was the right thing to do, for so many reasons.
To collect you for your surgery, is that okay?
Right. In the UK, some 3 million major operations are carried out every year.
Nice big deep breath. We'll look after you, don't worry.
Only the country's top surgeons are skilled enough to take on the most critical cases.
Cameron, you all right?
Just take a couple of deep breaths.
If you're going to make a hole in someone, you better be sure what you're going to do.
Should we go for it? Right.
They're using pioneering techniques to treat conditions that used to kill.
A few years ago, these operations were felt to be too big or too dangerous.
But pushing the boundaries of modern medicine comes with great risk.
Just keep quiet for a second, please. If I move the blade too much, she's going to wake up unable to breathe.
Life is precious. It can vanish in a heartbeat.
Whoa!
You need to keep your head.
Hold this. The heart is empty. We haven't got any volume at the top.
If you panic, the patient can bleed to death.
The surgeons bear the ultimate responsibility.
I need it ASAP. I can't wait for this.
I'm not infallible. Failure is absolutely possible.
We are a team, but there's one person's name at the top of the bed.
Bloody hell.
This is what really happens behind the closed doors of their operating theatres.
This is a battle, us versus the Grim Reaper. And we're not going to lose.
The Queen Elizabeth, Birmingham, one of the UK's biggest hospitals. Over 1 million people are treated here every year.
Lift, and straight up to floor 4.
Tens of thousands will pass through the hospital's 42 operating theatres, where the latest surgical techniques transform and save patients' lives.
Just think of something nice and just lie back and relax.
Each day,
1, 2, 3.
over 130 different operations take place.
Just proceed.
Most are routine. In others, surgeons will perform procedures so risky, the tiniest mistake can have catastrophic consequences. One of these is scheduled for Theatre 21. Preparing for his day in theatre is one of the QE's top neurosurgeons, Ishmael Ogredar.
Every day I go and I pray. I have a spiritual check for looking after my patients. There's a side that reminds me that I'm human at the end of the day. And I'm not infallible. And I'm also answerable, and not just to our regulatory body, our colleagues, but also to humans as individuals and a higher being as well.
The brain surgery Ishmael performs requires absolute precision. There's no margin for error.
Failure is absolutely possible, and every single surgeon that I've worked with or under, I have seen them fail at something. But really, that's what drives me to make sure that I don't fail my patient. I do everything I can to reduce that risk for that patient.
Ishmael's operation today is so complex and unusual, it's only performed at a handful of hospitals in the UK.
You can see this area here, which is tumour. It's slightly different colour to this bit here, for example.
My patient's tumour is on his left frontal side, and that area is responsible for his speech. So the problem with that is that if you do damage the wrong area, then his speech function would be permanently damaged.
To help navigate around tumours like this, the QE was the first hospital in the UK to introduce a 3D brain mapping system.
Newer technologies like your navigation scans will tell you roughly where you are to within about a millimetre or two, fairly accurately.
This pre-op mapping gives Ishmael a better idea of where the tumour sits and its boundary with the area of the brain relating to speech.
So what room are you?
14.
14?
Nice for you.
Ishmael's patient is 20-year-old Cameron.
The second I met Ishi, as in my surgeon, I knew straight away, I was like, I want him to do my surgery. He even said to me, I've got a fellow in Manchester, you can either go there and have him and be close to home, or you can stay here. But the second I met him, I was like, no, like, I don't want anyone else. Like, the second I met him, I thought, yeah, you're the guy to do it.
Yesterday? Yeah. He was sat, I think it was his mum, wasn't it?
Cameron has travelled from Lancashire for the operation with his parents, Richard and Jackie.
Nice day.
Yeah, but I'm going to be sleeping all day, so it don't really matter to me.
How do you open it? Or do you just push?
Push.
Cameron was finishing his training as an army medic when he got a fever he couldn't shake off. So he went to the doctor.
When I first went in, they said, oh, we think it might be meningitis. And then they pulled me into a separate room, into a consultant room. The doctor at the time came in and he just said to me, we found out it's not meningitis. And he pulled up on the screen and just said, yeah, we've found this tumour. And they just said, you need to ring your mum and dad.
Ish can't tell if Cameron's tumour is cancerous or not until a sample has been taken during surgery and tested. Removing as much of it as possible is vital.
We don't know exactly what type of tumour it is. So if it is something a bit more aggressive, the more we can take out as safely as possible, the better it is for his long-term prognosis.
Good morning.
Morning. Morning. How you doing? You all right? You made it down all right?
Yeah, yeah.
Oh, yeah. Yeah. Good. Need to put a mark on the side. So we'll be going in there roughly. All right.
What makes Cameron's brain surgery different from most major operations is that during much of the procedure, he'll be awake.
When I first found out you'll be awake while your brain will be open, the more I think about it, the more I'm like, I don't know. When I wake up, I don't know how I'm going to feel. Because you don't know, do you? It's like the unknown.
Morning, sir. I'm the anaesthetic consultant.
Anaesthetist Harry Kravidi is in charge of putting Cameron to sleep, then waking him up.
We do the first part of sleep to get all the painful, uncomfortable bits out of the way. And then Harry will lighten the sedation and start waking him up.
You'll hear us telling to open your eyes. And most important thing you have to remember is not to move your head, because head is fixed.
Cameron needs to be awake during the operation because his tumour, about the size of a ping pong ball, will be probed millimetre by millimetre using electric stimulation while he's encouraged to talk. If Cameron's speech falters, Ish knows he can't remove that area of brain tissue, or else he risks leaving Cameron unable to communicate.
There is a bit of dilemma in wanting to take out as much tumour as possible, ideally all of it, and balancing that with the risk of harming the patient. The consequences of taking the wrong bit of brain tissue can be catastrophic. It can be really life-changing, and it can turn somebody who is very independent and able to being completely dependent.
Any questions?
No.
No?
No.
I'll set to go.
Oh, just leave me in your capable hands.
Thank you very much. I think we're almost ready, so I'm going to nip down to theatre to make sure everything's sorted. Good. All right.
Okay, thank you.
I'll
Okay, we'll see you then.
See you in a bit. All right. Okay.
Cheers, thank you. As a father, watching him go, especially because you're helpless, it's tough. Very tough.
We're being very positive around him. I don't want him to see me getting upset because he'll get upset. But yeah, he's going to go through a lot and it's going to change his life.
When we wake you up, we'll have a little chat to begin with, make sure you're awake enough and that you're feeling comfortable. And then we'll start with the picture naming one.
Working alongside Ish is speech therapist Becky Marr. She needs to keep Cameron talking constantly once he's awake.
As Ish is stimulating parts of that tumour and the brain surrounding it to assess if there's a change in speech. I think the main thing is, out of everything in theatre, that patient can only see your face. So your every kind of communication they have will be stimulating different parts of the tumour. So if there's any difficulties, I can let Ish know, and then we know not to take that part.
So Becky's like a little force of nature. It really does take charge of the patient. So as soon as they wake up, they see her face. And so it's quite nice, from my perspective, to have somebody who's very engaged with the patient.
This is the computer we'll be using today. So as we're moving around the tumour, we go through the pictures, and for each picture I need you to say "it is" and the name of the picture for me. Exactly. Any questions for me, Cameron?
I'm happy.
No problem. So I'll be seeing you when you wake up?
See you when you wake up.
Perfect.
All set? Good.
Whenever we have a surgery, we'll speak before and we kind of have a bit of a game plan, if you like. So you have to be really confident that you know what you're doing, each of you trust how you're communicating, and then you know you're going to get the better outcome.
Becky and Ish have assessed Cameron to check if he's psychologically robust enough to cope with being awake during the operation.
I'm not nervous about surgery. I'm nervous about afterwards. I could wake up and be like, can't speak. So that's what I'm dreading.
Ready for us to come in?
Yeah. I feel like I'm about to go to war.
You ready?
Two in each site.
Ish clamps Cameron's head so it can't move during the operation.
Okay, pins going in. Nice and gentle, nice and gentle. There's plenty of support in there. That's nice.
Yeah.
Very nice, yeah.
Okay, can we confirm who this patient is?
Cameron Ray.
Yeah. Ish?
Yeah.
Duration of surgery?
Most of the morning, early afternoon,
5 to 6 hours?
4 or 5.
To get access to Cameron's tumour, Ish needs to cut through the scalp, skull, and the fine membrane surrounding the brain.
Usually it's fairly simple at this stage. It becomes very much routine. But all the time you're thinking a little bit further ahead about your approach, about your tumour, about your vessels. So you're always a few steps ahead.
Cameron's brain is now revealed.
Every time I open the skull and I see the brain pulsating away, I look at it and go, wow, what a wonderful piece of machine that is. Because it really does define who you are. It really defines you as a human, as an individual being. You do stop and think, wow, that is brain, and there is tumour in there, and you're going to try and help them as much as you can.
Leading cardiothoracic surgeon George Mascaro is also taking on a procedure in which even the smallest mistake can have life-changing consequences.
Surgery is not a competition, but probably the ability to undertake big operations and difficult operations has something to do with that inside will of pushing yourself.
He's preparing to perform an operation widely considered to be one of the most dangerous. Replacing a long segment of the aorta, the body's largest artery.
The aorta is a tube, however, a very important tube because distributes blood from the heart to the whole body.
Oh, that's a nice view. Yeah. Lovely.
71-year-old grandmother of two, Maggie, has a thoracoabdominal aortic aneurysm. Her aorta is swollen and could rupture at any time, causing a fatal bleed. Until it was discovered, Maggie believed she was fit and well.
You sort of like live your life on a shelf. You're too frightened to move in case it bursts. I haven't got an alternative. It is just living on the edge. Hello, daughter. You got my belongings.
Living with the aneurysm, it's unbearable that you know that they could blow at any time and there's almost zero chance of her recovery if that happened. She's finding all this a bit scary, to be honest, because it's out of her control. She's living with a time bomb.
Maggie's aorta, the main artery for distributing blood around the body, has two aneurysms. Abnormal weak spots, where the artery walls are bulging and in danger of rupturing at any moment. In her operation, a 24-centimetre section of her aorta will be detached and replaced with a synthetic tube.
The operation is not just about replacing the aorta, but it's also to re-establish the connections as quick as possible with the different organs that the aorta supply.
The Queen Elizabeth Hospital is one of only two in the UK that regularly performs this procedure.
The risk of dying is a clear risk in an operation this big. There is also risk of stroke. There is also risk of paraplegia.
As a result of the operation, around 1 in 10 patients die.
I've got so much to live for.
I'll pop those down.
I've still got a bucket list and I'm not halfway through that. I can't just give up.
Hi, how are you?
Terrified.
Why?
I don't know.
No?
Yeah.
It'll be okay. Okay? I just wanted to say hello now. I was doing a heart transplant last night, so that's why I didn't come up to the ward. But it was busy yesterday, yeah. But it's okay.
But you've had your lunch.
Yes,
You've
yes.
had breakfast.
And a nice sleep as well. So
you've done more than
everything is in place for today. Okay,
Yeah.
I will see you. I will see you later, yeah?
Okay.
Bye. Take care.
Mr. Mascaro, he's going to do his magic on me. He's the man that can do it. My hopes are all set on him.
I don't think that surgeons are superheroes. I think surgeons are just one more professional, and a good surgeon is a good surgeon because he's well supported. He's supported by a good team.
In the QE's theatres, there are usually 7 or 8 clinicians involved in each procedure. The team assembling for Maggie's operation outside Theatre 7 today is 15 people strong.
Today we have got Maggie. She was referred for thoracoabdominal aortic aneurysm. Now the aneurysm has reached criteria for replacement, so we're going to do a thoracoabdominal aneurysm repair. Okay? Thank you. Thank you. You bring out of that team the best of them, and that makes you a good surgeon On your own, you probably will fail.
With an operation of this magnitude, George and his team may be operating for 10 hours.
All right, off we go.
We're going to shift a little bit here, this way, and turn, yeah?
Okay.
That's it, perfecto. In order to have good access to the aorta, the incision needs to be a big one.
George must cut from just under Maggie's armpit, around the front of her chest, and down to her lower abdomen.
The aorta runs from the level of your neck all the way down to your pelvis. So when you need to operate on something that is that long, you can imagine the extension of the incision. The aorta, you know, runs at the back, so we need to go all the way round and dissect all of this free.
As he exposes the aorta, George needs to navigate with great accuracy, avoiding important blood vessels and major organs.
These here are lymph nodes, yeah? Careful, 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 they bleed. Lymph nodes bleed very easy.
With the upper part of Maggie's aorta exposed, George has to decide how much of it needs to be replaced.
Okay. Now the aorta here is quite smooth and regular, yeah? So we can replace it from here down, yeah? And the aorta remains sort of bulging here. And as we go further down, the aorta is quite unhealthy in this portion as well. So we're going to replace all the way down to this level. Yeah.
George is now ready to start the most important and dangerous part of the operation, detaching a large section of Maggie's aorta and replacing it with a synthetic one. This highly engineered section of tube is made at a factory in Scotland. It's manufactured in clean rooms, where the air is changed regularly through a high-tech filtration system. The fabric is made of polyester yarn and woven by machine. The geometric arrangement of the weave makes it strong, but also allows the surgeon's needle to pass through the fabric easily when it's being stitched into the body's tissues. The fabric is made mechanically, but the branches that extend off the main tube are attached in a more traditional way.
Over the years, we've looked at a number of different ways where it could be done using a mechanical means, but there's no substitute for the human hand and the sewing technique. It's the only way to achieve the precision required for such a device.
It takes 200 individual stitches to sew in just one branch.
This will be my 2,999th graft. So if I had done another one today, you maybe would have caught my 3,000.
The tube is only finished after it's impregnated with a unique gelatin. This acts as a sealant to prevent blood from leaking out. Over time, it disperses, allowing the body's natural tissues to heal around the synthetic material.
I've done like fashion, but it's a bit better when you're making something that's actually worth making. Saving life's by proxy, that's what everybody always says when they find out what I'm doing.
By late morning, many theatres at the Queen Elizabeth have had their first patients come and go. But in Theatre 21, brain surgeon Ishmael Ugradar is still in the early stages of his awake craniotomy on 20-year-old Cameron.
This here border, and around here, and with a speech with a smack bang in there. We're waking up, yeah, Harry?
Yes, yeah.
Normally, it's the anaesthetist's job to ensure the patient is unconscious. But in an awake craniotomy, they have to wake the patient up.
Cameron, just waking up.
When I'm waiting, it can be a bit tense at that point. You're wondering, is the patient going to wake up enough? Are they going to be able to engage?
Nice deep breaths. Take some nice deep breaths, okay?
The longer it takes, you do get more and more worried, and you get a little bit more frustrated as well. Your whole purpose of doing that operation is to do it with them functioning with their speech.
Cameron?
Even though you hope you screen for anyone that might be anxious, you never fully know what they'll be like on the day. Cameron, it's Becky
You're just
here.
waking up.
You hold on to me.
Just give him a few minutes to come round a bit more.
Hi, Cameron. Cameron, here's my hand, okay? Just slowly wake up for us. Doing really well. Cameron, can you try and do me a really loud ah? Good. You forgot you're in surgery. Can you remember now? Is your brain out? We can see it.
They suddenly wake up through the operation. You remember there's a body at the end of it. There's Cameron at the end of it. And it kind of personalises the whole operation again, because you start talking and interacting with them as you're operating.
Cameron, hello. Can you hear me?
Yeah, we got a thumbs up. He said you're doing a good job-ish.
Am I? Oh, right. Haven't started yet.
I like that process of engaging because it constantly reminding me what I'm doing, why I'm doing it awake, and what's at stake.
With Cameron awake, Ish and Becky must work closely to map what is tumour and what is brain. That way they can take out as much of the growth as possible without causing permanent damage.
It can be quite easy to get lost in the brain if you're not careful. Tumours and brain tissue can look extremely similar, so sometimes we have millimetres to operate in these areas.
So what we're going to do is we'll do a quick run through of pictures, and then we'll start the stimulation at the same time. So if anything's difficult when we stimulate, I'll be saying error and letting Ish know.
We'll start stimulating through the brain. And what we do is we send little bits of electrical current, and while we're doing that, we're testing their speech.
If the current interrupts electrical signals between nerve cells associated with speech, then Cameron will have trouble speaking.
If we find a problem during that process, we know that's an area where we can't go into. And in that way, we'll map safe and unsafe areas.
So it is, and the name of the picture for me.
Star.
Yeah. Well done, nice and loud for me, Cameron.
The horse.
Perfect.
Statue. The spoon.
Error. Semantic. There's different areas you can get with speech and language. A semantic error is when you say a word that's kind of within the same topic. So, for example, if the picture was of a chair and you said table. Error phonemic. You'll have phonemic errors where instead of saying chair, it might be share. So you've got a sound difference on that word.
When Becky calls that error, Cameron's brain is saying you're about to cause a problem here. There's about to be function at risk here. So it's a warning shot to us.
Error.
That's Roy's ventral premotor speech.
Arrest. A speech arrest is where you have like a complete block of speech. So a lot of the time, patients will be like, you'll have little attempts at sound, but you're not really getting anything coming out. Arrest. At this point, patients actually look quite scared.
Cameron, you
Don't
all
worry.
right?
Cameron, tell me your surname.
I don't think you can really appreciate what it's like to be awake during a procedure. And I think if you ask most people from the outset, they'll be anxious and scared.
Doing so well. Especially when he gets a speech arrest, that's when he really, really gets upset. And I think that's when it reminds him, this is what could happen if the surgery didn't go to plan. Cameron, just take a couple of deep breaths. It's okay. It's okay.
Suddenly they find themselves awake, with their head open, with their brain out, with somebody saying talk. and they can't move their head. It can be quite overwhelming, I think.
Cameron, you all right?
Yes.
What's wrong?
That's all right.
A bit emotional.
Does it all feel a bit of a shock?
Just relax.
Take a minute, don't worry.
At that moment, I'm thinking, have I made the right decision in assessing his suitability for being able to tolerate an awake procedure? Because he was clearly quite upset. Would I be able to proceed? Am I going to have to close up and come back another day? Are we going to carry on or not?
Things do go wrong. Anything can happen with Cameron while he's actually being operated on. There's lots of things after, but we just need to get this hurdle over with, and then we'll start the rest of the journey. At the end of this, he just wants to be a soldier and be in the army, and hopefully he can get back to that stage. Once he wakes up, then we'll see.
In many of the Queen Elizabeth theatres, 2 or 3 procedures are performed every day. But by noon, George and his team in Theatre 7 are still in the first stage of the operation to replace Maggie's aorta.
Yeah, you can see that there is an aneurysm as well. So here we're going to put our first clamp.
Once you have exposed the whole of the aorta, you're ready to start the proper operation.
In order to replace the damaged section of aorta, George must first stop the blood flowing through it by clamping it at the top and bottom, and clamping the 4 branching vessels which carry blood to Maggie's major organs.
We're going to clamp here so that we can sequentially move up, yeah? Give me a
clamp now. One of those buttons, yeah? The large one, that's it.
So now we're going to clamp here in between, yeah? We need to put a clamp up here, yeah? Which is where we are going to end our anastomosis, yeah?
So we're going on bypass now. Okay, Ram, on the pump, please.
Thank you.
Normally the heart pumps blood to every part of the body. And during Maggie's operation, blood will still flow from her heart to her upper body and brain. But with her aorta clamped, blood cannot flow from Maggie's heart into her lower body. So a bypass machine will take over this stretch of Maggie's circulation. Some of her blood will be rerouted to the machine, oxygenated, and delivered into her lower body. There it will rejoin her circulatory system and then flow back through her veins to her heart, ready to be pumped round her body all over again.
Temperature of 34 degrees, correct?
32.
32, thank you.
Perfusionist Ram Gohil is in charge of the bypass process.
Maggie's circulation is still one big joined-up system throughout her body. We are adding a detour for one short section of the journey.
Ram must regulate the delicate balance between the amount of blood flowing into the bypass machine and the amount left to supply the upper body and brain.
Getting the right balance, getting the right amount of flow to the brain, getting the right amount of flow to the lower part of the body, making sure everything runs smoothly. Things can go wrong, so you do have to be ready.
Lung remains ventilated, yeah?
Yes, lung remains ventilated.
Thank you.
Anaesthetist Harry Singh must keep a close eye on Maggie's vital signs to ensure her brain is getting enough oxygenated blood.
And Ram?
Harry?
We'll titrate the CO2, isn't it?
There is a triangle between surgeon, perfusionist, and anaesthetist. And this triangle of communication is vital for the success of the operation.
So we're opening the aorta now, yeah?
George detaches Maggie's aorta.
Okay.
Your flow is running okay?
Flows are fine, sats are good.
Careful with the stitch. Careful with the stitch. That's it.
He can now begin the exacting process of stitching the synthetic aorta into place, starting at the bottom.
Come down on your flow, Ram, please.
Thank you.
Okay. Come back up on your flow, please.
Back to where we were, right?
Yeah.
Thank you.
So, give me oops, where is bleeding from this? Quite a big bleed from here. Here. Ram?
Yeah.
Come down on your flow, please.
That flow is down.
Right down, yeah?
Yeah.
You need to see behind, yeah?
Fully clamped.
That's why it's bleeding, yeah?
Maggie is bleeding rapidly where George is trying to stitch in the new aorta. It could be a sign that the blood pressure's too high in her lower body.
We can see that. Finger away. Flow down.
Down.
Yeah. I don't know why you are so much pressure in the lower body.
With the way you're stitching, does it feel like the pressure is very high?
Very high, yeah.
Okay, Ram.
Very high.
So we need to tweak the volume down.
I have, yeah. You see, that's not reading right. You see, that's completely empty there.
Flow down, please.
That is down.
Is it?
Yeah. There's a lot of flow going to the bottom half of the body, and it can actually loosen the sutures.
Lots of pressure here, mate.
Yeah. Is there?
Yeah. It's huge.
That's off. That is virtually off there.
What's off?
The pump.
She looks quite pale as well. We need to give some blood. Get some blood, please.
Ram, the tension here is just too much.
Despite reducing the flow from the bypass machine, the blood pressure in Maggie's lower body is still rising too high. As well as making her bleed dangerously, it means that blood isn't circulating around her system properly.
It is a very stressful situation.
There we go, back down.
Something is not right.
Okay. Give me a swab, please. Give me a swab. Have a 24mm anti-flow graft, please. Hold this. No, with your hand. Give me a clamp, please. The heart is empty. We haven't got any volume at the top.
It seems there's a blockage somewhere in the veins that carry blood from Maggie's lower body to her heart. It's not only stopping the blood flow and causing pressure in her lower body to rise, it's also restricting the amount of blood available to be pumped to her upper body and brain.
If the brain doesn't get the blood supply that it needs, the patient can stroke or the patient can die.
So are we obstructing somewhere, George?
I don't know.
Very tense. Okay, think it through. We want to solve it as quickly as possible because the longer it is, the less safe it is.
Your blood pressure at the top is not coming up.
No, it's not. You see, this is
so much, isn't it?
No.
The team can't identify what's causing the blockage. Their best option is to try and reroute Maggie's blood supply around the problem.
I tell you what, give me purse string. Long needle holder. And give me a Femflex cannula, please, or something like that. Hang on, I'm going to put a cannula. Have we got a cannula?
We got this.
Yeah, okay.
George put a special pipe in Maggie's circulation in the top half so that perfusionists can directly transfer some of the circulation from lower half of the body to the upper half of the body.
Getting the rapid infuser out, getting the units of blood out.
Hold that, please.
By inserting a cannula into an artery in Maggie's lower body, perfusionist Ram can now divert blood directly to Maggie's heart, past the blockage. He should now be able to start supplying her brain with the blood it urgently needs.
Right, so you are perfusing the body and the head.
Okay.
Yeah.
Right. That's coming back now. Just see where we are with this.
Sats coming up?
Sats are okay now. Just come up to 55, 60.
The bypass machine is now circulating blood around Maggie's entire body. The team must wait for her to stabilise.
But the head has been low 15 minutes at least.
How low?
Low as in 35, 40.
Before the team managed to restore her circulation, the flow of blood to Maggie's brain was reduced. There's a risk this has caused a stroke.
Something might have happened, but we won't know until she wakes up and we know how she is.
With Cameron now calmer, Ish and his team can resume their awake brain surgery in Theatre 21 and start removing his tumour.
Good. Keep going for me.
Cameron, we'll start to take tumour out for you. Okay. You keep talking to Becky.
I remember you telling me when I last saw you about your car.
Oh, yeah, I've sold it. Yeah.
You sold it? I remember you saying it was for sale.
We'll start taking out the tumour, and we're constantly monitoring and mapping and stimulating as we're going along. And we'll repeat that process until we're either taking out as much tumour as we can, or we reach a problem in their function, and that's when we know when to stop.
Cameron, open your eyes for me.
What was it? 25.
Struggling, still arrest.
You all right, Cameron?
There's a lot of communication between me and Ish. Error. You need to be able to trust one another, that he can trust where I'm identifying things, but also that I can trust that he's going to listen when I say, we're having errors, please do not take that part. That's okay.
That's fine, that's fine. That's what we want to see. We want to see you stopping like that, yeah? That's good.
But don't be worried when that happens, Cameron. It means we know exactly where we are.
So we've defined some of the boundaries here, so we can't go into this bit here at all.
For Cameron, the biggest challenge is the blood vessels that were bleeding and oozing, because we're in very close proximity to the main parent blood vessel supplying that part of the brain.
Suction. You know, both suctions up, please. You can have the bigger sucker there as well.
So that's a little bit tricky to sort out without damaging the blood vessels or sending them into spasm to cause a stroke.
So what made you decide on the army?
Just the career, like, I've always wanted to help people. Being a car surgeon,
I lost that a little bit at the end. Say that again for me. Speech arrest. The most alarm bells rise when it's a speech arrest, because you know if that part of the tumour was taken, that could potentially be how they attempt to speak for the rest of their lives.
All the time you're thinking, if things are not going to plan, is it something that you've done or not done that's caused that problem? I don't panic. I don't get panicked that easily. But you do worry a lot, and you do get very anxious about what's going to happen, whether you can proceed, or has there been a consequence to them that may or may not be reversible.
Cameron? Cameron, you all right?
The consequences of a complication for Cameron would involve being completely paralysed down the right side and unable to talk.
Error.
Too much chatter. You ask them to be quiet as well, please, down there.
It can be quite daunting during those periods.
Cameron, I'm afraid I'm going to make you still talk to me though. Now the months of the year.
January, February, March, April, June, July.
Oh, we've missed one out. What's after April? Begins with the letter M. It's okay. April, May.
But usually they get through it and they bounce back.
So Cameron, we've got a ping-pong size hole in your head at the moment where the tumour was. Okay? We're taking a bit more now. We'll keep going until you can tolerate it, all right?
As Ish removes sections of tumour, they're prepped and sent to pathology to determine if they're cancerous.
Try and stay awake for me, okay?
Although it would be preferable to remove the entire tumour, Ish has taken out around 80%.
I can see that some of his tumour is extending into his speech area And so I've decided not to take that for fear of causing permanent damage to him.
So they're just closing everything up, so you'll feel things moving more.
It's nice though.
Yeah?
Feels good.
I think the only person I've known that said that.
The disc of skull is put back into place and secured with screws. Cameron has been in theatre for almost 6 hours.
I'm reasonably happy with how the case had gone, but I don't think I could have taken any more, so reasonably satisfied as to what we'd achieved.
Birmingham. This could be it. Hello? Oh, yeah, speaking. Thank you very much. Ta.
I did hear her say it's all gone well.
That's good. That's the news we've been waiting for. He's actually come out, he's in recovery room, he's awake, and he feels good.
Oh. Hi, lads.
What?
The operation seems to have gone well, but it'll be a few weeks until they know if Cameron's speech has been affected and whether the tumour is malignant. By afternoon, some 70 operations will usually be completed at the Queen Elizabeth Hospital. George and his team in Theatre 7 are still in the middle of Maggie's operation. They're waiting for her to stabilise after putting her entire body on bypass. They still don't know if the lack of blood to her brain has caused any damage.
There is a point of no return. And when you get to that point of no return, you just need to carry on your operation to the end. So you need to stay cool, and you need to be able to control your emotions for the sake of the patient.
We need to deal with it and then carry on with the operation. And this is where I like George, where he would just stand and carry on at the same pace with the same vigor and expect the best, you know.
Okay, and let's try to carry on the operation, yeah?
George needs to continue attaching Maggie's new synthetic aorta to her blood supply.
We rejoin the main tube first. Now we can concentrate in rejoining these branches that arise from the aorta for the liver, bowels, kidneys, and so on. Right kidney is in.
Thank you.
Now we do the left renal, which is just here, yeah? It's here.
It's painstaking work. The branches are small, and George is trying to connect them to blood vessels that are unhealthy, so they are thin and fragile.
There. Left kidney is in. Oh gosh, what's bleeding now? It's going from bad to worse. Where is the blood coming from? In moments of emergency, you need to keep your head. If you panic, if you lose control, then it's very likely that your team around will start losing control as well. Give me. It is dissecting from somewhere, and I don't know where from.
There's a new serious bleed they need to control.
This is bad. This is bad. Something is happening that I don't like. At this point of the operation, Maggie is at risk of anything. If we cannot stop the bleed, patient can bleed to death. Anything can happen.
I think we are in a little bit of trouble, George.
Yeah?
We
Tell
got
me.
a lot of blood coming out.
No, I know where it is. I think it's the right kidney. Okay, yeah, it is the right kidney. Was dissecting.
I think all the aorta and the vessels are very unhealthy. They don't hold stitches.
It's everything very unhealthy, I agree with that.
Because the vessels are so weak, a branch George stitched in has come undone.
I'm redoing the right kidney. I need to stitch quickly, but those stitches I need to make sure that they're going to be strong enough to support the aorta. So the right renal artery is back in now, yeah?
Yeah.
Okay, hopefully that's going to be okay. All right?
We're nearly there. We are nearly there.
All the branches of the synthetic aorta are now connected to Maggie's body.
We need to check our joints. Here, looks okay actually. Flow down.
Down.
Clamp the arterial there, yeah, clamp it.
Okay, clamping.
Flows back up.
Yeah. Everything open?
All open.
Thank you.
After 6 hours in theatre, it's now time to test the new aorta. They're ready to open all the connections, let blood flow through it, and take Maggie off bypass.
Okay, Ram?
Yeah.
All yours.
And coming down now, thank you.
Coming down to half flow.
Yeah.
This type of operation, there is a risk at every single level.
That's half flow. Down to quarter.
Coming down to quarter flow.
Thank you.
Once you're coming off the bypass machine, one of the biggest fear is, will the heart cope with its own function after such a long operation? So there's always a degree of uncertainty.
Quarter.
Enough bypass when you're ready.
That's off bypass.
Off bypass. All good?
Yes, we're okay.
The patient now is maintaining her circulation by herself.
Maggie's new aorta, 24 centimetres of synthetic tube, is doing its job.
Now we're closing the abdominal muscles. The closure of these patients is almost another operation.
I'm thinking that this has been a very stressful day. I would have liked it to have gone easier, but some operations don't.
Thank you very much.
Thank you, Mr.
We're finished. We're done. And everything looks okay, yeah?
Until Maggie wakes up, George won't know if she suffered a stroke during the operation.
We always try to look for a possibility to help the patient. But medicine is driven by human beings, and there's always a limit to how much we can do. And it is very sad, but sometimes we just can't help people beyond of our means.
It's 2 weeks since Cameron had his awake craniotomy.
Up to now it's been really good, so hopefully it stays like this.
The operation has had no lasting impact on his speech. Today, he's seeing Ish for the biopsy results on his tumour.
Cameron, come on in. Yeah, how you doing? You all right? You all right? Yeah, not bad. Good, your speech already sounds a bit better. Come and take a seat for me. So if I just show you your first set of scans, it's this area that we were interested in here. Yeah. So if we go to your post-op scan, they think all the solid bit is out. So the scan looks good and you look good. So then we go backwards and we talk about the diagnosis again. So just to go backwards, so we talk about gliomas as being two broad categories. So low-grade gliomas and high-grade gliomas. The difference between the two is that the high-grade gliomas are the cancers. Okay? And so the low grades are grades 1 and 2, the high grades are 3 and 4. Okay? Yours, unfortunately, has come back as a grade 3, which isn't quite an aggressive grade 4 cancer, not quite a grade 2, which is what we were hoping for, but somewhere in between. What it means is technically that this is a cancer of sorts, of the brain. But what it does mean is that we would recommend chemoradiotherapy if it had been grade 2, we might have said, sit tight a little bit. We'll do another scan, see how it goes. But I think with that, with them saying it is a grade 3, we think it's probably worth giving you treatment earlier rather than later. So, not the best news we could have had, and it's nothing that you've done or not done that's caused this. So it's just very bad luck, I'm afraid, very, very bad luck.
Ultimately, I guess the real challenge is having to give him his bad news that he's had a cancer. Unfortunately, we can't cure it. So his prognosis would be measured in years rather than decades, unfortunately. Especially when it's somebody so young like Cameron. It really hits home.
Following her operation, Maggie had to spend several weeks recovering in hospital. Tests revealed she had suffered a stroke during the operation, affecting the right side of her body. When she left hospital, Maggie was unable to walk.
Just in case you don't come out and call you, you might just have to watch for your name up on that screen over there.
Right, yeah. Yeah.
Now, after 3 months, she's back at the Queen Elizabeth for a checkup with her surgeon, George Mascaro.
Maggie, would you like to come through?
Yeah. Yeah. That's it.
Maggie's new synthetic aorta is functioning well, so George wants to check how she's recovering from the stroke.
Hey.
We need to assess your strengths to see how strong you are.
Right, okay.
Excellent. Excellent.
I tend to drag my one leg a little bit.
Yeah? Okay.
But, you know, I'll get there.
Yeah? Good. Excellent. How have you been?
The use is coming back into my hand.
Yeah.
My legs are okay.
Yeah.
I can
Good.
stand up, as I say, and I can walk a bit.
Yeah. Yeah.
I haven't gone dancing yet.
Okay.
But that's to come.
I think more strength is necessary.
Yeah.
So you will need to do a little bit more
Yeah.
of exercising.
I've got a gym instructor. He's got lovely legs. Yes.
Oh.
And he gives me exercises to do as well. I feel fantastic. I'm not worried like I was in case it just blew.
Yeah.
But I just feel really well.
Wonderful.
I've got lots of scars, but they'll heal.
Yeah, well, life gives us scars.
I've solved one problem, haven't I? And this other one with a dicky arm and not being able to walk very far. It's just a minor thing, I'll sort that out. There is no stopping me now.
My biggest fear as a surgeon is that I will fail. But the patient doesn't want for you to suffer with him. The patient comes to you for help. But you can't take the emotional involvement completely out, because what drives you at the end of the day is your emotions.
Finish it, finish it! Is that a penalty? Surely, surely. Surely that's a free kick or something.
It can be a sobering experience when you you haven't achieved what you would like to have achieved. I do take it personally, but then remind myself that there are some things that are unachievable. It certainly makes you appreciate life, health, and the time you have with your family.
I've come to collect you for your surgery, is that okay?
Right. In the UK, some 3 million major operations are carried out every year.
Nice big deep breath. We'll look after you, don't worry.
Only the country's top surgeons are skilled enough to take on the most critical cases.
Cameron, you all right?
Just take a couple of deep breaths.
If you're going to make a hole in someone, you better be sure what you're going to do.
Should we go for it? Right.
They're using pioneering techniques to treat conditions that used to kill.
A few years ago, these operations were felt to be too big or too dangerous.
But pushing the boundaries of modern medicine comes with great risk.
Just keep quiet for a second, please. If I move the blade too much, she's going to wake up unable to breathe.
Life is precious. It can vanish in a heartbeat.
Whoa!
You need to keep your head.
Hold this. The heart is empty. We haven't got any volume at the top.
If you panic, the patient can bleed to death.
The surgeons bear the ultimate responsibility.
I need it ASAP. I can't wait for this.
I'm not infallible. Failure is absolutely possible.
We are a team, but there's one person's name at the top of the bed.
Bloody hell.
This is what really happens behind the closed doors of their operating theatres.
This is a battle, us versus the Grim Reaper. And we're not going to lose. People, they say, oh, that must be terribly awful dealing with children. And, well, I guess, yeah, it is stressful.
In the heart of the city, Birmingham Children's Hospital is a world-leading centre for complex paediatric surgery. Around 70 life-changing operations are performed here every day, many on children who are still just toddlers.
To breach the body is a big deal, isn't it? Any surgeon doing any operation feels that sense of responsibility. But when you're operating on children, there is that added factor which ups the ante.
David Barron is one of Britain's top paediatric heart surgeons, specialising in conditions that develop before birth.
Compared to what we felt was the limit at the turn of the century, things have changed. We're able to do things that we didn't appreciate might be possible. We're always striving to be better, and we always want to be better than everybody else. That's in our nature.
David is about to perform open heart surgery on 3-year-old Madison, who has been in and out of hospital since she was born.
Once you get to know her, she's the life and soul of the party. She just doesn't give in to anything. She just wants to keep going.
She is very confident, not scared of much.
Madison has a very complicated type of heart condition that's called pulmonary atresia, and that really means there's no connection between the heart and the lungs in the normal way that there should be. There are many varieties of pulmonary atresia, but this particular type is really rare.
Before blood is pumped around the body, it has to be oxygenated. Normally it's carried directly from the heart to the lungs, where this happens, via the pulmonary arteries. But in Madison's case, those arteries never formed correctly and do not connect to her heart. This means blood can't get from her heart to her lungs as it should. To compensate, Madison's body relies on several narrow vessels called mapkas, which branch off from the body's main artery, the aorta. They act as a makeshift route for at least some blood to reach her lungs. We all have these vessels in the womb, but by birth they've usually become redundant. Madison wouldn't be alive without them.
Shall I do it, Mum? I don't think I can do this, Mum.
But the amount of blood they send to her lungs is far less than normal, so her blood oxygen levels are low, and that has slowed down her growth, leaving her much smaller than a 3-year-old with normal circulation.
She's only in 1.5 to 2 year clothes, and she's 3. Seen her not very well. It's hard, because she's such a good girl.
For her parents, mechanic Phil and catering assistant Michelle, it's a miracle that Madison was born at all.
It was detected on a 20-week scan. The doctor said that she was not a viable baby, and he says on paper she shouldn't be here.
It's a bit high.
Madison needs an operation to correct her circulation by building a new route between her heart and lungs. The procedure is risky, but without surgery, her body will continue to be starved of oxygen, and she's unlikely to survive beyond childhood.
Just trying to hold it together. But it just, yeah, keep it in and keep going.
Okay, we've got everybody. Oh, that's better. So we have a bed, we're good to go. And so it's just one case today because she'll be an all-day case. She's only about 10 kilos, isn't she? Quite small. She's 3 years old, so she's small. So left side up first, just to mobilise the vessels, and then turn her on her back, find everything we can, join it all together. So plenty to do. Very good. Let's get cracking.
He said there was 10% chance of her not making it through the surgery. Love you. See you later.
Take it there,
I don't want to see her going to sleep. Thinking she doesn't wake up again.
That's all I can do. Make her understand that she's safe, and it might hurt for a bit, but it'll make her better.
Okay. You're doing really well, Madison.
Consultant anaesthetist Vasco Lagina Rollo is responsible for Madison's life support throughout the procedure.
Now, Daddy will stay here with you, and you are going to have a nice sleep, aren't you?
I think it is beyond any comprehension. As a parent, your main responsibility is to protect your child from all harm. And in that particular circumstance, you're actually not. Someone is actually going to cause harm to your child in order to make them better.
Get you to give Madison a nice big kiss. See you later. This will take good care of Madison for you.
That's incredibly hard for a parent to accept.
The procedure to correct Madison's circulation is so challenging that Birmingham Children's Hospital is one of the few places in the world equipped to tackle it.
A-protein and started, yeah?
Yes, A-protein and testo started.
First, the team will prepare Madison's MAPCA vessels by separating them from the surrounding tissue. One by one, the MAPCAs can then be disconnected from the aorta and then combined with the malformed pulmonary arteries, bringing together all the vessels that can carry blood to her lungs. In order to link these combined vessels to Madison's heart, the team will use a synthetic tube, giving her normal circulation for the first time in her life. Stage 1 of the operation involves going in through Madison's side to give David the best possible access to the MAPCA vessels.
So a knife, please.
Knife to skin is that moment where everything focuses. It is a sense of sort of nervousness and anticipation. That moment is usually actually a tremendous feeling of release. The fact we're getting on with the operation.
We need to be all over the place today, so I want to try and get a good view for this. We've got a lot to achieve. Let's have the chest retractor, please, Lindsay. That's great, yes. And then we'll try and find the vessels.
Madison's condition is extremely rare, and the procedure to correct it is far from routine.
I'm not sure what that is.
You're finding yourself within parts of the chest that you're not used to operating within, really.
I'm not sure whether that's the map that I'm looking at here, trying to work out what's what, really.
Certainly at times you can lose your orientation, and it's important then to take a breath and just readdress everything.
There is one more vessel that comes off the opposite side of the aorta.
To the right lung.
So, yeah, but I'm not sure how easy it's going to be to find. It's a small vessel.
Working in the confined space between the heart and lungs, David relies on his optical magnifiers to help him tease out the MAPCA vessels. These tiny tubes are just a couple of millimeters wide, but each one could play a big role in supplying blood to Madison's lungs.
Just make some space.
The more vessels you have, the better. The general rule is try and find everything you possibly can, because you can't have too much.
So just a silk.
David identifies 5 MAPCAs that he wants to use, and he marks each one with a silk thread so they can be found again later in the operation.
I think I can just sort of dangle them in there. It should be easy enough to find. Okay, so I think we're finished. So I'm coming out, let's go.
The vessels and the silk threads are tucked back inside, and the incision is closed. The team can then reposition Madison for the next phase of the procedure, opening her chest and rerouting the MAPCA vessels to create a new connection between her heart and lungs.
So ready, steady, move. Great.
Even in the spectrum of children that we see with her type of condition, she's got a much more difficult set of blood vessels to deal with than normal. And when you're doing these sort of rather fiddly operations with lots and lots of things having to be sewn together and reconstructed, this carries a risk that we have to be open and frank about, that not all children can survive this sort of surgery.
At Birmingham Children's Hospital, they also deal with another kind of life-threatening condition that develops before birth.
Okay.
Consultant urology surgeon Liam McCarthy is a specialist in disorders that affect the kidneys and bladder.
Hi Emma, everything been okay overnight? No fevers? Excellent.
His challenge today is to try and transplant an adult donor kidney into a 2-year-old boy called Isaac.
He's got an obstruction of the tube leading from his bladder, and this has caused back pressure on his kidneys. So the kidneys never developed normally.
His parents, Lee and Amy, became aware of the problem during a routine pregnancy scan.
Not a lady.
Not a lady.
I was maybe 18 weeks. And they'd done the original ultrasound and they just said, look, there's something wrong.
Shoes off.
Obviously, I was crying my eyes out. They weren't sure whether he'd actually be, they used the term viable for life. At 37 weeks, he was born by a C-section and whisked off to the neonatal unit.
Where's those tubies?
I say, wakey, wakey, tubies.
Good morning, tubies. Are they going to be good tubies today?
We knew from day one that Isaac was going to need a transplant, just because even on the ultrasounds, they could see how much damage had already been done to his kidneys.
Isaac's kidneys don't effectively filter the waste from his blood.
You're normally so good.
To correct that, he now has dialysis 3 times a week.
All his chemical imbalances that he has, they make him sick. He gets really tired. He can't go to soft plays. He can't go to the park. So we're having to restrict so much that he can do.
That's it. Now what's missing? So where's the tummy going to go?
Dialysis is keeping him alive, but in the long run, the costs are high.
Dialysis has long-term complications, so life expectancy can be reduced between 40 and 60 years. That's a huge chunk out of your 80 years. If you have a new kidney, you get a very large chunk of this back. So you get much more life, and you get much better quality life.
Poppy,
Yeah.
So Isaac's parents have agreed to a transplant.
Bum.
Under your bum. Careful, because your lines seem a bit shorter today for some reason.
No.
During the operation, Isaac's damaged kidneys will not be removed, as doing so would cause unnecessary trauma. But the adult donor kidney is far bigger, and the challenge for the team will be to find room for it within the abdomen. They hope to position it behind the bowel and connect it to the blood supply in a completely new position, much lower down on Isaac's major artery and vein. The final step will then be to link the new kidney to Isaac's bladder.
It's a major surgery where we're going to be putting an adult organ into a small child. So he's at the limit of what we can do in terms of transplantation. But he's also approaching the point where if we don't, then dialysis is going to become an issue. So getting on and doing it, if we've got the opportunity, is the right thing to do.
What about nighttime kisses from Mummy and Daddy?
Yeah.
Yeah.
Mwah.
Thank you.
The kidney Isaac needs is being donated by his father, delivery driver Lee.
Good hands. Good boy. It is a strange feeling knowing that my kidney's going to be in Isaac, but he's half of me anyway, I suppose, isn't he? So finding out that I was a match was a relief more than anything. It never crossed my mind to have second thoughts. As soon as the option was there that you can do something for him.
I couldn't be prouder of him. He's not once just been like, I don't want to do this. It was just like, no, I'll do it.
Isaac, can you give Daddy a big love?
No.
And a big kiss. Thank you.
No.
We'll see you tomorrow. With the surgeries, I'm a lot more confident and laid back about mine than his. With Isaac, it's quite a big operation for him. A lot more risks.
No.
I have profound respect for families that go through this. It is a hugely brave thing for Lee to do.
Lee's healthy kidney will be removed 5 miles away at the Queen Elizabeth Hospital. He's prepped for surgery in Theatre 14.
1, 2, 3. I see that. Starting. 9:51.
The team begins by making a small keyhole incision in his side.
Lights off, please.
Navigating by camera, they locate Lee's kidney and remove the fat that's built up around it before clamping the blood vessels and disconnecting them. The kidney is removed through the same small incision. Another surgeon flushes the blood out, and the donor organ is packed on ice.
Can we send straight away? Specimen is going.
Outside the body, the kidney will begin to degrade. Keeping it cool will help, but to prevent serious damage, the transplant needs to be made as soon as possible.
You waiting for my kidney?
I am, bless you.
The kidney is rushed across town by an emergency response driver.
Have you walked all that way? You doing?
Big cuddle from Mummy.
You're gonna have crutches.
At the Children's Hospital, Isaac is given a general anaesthetic.
Oh, thank you. I'll see you later. Thank you.
Door closing.
I need to readjust everything, so
Yeah,
we're
yeah.
leaving it on.
Should be fine.
Yeah, great.
Okay.
1, 2, 3.
In theatre, Liam and his team make their final preparations for surgery.
It really is tiny, isn't it?
Dad was quite big, Isaac was quite little, so the amount of space for us to operate is restricted.
Liam, how big is the kidney?
Good 12 centimetres. We're going to need the kidney shoehorn to get this in.
Because of the risks involved in this kind of surgery, Liam will be joined in theatre by a colleague, consultant transplant surgeon Khalid Sharif.
The margin of error is very small. So for the smaller kids, for example, the transplant ones, we have decided 2 of us will do it. And that is just to have a safety factor.
Khalid, we're likely to put a patch on.
Uh-huh.
Hey, let it come down a bit. When you're dealing with people who are tiny and we're doing big things to them, having 2 sets of eyes and a mutual respect makes the whole thing a safer, more resilient process. Neil, ready for me to go? But complications do occur. There is a risk of things not going right. Roughly speaking, in the UK, about 1 in 100 people who have a renal transplant do not survive the procedure.
In the cardiac theatre, 3-year-old Madison's heart operation is approaching a critical stage.
You good to go, Vasco, from your point of view? Yeah.
Whenever you want to.
David Barron and his team have identified the MAPCA vessels that they need to create a new connection between Madison's heart and lungs. Next, they have to detach the MAPCAs from her aorta before bringing them down towards Madison's malformed pulmonary artery so they can all be combined together.
Okay, knife, please, when you're ready.
Knife?
To reach the vessels, the team must now carefully expose Madison's heart.
Opening the breastbone is a very emotive thing to do. It takes you inside the chest of the child.
Madison has had heart surgery before, and they'll open her chest in the same place.
Okay, lovely. It's had a wire cutter.
It's one of the riskiest steps of the entire operation.
Going back in is potentially a very hazardous thing to do, because you have to be very careful that we don't damage the heart with the saw as we go in.
Let's try and go in as carefully as we can.
It is something which is an anxiety-provoking moment in the operation.
Saw, please.
If the electric saw penetrates the outer surface of her heart, Madison could suddenly lose a dangerous amount of blood.
Okay, Vasco, we're going to open up.
That is potentially a risk of a catastrophic bleed. You can very rapidly lose your entire circulating volume. You need a degree of resilience within your personality.
Scissors now, please.
You have to have self-confidence or self-belief because the risks are pretty high.
So we've got the heart off the back of the sternum.
Now they've safely opened the chest without tearing the tissues beneath. Madison's heart is finally exposed.
I'm absolutely fascinated by it. It's an extraordinary thing. We cannot design anything close with the best technology to work as efficiently or as beautifully as the heart does. So it's fascinating being able to then intervene when the heart hasn't quite formed properly and looking at the ways you can try and correct things back as close to normal.
It's quite a big volume-loaded heart, isn't it? I think it'll be nice to get on bypass.
To work on the vessels around the heart, the team must take the pressure off the heart itself by placing Madison on bypass using a heart-lung machine.
We'll go on to the heart-lung machine now. Clamped there.
The machine will pump Madison's blood around her body and provide it with oxygen.
Yeah, just open it. There we go. Okay. So that canula's in the aorta. You okay, Vasco, yeah?
Yeah, all normal now, David.
With Madison on bypass, anaesthetist Vasco can monitor and manage her circulation right through this long and complex operation.
I see myself as a well-being guardian during surgery. David Barron is one of the few surgeons in the world that does this kind of surgery. You need to really be at the top of your game to be able to provide him with the best possible surgical conditions.
So let's just pull up on all of these.
With Madison stabilised, David begins to look for the MAPCA vessels that he marked earlier. The black silk thread he attached to each one makes them easier to spot. Carefully working around the heart, he disconnects each vessel where it meets the aorta.
Okay, scissors, please.
Once they've been detached from the aorta, David can pull the MAPCAs down towards Madison's pulmonary artery. He'll cut along the length of that artery and open it out before stitching the MAPCAs onto it so that all the vessels leading to her lungs are brought together.
Here's the napkin. I could just join it in as a double join, I suppose.
The surgery we do in this sort of condition is one of the more kind of extreme things that can be done within children's cardiac surgery.
This will be the most awkward bit of sewing I've got to do, I hope.
You're working down a rather narrow space and you've got limited movement.
Where has it gone? Lost it.
And on top of that, you may have blood and fluids constantly getting in your field. We used to get taught as junior surgeons to pass a needle through a set jelly in the bottom of a flower pot, and to try and do that without the needle tearing through the jelly. And that's quite a good way of imagining how to do things. Your anxiety is what's going to happen if it all falls apart.
In the transplant theatre, the team are getting ready to give 2-year-old Isaac a new kidney, which has just been removed from his dad, Lee.
Having them both in surgery on the same day, it's awful. I can't be in two places at once. I want to try and be there for them both, but it's very stressful.
Okay, knife please. You haven't attached anything yet. Okay, so have we got an easy clean tip as well? Yeah. So we'll need it in a moment. Yeah.
With Lee's kidney sitting on ice, surgeons Liam McCarthy and Khalid Sharif prepare Isaac for the new organ.
A lot of fat. A lot more fat you'd expect for someone with chronic renal failure. There we go. Yeah. See where we are.
To get to where they want to position the donor kidney, the team have to carefully pull aside Isaac's bowel.
So, can we have the retractors, please? You want to put it on your side or this side? That side's pretty easiest.
There is stuff which is there and you just have to lift it out of the way.
Okay.
But it's like everything in a small child. They don't have a huge physiological reserve, so you've got to do it without making a huge amount of hemorrhage happen.
You need to have a right angle ready.
Because it will be positioned lower down in Isaac's body, the donor organ can't be connected to his blood supply in the same place as his own kidneys. Instead, it'll be plumbed into his body's major artery and vein in an entirely new position.
Shall we divide this ligate?
The next step is to locate the artery and vein and expose these vessels enough to make a good connection.
I guess that is one of the vessels we are interested in.
The risks are all to do with finding the right vessels, not damaging things you don't want to damage.
There's nothing attached to it, no? It's gonadal vessels.
If we've had long-term dialysis, actually the vessels can be quite affected and they can be quite stuck.
Just mobilise this bit here so we've got a bit more space. Get rid of this. Then it'll be a nuisance otherwise.
And if they're stuck, it can be difficult to mobilise them and things can bleed.
Swab, please. Big swab, yeah. Right. We'll need the kidney in a minute to see where it fits, okay?
With the vessels prepared, the team need to work out how the new kidney is going to fit into Isaac's body.
Okay, so we've got the kidney. Let's have a look at it. Wheel it over here. In somebody of Isaac's age group, that's the size which not many people do the transplant in UK or in the world basically. So we have a space.
If your kidney doesn't fit, that's clearly a big risk.
It's going to be tight fit. Yeah. Okay, Liam, put it in. Okay. Non-tooth forceps. The vein's going to go down there. The artery's going to go there. Forceps, please.
A 2-year-old's kidneys are about 6 centimetres long, but the donor kidney is twice that length and 8 times the volume.
Yeah. It needs to go in here.
Before they attempt to connect it, they need to be satisfied that it will fit and that all the vessels will join up.
So you have to have a rotation of at least 10 degrees when you're putting it in. So put it there. So I think we just put the vessels basically side by side pretty much. Yeah.
It's a very simple thing. It's how are we going to arrange this organ so that the two pipes I need to join together are going to be able to reach the point where we're going to attach them in the child.
That's the renal vein and the renal artery. It is going to sit on top of it, okay? I think that's going to go there very nicely. Yeah, perfect, yeah.
Okay, happy with that one? The kidney itself will gradually degrade as it warms up. So there's a certain amount of time in which to do this.
Put it back. Okay, the clamps.
With the kidney back on ice to preserve it as long as possible, the team must quickly make their final preparations for the transplant.
It's a point where really there's no going back and you just got to get on with it.
Outside the cardiac theatre, Phil and Michelle face a long wait for news about their daughter, 3-year-old Madison. She's now been in surgery for 4 hours.
Obviously, we're going on what they say. They've worked this plan out. He knows what he's doing, and we trust everything will be fine. We just have faith.
Okay, there you go, George. Just need that one, I think.
In theatre, cardiac surgeon David Barron is carefully constructing a new link between Madison's heart and lungs.
Okay, good. So I've got everything. Quick suck inside there. Have I got enough length?
He's detached the MAPCA vessels from her aorta and brought them down to her malformed pulmonary artery. Opening that artery up, he has stitched the MAPCAs on at each side, combining all the vessels that link with her lungs. Before connecting all of this to her heart, a patch must be added to seal the joins. It's made from a special kind of donor tissue called homograft.
Needles there.
Yep. We've tried to use as much of her own tissue as possible, but that's not enough and you need to find something else.
Let's have a look and see. We want to use the best quality bit that we've got.
We want to use something that's soft and flexible, so it will naturally adopt to the curves and the twists and the little angles that we're sewing that material into without it creasing up, and something that won't degenerate over time.
Okay, we're going to go down. So just grab the other end of it. I'm not sure where that put it. Is that it? No? I think it's over here. Yeah, that looks about right.
A homograft is a tissue graft donated by another person and tucked away just 1 floor below the operating theatres. Birmingham Children's Hospital has its own dedicated tissue bank. This is where the patches are prepared, using tissue carefully salvaged from donor hearts. Each year, the technicians receive as many as 90 hearts, from which they can produce up to 200 patches. When they arrive, the hearts are dissected in a cold storage room under the same sterile conditions as an operating theatre.
All our donors come from within the Midlands region. From the time of death, we've got approximately 48 hours. You know, the condition will start degrading over time, so the vast majority of our tissue is processed and in antibiotics within 6 to 8 hours.
The heart is cleaned and the fat is removed before it's dissected to retrieve a usable patch of tissue.
There's not many of us technicians that do this in the country, probably 24 maximum. It's 6 months of training on pig hearts, and then human hearts from then onwards. I'm coming up to 19 years of being here, and I've processed 750 to 800 donors in that time. I'm a bit apprehensive of every heart, because you are aware that you could make mistakes, I could damage the tissue and come out with nothing. It's me and that heart. You've got a donor family that are relying on you to, you know, they've made this amazing donation that you have to do the best you can to to fulfil their wishes.
Once the homograft material has been prepared, it's stored in a concentrated antibiotic solution for 24 hours and then placed into cryopreservation at up to 190 degrees below zero.
The most rewarding part for me is I can go home every day knowing that I've played no small part in saving or at least enhancing a child's life. It's really nice to go home with that feeling.
There's the patch coming through.
The homograft patch is carefully stitched into place to complete the reconstruction of Madison's vessels.
Needle's coming.
For us, it's a very beautiful piece of material to work with and to do our reconstruction with.
So we have finished the patching. I've got a long way to go still.
Yeah.
The homograft patch creates a perfect seal over the vessels. And onto it, David will now stitch a synthetic tube, which will become the link to Madison's heart.
So this is the corrugated tube.
The tube is the final element of the reconstructed blood supply for Madison's lungs. But before it can be connected to her heart, the team has one last issue to overcome. Madison's condition has also left her with a hole inside her heart. Only when it is closed will her body be able to circulate blood normally for the first time in her life.
Okay, so that's everything, yeah?
And in order to work safely on the heart itself, it must now be stopped altogether.
Cross clamp, please.
In her case, that's an extra added risk that we know the heart muscle isn't quite as healthy as we would have expected. And so to put her through a long and complex operation where there's going to be a period where the heart is stopped is an additional risk to her on top.
If you hold that up in the air, George, okay?
An extremely cold chemical solution called cardioplegia is pumped through the heart, which stops it beating and protects the tissue.
Half flow.
Half flow.
Clamp is on, thank you. Run your pleater and come back up.
Back up. Pleasure's running.
The heart stops. Pump sucker, please. The knife, please. 15 blade, yeah.
With the heart no longer beating, David can cut directly into its outer wall.
So let's just have a look, make sure I can see my way around there.
Going in through the new incision, he uses an artificial patch to fix the hole inside Madison's heart.
Okay, that's the big patch closing off the hole. So we've finished it there.
With that done, David can now stitch the synthetic tube to her heart, completing the new link to the lungs.
So we're now just connecting to the heart. I'm just going to come one more stitch and I'm going to stop. Okay.
Madison's heart has now been stopped for an hour. With the reconstruction complete, the team must now restart it and hope that the new vessels function as planned.
So, clamps off.
Lungs off.
Come back up. Yeah, lungs off, thank you. The heart will now hopefully start to wake up. Right, good.
Once her heart is pumping blood unassisted, the team can finally separate Madison from the heart-lung machine.
So you're back on full flow, yeah?
Yeah, rewarming, yeah.
It's an absolutely key moment in the surgery when we come off the heart-lung machine, when you really need the whole team completely focused on what we're doing and to be aware of all the things that might go wrong. Madison's case, it's quite a lot of surgery and a lot of suture lines, so you certainly are anxious and worried that you're going to have a problem with bleeding at the end of these sort of operations.
Some bleeding is expected, but if David's stitching is sound, then it should soon dry up.
He's got a bit of bleeding. Suckers on, please.
If the bleeding carries on more than you anticipate, then it's sort of anxious time.
More swabs, please. Just 1,000 things that can bleed at this stage. So let's look at the echo again, Rob. So that's stopping. That was all weeping before, wasn't it? It stopped.
It's always a great relief when you see the circulation balanced the way you want it.
So we're gradually getting there.
Madison now has a new pulmonary artery, carrying blood from her heart to her lungs. And with the bleeding stopped, David's work is finally done.
Oh, don't tell me you're tired. Come on.
This sort of procedure, which we may be standing at the table for 12 hours, is about the limit of certainly what I would want to do.
Don't be a wuss.
It's physically and mentally exhausting.
The soft tissue patch. I think I'm going to go for a lie down. There you go. Yeah, okay, thanks guys.
Oh. You take the pipes, can't I?
Yeah, you can. Thanks, Rob. I was very happy that we'd managed to really find and recruit all the vessels and probably get the best result I could have hoped for. But the sort of technical achievement of the surgery is only part of the story. You're only really happy when you know that the heart and the circulation and the patient behind it is recovered as well as you'd expect them to.
In the transplant theatre, 2-year-old Isaac's surgery has reached the final phase as the team prepare to connect the donor kidney.
So what we need is the venotomy knife, the ring tip and the straight blue handle. Okay.
Working together, surgeons Liam McCarthy and Khalid Sharif must now stitch the new kidney's vessels into Isaac's blood supply. And they need to work fast.
Okay, kidney please.
Okay, so we've got plenty of cold flush available.
It's probably one of the more pressured things I do because the clock is on. As soon as the kidney's actually on the edge of the patient, there is a finite time in which to get the joint done.
Nice.
Perfect. There we go.
You've got a kidney which is progressively being damaged by not having any blood in it. You want to be less than about 45 minutes, but ideally quicker.
Please have some lubrication to my fingers, please.
Liam asks for his hands to be lubricated to make sure he doesn't snag the stitches at this crucial stage.
You've got 2 tubes and you've got to join them together.
Okay, you want to hold the end of that?
And you've got to do it in such a way that you don't provide a rough inner surface, which might promote clot formation, and which doesn't leak.
Okay, that's good.
The first connection is to the major vein that will drain the kidney of blood.
I think it's going to be okay.
I think I'll put one more just to please me.
Anything to keep you happy, Carlos.
Beautiful.
That's good. Okay, cold on the kidney.
We're clamping the aorta now, Neil.
Should we just lift that?
Then the kidney is stitched to the major artery that will supply blood directly from the heart.
So I'm just going to come in about there. That's it, that's good. I like that.
You've done so nicely. Beautiful, Mr. McCarthy.
Okay, so we're taking cramp off the aorta.
In theory, Isaac's blood should now begin to flow into his new kidney for the first time.
Right, so let's take this off.
Yeah.
Okay, so arterial clamps off. Kidney's lovely and pink. It's filling beautifully. Okay, and venous clamp is off. So nice and pink, that's what we want to see.
You've done the best job you can to put everything together. But you take the clamps off and it turns pink, and it's a huge relief.
Okay, let's just prepare the ureter.
The final stage of the operation is to connect the new kidney to Isaac's bladder so that the urine it produces can be removed from the body.
Okay, hold that, hold it.
Forceps, please.
Nice and firm.
Before making this connection, the team must be happy that the kidney is functioning as it should.
Having seen the kidney turn pink, what you need to know is that actually it's going to be able to produce urine. That's what the ultimate test of a kidney is.
And we've got urine.
It means the kidney's actually working.
Okay, hold that.
With urine flowing, the team can connect the kidney to the bladder.
Looks beautiful.
Then finally, they can replace the bowel and carefully close up Isaac's abdomen.
So I have to say, I'm well impressed by this. Okay. It's actually posed quite nicely, isn't it?
Yeah, it went pretty well. There's profound relief when it's all working.
Hi, I'm with Isaac Willocks.
While he recovers, Isaac will be taken to intensive care for further monitoring.
I knew I wanted to do surgery of some sort, but when I first did paediatric surgery, I felt a fraud because I did not have any children of my own.
Hey, Squishy. You did good.
At the end of that rotation, I got married and my wife and I had our first kid. I then got the chance to do paediatric surgery again and it felt much more natural. Being a parent gave me a lot more insight into what it was like to actually look after another human being. I think it makes me a better surgeon.
That's the koala. Koala. That one's a lemur.
Lemur.
bit like a monkey. A little bit like a monkey.
2 weeks after the transplant, Isaac and his dad Lee are both recovering well from surgery.
I'm feeling okay. Still can't do anything strenuous, but everything's going pretty well. It's nice to have everything sort of getting back to normal. Nice to have Isaac back. Leave it in.
The recovery was really, really quick. So just so glad it's over now, and we can start looking forward to not having to worry so much.
We'll just need to keep an eye on him. Provided he doesn't get unlucky, provided we do our job well, then actually the kidney itself has got a 10 to 15 year average lifespan. Of course, in and amongst that, there will be kidneys that go on much longer.
When Lee's donor kidney eventually stops working, Isaac will need another transplant. His mum Amy is also a match, but it's too soon to know whether her kidney would be the best option.
Come on, doggies. When you look after a child, you're looking after a family. There's a huge amount of emotion and trust that's required. And it is a huge thing for a family to hand their child over to someone to do this. But while the kids get sick quickly, but they also get well quickly. And that's a very nice thing.
Yeah.
No more.
No more.
After a month recuperating in hospital, Madison is finally well enough to be discharged.
You have to have it on before you go outside.
Daddy,
Yeah?
do I need to take that one?
Yes. Your bandage?
Yeah.
Madison has a real will to survive. This is the best shot we can give her.
We've got to go home and get everything ready.
Is giving her something that nature didn't. We've certainly been able to restore her to a normal circulation, to normal oxygen levels.
Is anybody at the desk? Can we pass this cord to the desk? Give it to the girl. Okay. You saying bye? Thank you. See you again.
It's not going to be a complete cure, and she'll still have to face further surgery when she's older, because some of the tubes and conduits that we put in she'll grow out of. But that doesn't take away from the quality and length of life we can give her.
Go away. Another day.
We're pushing at the limits of what can be achieved technically in terms of surgery, and that can be hairy at times. But it's what drives us. And as long as we're not foolish enough to promise everything, then I think the amount of good we do is remarkable.
To collect you for your surgery, is that okay?
Right. In the UK, some 3 million major operations are carried out every year.
Nice big deep breath. We'll look after you, don't worry.
Only the country's top surgeons are skilled enough to to take on the most critical cases.
Cameron, you all right?
Just take a couple of deep breaths.
If you're going to make a hole in someone, you better be sure what you're going to do.
Should we go for it? Right.
They're using pioneering techniques to treat conditions that used to kill.
A few years ago, these operations were felt to be too big or too dangerous.
But pushing the boundaries of modern medicine comes with great risk.
Just keep quiet for a second, please. If I move the blade too much, she's going to wake up unable to breathe.
Life is precious. It can vanish in a heartbeat.
Whoa!
You need to keep your head. Hold this. The heart is empty. We haven't got any volume at the top. If you panic, the patient can bleed to death.
The surgeons bear the ultimate responsibility.
I need it ASAP. I can't wait for this.
I'm not infallible. Failure is absolutely possible. We are a team, but there's one person's name at the top of the bed.
Bloody hell.
This is what really happens behind the closed doors of their operating theatres.
This is a battle, us versus the Grim Reaper. And we're not going to lose.
Life is fragile. Sometimes it hangs by a thread. It can change for anybody in an instant.
The Queen Elizabeth Hospital, Birmingham, treats some of the most complex trauma cases from across the West Midlands.
Hello, I'd like to put out an adult trauma call arriving by land to A&E recess.
With 9,000 emergency patients arriving here every month, each of the hospital's 140 consultant surgeons must regularly be on call. Neurosurgeon Ismail Ugradar sometimes has just minutes' notice before he must operate to save a trauma patient's life.
I'm on call 1 in 8 days. It can be quite unpredictable, so really quite exciting, but at the same time quite harrowing as well, because you can see some really serious traumatic brain injury.
Okay, so we've got a 64-year-old lady who has fallen backwards and sustained a head injury, not moving right side.
Bleeding has now stopped and kind of clotted. She does have full sensation in the limbs and didn't have any C-spine concerns initially. Within 10 minutes on the back of the ambulance, condition deteriorated. She can't lift her right arm, she can't lift her right leg.
30 minutes ago, 64-year-old Susan fell in the street. She has a possible fractured skull, and medics are concerned that she may be suffering a bleed on her brain. Within 11 minutes of her arrival, a call has gone out to neurosurgeon Ish.
There is a bit of adrenaline rush when you get that phone call about something that you think you can salvage just by going in and doing an operation very quickly.
No wound in the groins, no bleeding down there in the cranium.
Sue, open your eyes, please.
So right pupil is size 5.
Patients with head injuries can deteriorate rapidly and are at risk of permanent disability or death.
Head and neck, please.
Head and neck.
Yeah.
Susan is taken for an urgent CT scan to determine the extent of her injury.
It's a significant bleed.
She has a life-threatening bleed on her brain called an extradural hematoma.
Move, ready, set, move.
The area between the inner surface of Susan's skull and the outer protective layer of her brain, the dura, is filling with blood. The space will continue to fill, putting extreme pressure on her brain that could kill her, unless they can open up the skull in time.
Where you've got a clot that's expanding, that has to come out straight away. No two ways about it. The brain cannot take that kind of pressure for a sustained amount of time.
Only an emergency craniotomy, opening up the skull, will save Susan's life.
There's a completely different pace with emergency work. And that's very different to a planned elective practice. Make a decision, get on with it, do something about it. That is trauma neurosurgery, defined.
Susan is taken to be prepared for surgery in Emergency Neurotheatre 21.
Your skull is a fixed box. Your brain's got nowhere to go. It's just getting more and more squished. If left untreated, then she would probably very quickly pass away.
We don't know any history for her, and there's nothing on the system. So.
Have all the equipment you require?
You want the drill somewhere?
While the team get ready for surgery, Susan takes a turn for the worse.
She was all right when she came in, but then her pupils blew. That's why we were rushing. So the pressure in the brain is extremely high.
Her blown pupil indicates the bleed is expanding to a critical point.
Okay, let's have everything. We've only got minutes to get that skull open, that clot out. So every second counts. Somebody tie me up, please.
To release the pressure on Susan's brain, they're going to have to open her skull 3 times faster than they normally would for an elective case. They only have minutes to get through one of the toughest bones in the human body.
A knife, please, starting. I just need a knife and a drill, that's all I need. All the way. Priority is just to get that skull off as quickly as possible. I want to be there within 10 minutes to try and obtain the best outcome for that patient. There's a fracture there, the fracture there. Yeah.
As they peel back the skin, the full force of the impact is becoming more apparent.
You see it's very swollen and it's got a laceration here, so I suspect she's had a direct injury on this side where she fell. Got the drill connected? Yeah, go for it.
To get to the clot, Ish and his registrar Ben Fisher need to remove a 12cm squared section of skull known as a trapdoor.
What you need to do, drill a few holes, use a jigsaw type drill and have the bone off. Thank you. You do release a little bit of pressure with that first hole, but it's not until you take that bone off does the pressure suddenly come off.
Change to cutting.
Having drilled 3 burr holes, Ben uses a specialist saw to cut out the section of skull at the point of impact, gaining access to the clot beneath.
So go around the fracture if you can.
So far, they've been operating for 7 minutes.
If you're not careful with your landmarks, for example, if you cut through a major vein, that can cause torrential bleeding. So you need to be careful where you're going. There you go.
8 minutes since they began, the clot is exposed, and the pressure on Susan's brain is relieved.
Once you've got the bone off, you're happier because suddenly your brain's got room to expand. The skull of that box has been opened properly. And then you see that big clot underneath it. And then that's satisfaction.
Susan is out of immediate danger. But the clot could return unless Ish replaces the trapdoor in her skull carefully, so blood can't build up again beneath.
The skin of the brain at this point now is quite loose and lax. So what you don't want is to put the bone back on, and then the skin of the brain is underneath it, and there's a gap between the two for any small bits of oozing to form, reaccumulate a clot. So So what you do is you make lots of holes. We then stitch the skin of the brain and pull it up through those holes. They're called hitch stitches.
And then just be careful, because if you will strip the meningeal. It's a bit oozy around.
So what you do is you hitch and fix the skin of the brain to the bone all round, and then put the bone back on.
Do you want to reconstruct the bone?
Some mini plates and screws, please. Careful, do it here. Okay, that's the fracture through there, so fell straight backwards.
Your brain is basically you, it defines you. It's got your personality, your memory, your movement, your senses, everything. And we know that an operation perhaps is going to change you in some way. Although you may have removed the actual clot, what you don't know is if there is a damage to the internal structure of the brain.
Right, what's going on here?
It's definitely the right way, isn't it?
Yeah, it's just...
At the back of your mind, you're always thinking, you know, was it quick enough?
One big wash.
There could be a number of bad outcomes for Susan.
The scalp here is quite swollen, so sorry.
For example, she lost too much blood, her brain stopped her heart from beating, or coma.
Head bandage, please.
They're all disastrous situations, to be honest.
As well as receiving trauma patients from across the region, the QE is the UK's base for receiving all military casualties from overseas.
Right, morning everybody. Sorry for the late, slightly late.
Good morning.
The hospital's major trauma service has a unique mix of both military and NHS staff who perform emergency operations and coordinate patients' care from arrival to rehabilitation.
He had no exit wound we could find, but he had a load of blood around his mouth that we could not explain, so we ended up looking for the bullet.
My training was greatly enhanced by being in the military in Iraq and Afghanistan. We saw injuries that you would never wish to see outside a battlefield.
Catherine Powell is a commander in the Royal Navy. With many years' experience operating on major trauma injuries.
I enjoy the specialty of trauma surgery. It can be incredibly dynamic and incredibly fast-moving, and things can happen so quickly, as opposed to an elective theatre. You know, that's a very, very different environment. Didn't have as much adrenaline in that one.
A&E at the QE. And what's your ETA?
A motorcyclist has been involved in a high-speed crash and is being brought in by air from over 50 miles away.
Can you get the theatre team ready, please?
He has been classified as a polytrauma patient, meaning he has at least 2 severe injuries. Specialist surgical intervention could be essential. The trauma team will need to work out which injuries most urgently require surgery and which can be more safely operated on later once he is stable.
Stephen, you just arrived in the hospital, okay? This is Stephen, 56-year-old male, motorcyclist. We presume he's come around the bend, has hit the curb and gone flying.
Okay.
On crew arrival, complaining a lot of pain. His right arm abducted and the left arm looking deformed. Abrasions cause his abdomen, but not complaining of any pain. So at the moment, we have got really effectively 2 upper limb injuries that I expect to come out, and his arm's gone backwards like that. Okay. Just can't keep the arm down.
Stephen has a dislocated shoulder on one side and may have broken his other arm.
Can you do this with your right hand?
Although these injuries are causing him intense pain, the team are anxious they could be what's known as distracting injuries, masking a more dangerous trauma.
Right. Look, with the arm, I know that's obviously what's causing the most pain at the moment. We just need to make sure you haven't got any more serious injuries.
Because Stephen has come off his motorbike at speed, it's possible he has life-threatening injuries to his internal organs.
Any pain in your tummy? Is your tummy sore, Steve? There's some abrasions over his abdomen. Can you feel me touching you here? No. No? Where am I touching you now?
I don't know.
You don't know, you can't feel anything?
Can't feel me right side.
Okay. Right upper limb is cool to touch. Okay. I'm going to take you for a scan to check that you've got no major injuries, okay?
Time is an essence. Scan is ready for the patient.
To try and work out which of Stephen's injuries are distracting and which need the most urgent treatment, the team take him for a CT scan. It confirms that Stephen has a badly dislocated right shoulder, which is restricting circulation in his right arm. He also has multiple fractures to his left arm, and he has a further injury, one he can't feel to complain about, a potentially life-threatening internal bleed near his liver.
It looks like it's going to be a bit tricky. I'm a bit concerned.
Stephen's fractured left arm is a serious but distracting injury. Surgery on this can wait.
Right, on move, ready, steady, move.
More concerning is the dislocated right shoulder that's cutting off blood supply. If not treated soon, Stephen could lose his arm.
He's got quite a significant bleed, so we have to start thinking about limb-threatening versus life-threatening.
Absolutely.
But the internal bleed could be the most dangerous or even fatal injury. Deciding what to treat first is a dilemma for the trauma team.
Hi. Just a bit of an update. So this guy's got a liver laceration that they think is going to require angiography.
An urgent request goes out to the on-call surgeons.
And actually he's got quite a significant bleed in his abdomen, so both need tackling in quite a short time. I don't think this is going to be straightforward. And I also don't think we're not going to have a lot of shots at it. The general surgeons are on the way down.
He's come off his motorbike at high speed, he's got a dislocation of his arm with no pulse, but he's not stable. Okay, I'm on my way. Your senses are awake. That's the drive of adrenaline.
Okay, what's happening?
Anaesthetists and surgeons specialising in liver, orthopaedic, vascular and abdominal procedures assemble in recess to discuss how best to approach Stephen's multiple injuries.
To sum up, he has got shoulder injury, vascular injury, liver laceration, so we need to make a decision about whether that requires any further intervention.
I'm personally not convinced it's an active bleed.
Blood pressure is dropping from 120 to 80.
But as Stephen's blood pressure is starting to drop, the decision about whether to take him to theatre becomes more critical.
What I think we should do is get him upstairs, put him asleep upstairs, get his shoulder back in, and then we can reassess from there. But let's get him upstairs, I think.
As soon as things change, then I just don't want the patient in the emergency department. I want them in a space where I'm very comfortable.
Shall we take him to theatre and make all the decisions in theatre?
Well, I think we should just go once they're ready. Hi, it's Catherine. Can you tell there's a patient on its way, okay? Everything needs to happen up there, not down here.
Catherine and the team take Stephen to one of the QE's dedicated emergency operating theatres, 17.
Do anything else about him now?
No, I'll try and figure out a bit more from the crew, but there we go. So far, no more stories. Thank you. Cheers. I'll go down to the radiology to find out a bit more.
Okay.
Thanks.
Can we just listen up for 2 minutes, just so we know what's happening? He's got a flush at the back of his liver, but I'm not convinced, okay? So he may end up having a laparotomy, but that's the may at the moment. This is the priority.
By the time Stephen is in theatre, his blood pressure has stabilised again, a sign that for now, his internal bleeding is under control. This makes saving his arm by correcting his dislocated shoulder the top priority.
So the plan is to bring him in, put him asleep, and put this back in place.
A team of 20 surgical staff are ready to treat Stephen's injuries.
Keep moving, keep walking, or don't stop. Right, there's too many people around here, man. Keep walking. Sorry, sir.
We're going to get you asleep and get your arm sorted. All right.
We've got to get that shoulder back into place to see whether or not the blood flow is going to return or not. The longer you leave that, then that becomes limb threatening.
How long is now? 4 hours. So normally how much time we have?
6 hours.
It's down to consultant surgeon Socrates Kalagriantis, who specialises in shoulders, to save Stephen's arm.
So he needs to have good muscle relaxation, yeah? Loads of, otherwise this won't go back in.
I'll give him a full dose of relaxation for an hour, so he should be well. Okay guys, we're gonna intubate now, so we can have some quiet, please.
Until they can manipulate his arm back into position, the circulation cannot return.
Pull, 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 pull.
Socrates uses the traction-counter-traction manoeuvre to pull the shoulder back into the joint.
X-ray. Okay, let's have a look. Give me another view. And again. He has a small fracture there, okay? But it's in, that's fine, thanks very much.
Are we in?
Yeah, it's in and looks much better.
A Doppler machine confirms that his circulation has returned.
You happy?
We're happy with the blood supply, yeah.
The limb-threatening dislocation is resolved, but Stephen's case remains complex and uncertain.
Still have a feel of his belly. He's definitely getting bigger abdomen. No, you're right, he's a lot more tense.
An unusually firm abdomen could indicate that Stephen's internal bleeding has restarted. The only way to stop it will be to open him up and find the source.
You have bleeding from an arm, well, I can put a tourniquet around that, I can put a bandage around that arm to stop that bleeding. If you've got bleeding from a liver, well, we need to do something to stop that.
He's just sagging again, okay.
If you've got catastrophic bleeding, that will kill you, and hemorrhage and trauma is the biggest killer.
Is there anything else that needs to be said amongst that?
He's type 1 diabetic. He's got end-stage renal failure.
As Catherine and the team continue to assess Stephen's condition, they receive alarming news from his family of a complicated medical history.
He's had 2 failed kidney transplants and a failed pancreas transplant.
He's on warfarin for a previous blood clot in the neck.
Right. Oh, dear.
Stephen's previous failed transplants and the fact that he takes the blood-thinning medication warfarin mean that opening him up will bring significantly higher risks than operating on a healthier patient.
I'll speak to radiology.
Warfarin thins your blood, so it takes longer to clot than somebody who's not on that drug. So when you're injured, it becomes a real problem because you will bleed twice as much as everybody else will, or more.
Because he's had so much surgery, he's not a straightforward, oh, let's just have a little peep inside his tummy type candidate. He could be very challenging.
Doing a big operation on somebody that's had major abdominal surgery before, I'm not wanting to rush into this.
I think I'd rather rescan him rather than rushing in unless we've no choice. That's my instinct to say that.
The big decision in surgery is actually when not to operate. I don't want to put somebody through an operation they don't have to. But the worst thing is I don't want to not do an operation at the right time. There is always some degree of self-doubt.
Just 2 hours after 64-year-old Susan fell near her home, neurosurgeon Ismail Ugradar and his team are completing her emergency craniotomy in Theatre 21.
You've got something to wash your hair with.
With trauma, as soon as that drape goes on, all you can see is a small part of that human being. But then once you've controlled that, taken the clot out, taken control of the situation, then you start thinking, hang on, there's a human underlying this. Are they going to wake up? If they are, how are they going to wake up? So that does kick in afterwards, and you suddenly go back into that mode of, hang on, that's a patient, that's somebody's loved one.
Ish and the team won't be able to assess Susan's condition until they wake her.
Susan, open your eyes for us.
The worry is, has the clot reaccumulated, or has there been other injuries that we've missed that is causing this reduced conscious level? That's the worry immediately.
Susan, open your eyes for us. Susan. Susan, open your eyes for us.
Despite their efforts, Susan remains unresponsive.
Yeah, I'm just wondering, is it worth travelling to CT? Her pressure's extremely low, so we just want to make sure. Let's do a scan, that's right. Spence, let's go.
You see a lot of serious head injury patients that never come around or may lose important function, memory, cognitive function, speech, movements, etc. And that's where the real damage occurs.
The scan confirms the procedure has been a technical success. But Susan's recovery is far from certain.
Post-op scan can be quite useful to tell you things are going in the right direction. But there's no real indication what's going to happen in the future.
Ish may have saved Susan's life, but he'll have to wait to see whether her brain can still function fully.
Unfortunately, she had a very severe traumatic brain injury. Occasionally we may do an operation thinking, I'm not sure how effective it's going to be, but we'll give it a go, see what happens, see how they wake up. And yes, if they do well, then you've made the right decision, but if they don't, then you have to kind of live with that consequence.
It may be weeks or even months until Susan's outcome becomes clear. General Surgeon Catherine Powell is monitoring polytrauma patient Stephen in Theatre 17. She's concerned that he is still bleeding internally.
Oh, please tell me that's not his pressure.
A drop in blood pressure suggests it could be getting worse.
He's changing. He's not maintaining his blood pressure. And I have seen blood pressures change, as any trauma surgeon will have. They can change very quickly.
Given Stephen's complex medical history, Catherine needs to be sure she's making the right decision before committing to surgery.
Can I get in here for a minute?
She decides to order an echo ultrasound scan to check his heart and abdomen.
I want to see what this is doing before I'm operating.
Okay, so finding the heart. So, where's Catherine? Is Catherine able to see this? Catherine, can I just show you this?
Yeah, sure.
So what I'm seeing, this is an enormous amount of hemorrhage within the abdomen. Here. I'm just seeing this pool of blood, all of this black stuff there. That is a large clot surrounded by blood within the abdomen.
Yeah. I think we just go.
I'm now taking the decision to operate, because then I'm back in control again. If there is something ongoing bleeding, I can deal with that, rather than delaying and let him bleed more and more.
I think, guys, we're going to be heading to laparotomy.
Performing a laparotomy means opening up the entire abdomen, from diaphragm to pelvis. It's a major operation, bringing risks of infection if the digestive organs are accidentally perforated.
Hi, John. I'm actually just about to open him, I think. He's just gone really saggy on me, and so I'm just going to operate him.
Stephen's blood-thinning medication increases the risk of significant bleeding. So Catherine needs to give herself the best possible chance of stemming blood loss.
Should we just get some blood into him? Can we ring blood bank? I want FFP is what I need, as well as blood, okay? I can't wait for this.
Sorry, I told her 18, didn't I?
Fresh frozen plasma, or FFP, is a blood replacement product with high clotting factors that can help to control major hemorrhage. By transfusing FFP directly into his bloodstream, Catherine hopes it will counteract the effects of the blood thinners he's been taking and limit the amount he bleeds when she operates.
Can I have a suction tubing, please? Thank you.
Well, I've had 2 bags of crisps for lunch, so I'm good to go.
As it's a complicated case, senior consultant surgeon John Whiting has agreed to operate with Catherine.
2 failed liver kidney transplants.
The type 1 diabetic.
Yep. And you've had a pancreas transplant.
Knife, please.
Big hole.
Oh, somebody's been here before. Because of his surgery previously, everything is very stuck.
When you go into somebody who's had previous surgery, especially if they've had multiple previous surgeries, it's always a little bit nerve-wracking because you don't know what you're going to find.
I haven't met much blood yet. I'll tell you one thing, it's completely stuck here.
It's a bit like a book. If you want to open the pages on a book, if the book's new, it's dead easy. Now imagine throwing that book into a bath and then drying it up. And so going into somebody who's had previous surgeries is like trying to separate all the pages.
Let's just see where I can get into here.
Sometimes things will be so stuck that actually you can't but rip pages.
Well, he's got blood in here, we're not making it up. Pass, please.
With the abdomen open, she fills the cavity with several large abdominal packs to temporarily control any bleeding.
You put the packs in, we call it damage control. A large dishcloth, sterile. They take up space, they absorb stuff, but it helps me give compression to stop hemorrhage and control contamination. Those are your 2 key things you're trying to do.
If you have a basin ready, because then whatever clot we can get out, we can just put it straight into the basin.
The clots of blood confirm her suspicions of internal bleeding, but now she needs to locate the source.
Where is that coming from? Where is, because it's coming off a spleen or because
Not an easy task in the body's largest cavity.
Opening somebody's tummy in trauma, you almost have a recipe in your head. You go through and you check everything from literally A to Z and make sure that there's nothing I've missed. And I do that like a clock face, and I do it the same way every time. So no matter how bad it is or how awful it is, I will methodically go through every organ, every junction, every zone.
Let's just run this from the top.
I start with the big organs, which are the spleen and the liver. So the big, what we call solid organs. And I'm starting to make mental notes. That's fine, that was clear, that's not clear. Okay, we've got this problem here.
8 digestive organs, including the small intestine, which alone can measure up to 20 feet in length, are housed within the abdomen.
This is going completely underneath here. I have to free this off.
Catherine has to track through every inch of it if she's going to find the bleed.
It's all your senses. You're listening, because sometimes you can literally hear bleeding. That's very sharpening. And you're looking. So, for example, the spleen. You run your hand over the top of the spleen. What you want is a lovely, smooth feeling.
Scissors? Yeah.
And the gut then is like a big long hose pipe, and you follow that big long hose pipe in all aspects. So you check all of those areas. So it gives you that sensation of, yep, everything feels fine.
We're not in a hematoma that's so big in there here. I mean, he's got a tear there, and he's got a hematoma here.
So there's the hematoma, and you can see the tear.
Having searched his entire abdomen, Catherine finally finds the source of the bleed. A cut to Stephen's mesentery, the membrane that secures the intestine to the abdominal wall.
I mean, he's got that mesenteric hematoma, and he had some blood. Not as much in here that I would be thinking his blood pressure was in his boots because of what was in his belly.
Another mock, medium mock.
But the injury doesn't explain why Stephen's blood pressure had fallen so low.
Okay, so his left liver is completely intact.
You're always questioning, am I doing the right thing? Have I made the right decision here? And I think the more time you have to think about decisions, the more that makes your doubt come in.
So, what have you found? Not a lot.
Not a lot. That's hematoma in the mesentery.
Oh, yes.
But that's A, not hosing, and B, not killing him.
In some ways, we didn't have to do any actual interventions. But do I believe that I made the right decision to operate? Yes, I did.
Okay, let's have the closure suture, please. Thank you.
All right.
Satisfied there are no other internal injuries, they begin to close.
If I'd let him go any longer and he got sicker and something dreadful happened, you would look back and go, why didn't you operate at that point? What had happened was that he had had a big bleed initially when the injury first happened. And then his body just didn't have enough gumption, for a word, or enough strength to cope with that blood loss. So when I went in, my concern was he was still bleeding.
Yeah, that's fine.
Once we got all the medication in to stop the warfarin thinning his blood, actually that bleeding had stopped.
Okay, we're done. Thank you very much.
He's not the 20-year-old who's fit and healthy with no past medical history. You could almost say, should you really be riding a motorbike at, relatively high speeds? I'm sure it's great fun and the thrill of it and the sense of freedom and speed. But sadly, unfortunately, I just see the wrong side of the outcome.
The fractures in Stephen's left arm will still require surgery once he's well enough, but for now, he'll be taken to intensive care and stabilised.
I'm very happy I found what I did because it meant that I knew he was going to recover.
Tidy up. We're not stopping for a break or anything silly like that.
Between each life-saving trauma operation, the theatres must be cleaned and prepared, ready for the next case. Everything used while Stephen was in theatre must now be removed for cleaning. Each emergency theatre at the QE has trays of specialist instruments on standby for life-saving procedures. It's vital that there's a fast turnaround system to keep them sterilised, ensuring they're always available for trauma cases. On the outskirts of Birmingham, Europe's second largest decontamination facility is responsible for collecting and cleaning used trays 24 hours a day, 7 days a week. When the trays arrive, they are checked in by hand and then fast-tracked through a 4-stage process.
We probably process in the region of 350, 400 trays per shift.
Everybody is aware that at the end of every single tray that we have, it's a patient.
Once checked in, the blooded instruments are cleaned and disinfected before being inspected, packed and sterilised. First, they are put through a multi-stage wash process, which includes thermal disinfection at a temperature of 90 degrees centigrade. Then they are released into a medical clean room, where the staff inspect every aspect of the instruments by hand.
They're tiny little clamps to use to stop a bleed in the patient at Queen Elizabeth. So I'm just checking to make sure there's no blood inside.
Around 1,500 trays go through this process every day.
And those trays can range from a few instruments to an instrument tray like this, which has 160 instruments on this one particular tray.
And every instrument is accounted for at every stage.
They obviously rely on us. Even if it's a small tray, I would like to get it right. It is very important.
After being cleaned, the instruments are packed and wrapped. To ensure they are sterile, the trays are then subjected to the final stage of the process, a 1-hour steam sterilisation at a minimum temperature of 134 degrees. The turnaround time for returning decontaminated trays to the QE is usually 24 hours. But in emergency situations, they can be dealt with in as little as 5.
I always think that it could be one of my family members. It will save someone's life.
At the QE's emergency department, the trauma team on shift today have already treated patients from a car crash and a shooting.
Hello, QE.
The third trauma call of the day is on its way.
We have a trauma alert, another one, yeah?
A motorcyclist has collided with a car. British emergency departments treat around 18,000 motorcycle casualties a year, almost a third of them aged 17 to 24. This time the driver is just 18.
Where do you want to go?
We'll have 6.
Okay.
One of the first to respond in resus is trauma specialist JJ Lee, who will oversee this case from the start.
When I hear that I have an 18-year-old male, I'm not surprised. Our younger population, particularly men, are more active and probably more likely to take risks.
Ready, steady, steady. So this is Jamie. He's 18 years old, was a rider of a moped. There's been a car turning right across him and essentially T-boned him and then thrown him about 15 to 20 foot off his moped.
The patient, Jamie, appears to have serious injuries affecting his right leg, from his foot up to his pelvis.
I know as a young person he has a lot of reserve so that he is strong and probably the fittest he's going to be in his life. CT's ready when you are. But he's able to mask signs of significant chest deterioration, any abdominal injuries, solid organ injuries. And so I want to get this patient to the CT scanner now.
The scan confirms that while Jamie has no hidden injuries, he has broken the 2 longest bones in the human body.
So it looks like we've got right proximal femur fracture and right tibial fracture. Okay, that's the hot report.
Jamie's broken the large bone in his thigh, the femur, and the tibia in his shin.
Jamie, my name's JJ Lee. I'm one of the trauma surgeons. How are you feeling? Are you in pain?
Just that leg.
Just the leg. What Sid needs to do is just to put a little probe onto your foot just to see if we can check the blood supply of that foot, just to make sure it's okay.
Hang on,
All right.
does it softly? I don't care.
I'll ask him nicely. You've got to be nice and do it
Yeah.
softly.
Try to be as gentle
That's
as
what
I
Jamie
could,
says, okay? You've got family members here. Do you want to see them?
Yeah.
You better see Mum first, I think. Yeah? All right. I'm going to go and get his mum. So Jamie has significant lower limb injuries, but actually those bones are so broken that they're going to need surgery. But the surgery itself can be quite traumatic, almost the same as being injured again. And it's that shock and expectation of what we're going to need to do that I need to manage, not only for him, but also for his family as well. We will stabilise his limb and then for theatre tomorrow. Yeah.
Jamie recently started work as a pub barman, his first full-time job after leaving school.
He rang me at 7 o'clock and all he kept saying is, Mum, help me, Mum, help me. Mum, come and help me. This could set him back 12, 18 months. Just like to keep me on my toes, don't they? I'll see you in a bit, love ya. Normally I'm quite strong, I'm not normally weak. He loves his job, he absolutely adores his job, and not being even just to be able to go there will be heartbreaking for him.
Jamie's operation is expected to take up to 4 hours in Orthopaedic Theatre No. 1, dedicated to surgery on the muscles and bones.
Ready, steady, slide. There we go. It's probably a rugby player.
Well, let's hope he supports a good team.
Consultant orthopaedic and trauma surgeon Ravichandran Karthikeyan known as Karthik, will carry out the procedure on Jamie's badly broken leg.
Fixing broken bones is something that we do day in and day out. We roughly treat between 2,000 and 3,000 people a year.
There's an operation straight down where we want to go, isn't it? That's typical tuberosity.
Of course, there are complications from these operations. Wounds can get infected, the metal itself can get infected. Worst case scenario could even be a risk to life.
Okay, just mind yourself, guys. X-rays coming in. Okay, that looks good.
Jamie has fractures in both his femur and his tibia. Karthik will make an incision in the front of Jamie's knee. He'll need to realign the broken bones before inserting 2 titanium rods into the upper leg and then into the shin. The rods will be secured by 8 locking screws.
Other plan is I've discussed with Alex as well earlier on. If there is any problem during the femur or after the femur, we'll cut short and then put an X-fix and get out. Is that all right?
The team will operate first on Jamie's femur. If he remains stable, they will continue with the second procedure on his tibia.
Okay, have skin knife, please, thanks.
Karthik makes an entry incision in the knee.
You're entering through a pristine knee joint. So you want this knee joint to be pristine for the rest of his life. You have to make sure that you don't cause any more splintering of the bone.
So can I have the entry guide wire, please?
First, he'll need to drive a guide wire up through the bone and into the marrow-filled canal in Jamie's femur.
Oh, this midline. That's pretty much where we want to be.
As well as creating a pathway for the titanium rod, Karthik will use the wire to help realign the fractured femur, as he needs to manipulate the broken sections of bone back into position.
Okay, can I have the driver, please, now?
In Jamie's case, he's got a very tough bone. And actually treating someone who is younger makes it a little bit more difficult because the bones are much harder.
And again, Tim. Can the screen come a bit closer, please?
Hang on, sir.
Karthik continually checks X-rays to monitor the progress of the wire inside the displaced femur.
Yeah, that's much better.
Yeah.
And again? Good, Dan.
It's got solid bone.
When you're drilling into an elderly patient's bone, it's pretty much like cheese compared to drilling into granite on a young person's bone. You can get tired pretty quickly.
That's your workout for the week.
Yep. I don't think you need to go to the gym after this, but
just lift the tibia a little bit up so I can get in a little bit more angle. And I've got it.
With the guide wire deep inside the femur, now Karthik needs to work against Jamie's leg muscles to maneuver the broken bone back into alignment or reduce the fracture.
Can I have the reducer, please, instrument?
Jamie, he's a young, fit individual, and his muscles are going to be strong compared to someone who's much older, and you can actually overcome these forces a bit more easily.
Tim, show us that, please. Can I have a mallet wrapped up in a swab?
With the bones still out of line, now Karthik tries applying force to the outside of the leg.
And then show me that, please, thanks. And again. So I need to be up. And again. It's completely defunctioned, so. And that gives you a bit of extra traction. And again, please.
I have to constantly keep thinking in my mind, am I going to take a longer period of time? Is he going to tolerate that longer period of time?
If Karthik can't maneuver the broken sections of bone into alignment, he will have to apply more direct force to the fracture by making an incision deep in Jamie's thigh.
When you're thinking about having to use a second incision, it's causing more trauma, which can then lead to a delay in healing, or even might lead to not healing completely.
Okay, so I know it's not aligned in the AP plane. And again. So that kind of decision has to be made pretty quickly because you don't want to spend too much time on the operating table. It's not playing ball. Okay, relax, let go. All right, we'll better open it up and then nail it. About there. Skinny knife, thanks.
Karthik's best option now is to cut into Jamie's thigh, as close to the fracture site as possible.
So feel that, so you can get the fracture, you can feel it.
Oh, yeah.
The femur is one of the biggest bones in the body, so if you want to control it, you need instruments that are big enough to control it as well. Okay, hair grooves again, please, thanks.
With forceps, he grasps Jamie's femur to try and pull the broken sections into position.
And again. Okay, and again. You have to use force, physical force, to actually reduce the fracture fragments together. And there's no easy way around this. And again, please. It's not just brute force and ignorance, it's actually a technique involved. You have to make sure that none of the other soft tissue structures are caught in it. My worry would be damage to nerves and blood vessels, leading to a loss of limb in a worst case scenario. And again, Tim. Okay, that's nearly there. And again. That's passing through. Okay, so that's the tricky bit done. It's a bit of hard work.
With the bones finally in position, the team can now push the guide wire into the upper section of the femur.
Show me that, please, Tim.
And insert the titanium rod over the wire so it slots neatly into place.
Tim shows up. Ultimately, the bone will heal around this rod. The bone will then take over the function and the rod will be then defunct.
With the rod in place, the guide wire can be removed and screws lock the rod in position.
Right, next step down.
Jamie's thigh bone has been repaired. He's been in surgery for 2 hours.
Now start thinking about whether he can tolerate another couple of hours on the operating table to fix his tibia. I discussed with the anaesthetist to find out whether this is going to be feasible. How's it feeling, Alex?
Doing great.
Okay, so should we proceed?
Yes.
Okay.
This time, Karthik is able to drill down into the bone and feed the guide wire through the fractured tibia without additional incisions.
Suction, please. But we should be able to stop there because I don't want any more deeper there.
The screws secure the rod in place.
It's definitely there, isn't it? Yeah. Okay.
After 4 hours of surgery, the fractures are now both permanently stabilized.
That's nearly done. All done. Happy. He's just over the first hurdle at this stage. It's all done. Then he's going through the next phase of rehabilitation, which is to mobilize him. I would definitely look forward to him walking independently and mobilizing. Perhaps not on the motorbike.
Jamie will remain in hospital to recover and start the rehabilitation his leg needs. It's been 2 days since Stephen came off his motorbike and he's back in theatre. He's about to undergo extensive surgery on his left arm.
Okay, ready to start?
Yes, please. That's good. Thank you.
The force of the accident shattered the long bone in Stephen's upper arm, the humerus, in 3 places.
So that and that should be together. And try to bring them together and fix them together with a couple of screws.
The bones are pulled together and secured using a 27-centimetre metal plate and 13 screws.
There's a cat with 9 lives. He's used up a few of them. Life throws many things at us and rolls many die. Stephen is very lucky. He has had a serious injury which will affect both of his arms. So to recover from that, is not insignificant.
Okay, I'm quite happy with that. Thanks, guys.
Ready, steady, slide.
For 2 weeks, Stephen recovers in hospital.
Critical care area, was I in there?
Yeah, he was in there.
Today, he's finally on his way home.
I've come off at over 100 mile an hour and I've just done nothing. And yet this was 40, 50 mile an hour and nearly died through it. I don't bounce as well as I used to. Physically, I'm nearly there. Mentally, it's still affecting me. More wary of things that can happen. Surgeons saved my life. They just say it's a job, but they save lives all day long, don't they? I've been lucky, very lucky. It's incredible.
25 days on from his accident, Jamie is well enough for his mum to take him home.
Put an engine on this eventually.
Jamie's always been a happy-go-lucky boy, and I just want him to go on being active, being happy.
Six weeks after falling in the street, Susan is back at the QE.
If they hadn't have operated, I would have been a goner.
Although physically she has made a good recovery, the injury to her brain has affected her memory.
How are you? I'm very well. It's the best day since I come out of hospital.
When you were admitted, what was your first proper memory of in hospital? Not what other people have told you.
Because the surgeons came up to see me and they just came to have a look at me, see if I was okay, and just reassured me. Really, really nice guys.
How long after the accident do you think that was?
I don't know, probably the next day.
No, I think it was actually a few weeks later.
Really? Honestly? Could have sworn it was the day after.
Well, at least you did remember being here, so that's good.
She doesn't remember me at all, as I would expect. So the last time I saw her, she had no idea who I was, no idea what I'd done. That's to be expected.
That's healed really well.
Sometimes you'll see patients who have been very, very dependent for weeks, months on the ward, and then you see them in clinic maybe 6 months, a year down the line, and they're completely transformed. That makes it worthwhile.
While Susan's memory has been affected, there is now every chance that she will make a full recovery.
Thank you. Lovely to see you.
You take care.
I will do. And you.
You soon.
But she was lucky. She was found quickly, transported here quickly, scanned very, very quickly, and straight into theatre. Could have been a very different outcome. But there's an old boss of mine who used to say, it's better to be lucky than good. So yeah, I do believe in luck.